हंसते तू बस थामे इसका हाथ चल।
चलेगी फिर हवाएं, बदलेगा मौसम, रास्ते लंबे हैं रुकेंगे ना कदम। मुश्किलें आती है जाती भी है, इनसे झुकेंगे ना हम। उम्मीद के साथ आगे बढ़े, जीने के लिए ही है हम। जब तक जिए हम, जिंदा रहे हम, धूप हो छाँव हो चलते रहे हम। जब तक जिए हम, जिंदा रहे हम, धूप हो छाँव हो चलते रहे हम।
जिंदगी की राहों में फूल हो या हो कांटे, कदम कभी रुके नहीं, चलते रहे बढ़ते जाए हम।
छोटी सी मुस्काने गाने दो चेहरे पे इस दिन को, खुल के तू जी लेना ओ यारा। कल की तो बातें हाँ कल की है, इस दिन को खुल के तू जी लेना ओ यारा मेरे यारा। छोटी सी मुस्काने गाने दो चेहरे पे इस दिन को, खुल के तू जी लेना ओ यारा। कल की तो बातें हाँ कल की है, इस दिन को खुल के तू जी लेना ओ यारा मेरे यारा। जब तक जिए हम, जिंदा रहे हम, धूप हो छाँव हो चलते रहे हम। जब तक जिए हम, जिंदा रहे हम, धूप हो छाँव हो चलते रहे हम।
जिंदगी की राहों में फूल हो या हो कांटे, कदम कभी रुके नहीं, चलते रहे बढ़ते जाए हम।
छोटी सी मुस्काने गाने दो चेहरे पे इस दिन को, खुल के तू जी लेना ओ यारा। कल की तो बातें हाँ कल की है, इस दिन को खुल के तू जी लेना ओ यारा मेरे यारा। जिंदगी क्या है कोई सपना या एक जुनू, जब छाए गम के बादल।
ओ जिंदगी वो है जो है हर पल में, हंसते तू बस थामे इसका हाथ चल।
चलेगी फिर हवाएं, बदलेगा मौसम, रास्ते लंबे हैं रुकेंगे ना कदम। मुश्किलें आती है जाती भी है, इनसे झुकेंगे ना हम। उम्मीद के साथ आगे बढ़े, जीने के लिए ही है हम। जब तक जिए हम, जिंदा रहे हम, धूप हो छाँव हो चलते रहे हम। जब तक जिए हम, जिंदा रहे हम, धूप हो छाँव हो चलते रहे हम।
जिंदगी की राहों में फूल हो या हो कांटे, कदम कभी रुके नहीं, चलते रहे बढ़ते जाए हम।
छोटी सी मुस्काने गाने दो चेहरे पे इस दिन को, खुल के तू जी लेना ओ यारा। कल की तो बातें हाँ कल की है, इस दिन को खुल के तू जी लेना ओ यारा मेरे यारा। छोटी सी मुस्काने गाने दो चेहरे पे इस दिन को, खुल के तू जी लेना ओ यारा। कल की तो बातें हाँ कल की है, इस दिन को खुल के तू जी लेना ओ यारा मेरे यारा। जब तक जिए हम, जिंदा रहे हम, धूप हो छाँव हो चलते रहे हम। जब तक जिए हम, जिंदा रहे हम, धूप हो छाँव हो चलते रहे हम।
जिंदगी की राहों में फूल हो या हो का
नमस्कार, मेरा नाम है विवेक शर्मा और बहुत बहुत स्वागत है आप सबका दी कैंसर कॉन्क्लेव 2024 में, जहां हम आज बात करने वाले हैं कैंसर से जुड़े बहुत सारे एस्पेक्ट्स की और स्पेशली उस एंगल की जिसको हम बोलते हैं एडवोकेसी। और एडवोकेसी क्यों इम्पोर्टेंट है और क्या रोल प्ले करती है, आज हम जानने की कोशिश करेंगे। बिकॉज देखिए, ये एक नया सब्जेक्ट है और एक नया आयाम है जिसके बारे में बहुत सारे लोगों ने बहुत सारा काम नहीं किया हुआ है। अभी हमें बहुत सारा काम करना बाकी है। लेकिन इस पे आगे बढ़ने से पहले सबसे पहले हम समझने की कोशिश करते हैं कि ये जो पेशेंट एडवोकेसी है वो है क्या। मेरी स्क्रीन पे आपको एक चित्र नजर आ रहा होगा और ठीक है, इट्स गुड टू लाइक भगवान श्री राम को नमस्कार करना अच्छी बात है। लेकिन ये सिर्फ नमस्कार करने के लिए ये चित्र नहीं है। यहाँ पे इस चित्र में आप देखेंगे कि ये वो सीन है जब लक्ष्मण जो है मूर्छित हुए होते हैं और राम जी जो है उनको गोद में लेकर बैठे हुए हैं। और उस समय जो है हनुमान जी को जो है बोला जाता है कि भाई ये बूटी है, ये बूटी लेकर आनी है। और वो बूटी की बजाय जो है पूरा पहाड़ लेकर आते हैं। अगर आप सब जो है मेरे ख्याल से सब कैंसर से रिलेटेड लोग ही अवेलेबल हैं यहाँ पे और वो मुझे देख रहे हैं, हम सब जुड़े हुए हैं साथ में। अगर आप रिलेट करने की कोशिश करेंगे तो क्या ये कैंसर जैसा सीन नहीं है। भाई श्री राम जी जो हैं वो बहुत बलवान हैं, बहुत काबिल व्यक्ति हैं, लेकिन उसके बाद भी वो कुछ नहीं कर पा रहे हैं क्योंकि उनका भाई जो है, उनका परिवारजन जो है वो मूर्छित पड़ा हुआ है। उनके आसपास बहुत सारे लोग हैं, सबके पास अपने अपने ज्ञान हैं और सब लोग अपने अपने ज्ञान दे भी रहे हैं लेकिन कुछ कर नहीं पा रहे हैं। ऐसे में जो है एक व्यक्ति जो है वो किसी को बोलता है कि भाई पंडित जी, वैद्य जी क्या करेंगे, तो वैद्य जी बताते हैं कि भैया ये दवाई है। अब जो केयर गिवर है वो भी जाता है, उसको ये नहीं समझ में आता कि भाई बूटी कहाँ है, कौन खोजते फिरेगा। उन्होंने पूरा पहाड़ ही उठा लिया, फिर लेकर आते हैं तो फिर पता चलता है कि भैया ये बूटी है और दो, और ऐसे काम होता है। आज का हमारा कैंसर का सिनेरियो काफ़ी कुछ ऐसा ही है, जहाँ पे एक एडवोकेट की हमें ज़रूरत होती है, जैसे कि डॉक्टर्स हैं, लेकिन दे हैव देयर ओन लिमिटेशंस। देन लाइक हमें पूरा पहाड़ नहीं उठाना है। आज बहुत सारी चीज़ें बदल गई हैं। आज जो है हमें सिर्फ संजीवनी बूटी की ज़रूरत है। अब ये चाहे कीमोथेरेपी हो, टारगेटेड थेरेपी हो, इम्यूनोथेरेपी हो, लेकिन सबसे इंपॉर्टेंट चीज़ है कि भाई ये मिले कैसे, आए कहाँ, कैसे हम यहाँ तक पहुँचे। सो to understand this thing, we at UHAPO we have done one study kind of thing, जहाँ पे हमने 700 से ज़्यादा लोगों को कैंसर पेशेंट्स एंड केयरगिवर्स को इंटरव्यू किया। एंड हमने एक कॉमन ट्रेंड या कॉमन थ्रेड पाया उन सारे लोगों में। वो ये है कि एक, भाई देखिए, फिजिकली हम जैसे भी प्रोग्रेस करते हैं क्योंकि वो चीज़ें दिखती हैं तो हम उसके बारे में बात करते हैं। भाई आज मेरा पेट दर्द है, आज मेरे सर दर्द है, आज मुझे ये फीवर है। लेकिन जब मन खराब होता है तो हम बात ही नहीं करते हैं। लेकिन हकीकत ये है कि मन और शरीर जो हमारा साथ साथ चलता है। और ऐसे ही एक एवोल्यूशन होता है पेशेंट की लाइफ में, जिसको इवेल्युएट करना बहुत जरूरी होता है। एंड चाहे वो नॉर्मल जब पेशेंट होते हैं या जब हम पेशेंट नहीं होते हैं। देखिए कितनी विडंबना की बात है कि मतलब जब एक एक व्यक्ति जो है एक डायग्नोसिस के बाद जो है एक मरीज बन जाता है या कैंसर पेशेंट बन जाता है, उसकी आइडेंटिटी ही चेंज हो जाती है। ये बहुत बड़ा स्टेप है एंड पूरी जर्नी जो है उसको तय करनी होती है। और इस जर्नी में बहुत सारे सवाल होते हैं उसके मन में, और वो सवाल जो है वो चेंज होते जाते हैं जैसे जैसे वो जो प्रोग्रेशन है डिसीज का या जो सर्वाइवल है वो आगे बढ़ता जाता है। मेरे बाद बहुत सारे लोग हैं जो आपसे बात करेंगे और आपको ये भी शेयर करने की कोशिश करेंगे कि कैसे ये होता है। एंड जब पेशेंट जो है किसी लेवल पे होता है, इसमें जैसे देखिए हम कंफ्यूज्ड, विक्टिम मेंटालिटी, नर्वसनेस, होप, इरिटेशन एंड फ्रस्ट्रेशन एंड पॉजिटिव रिस्पॉन्स, ये इतने 1 2 3 4 5 छः स्टेजेस हैं यहाँ पे। इन 6 स्टेजेस में हर स्टेज पे पेशेंट की जो है रिक्वायरमेंट जो है, जो ज़रूरतें हैं वो बदलती चली जाती हैं। भाई किसी स्टेज पे कुछ चाहिए, किसी स्टेज पे कुछ चाहिए। लेकिन सबसे बड़ी प्रॉब्लम कैंसर में ये होता है कि किसी को पूरा पिक्चर पता नहीं होता है कि हमको एक्चुअली क्या चाहिए। इसके लिए बहुत ज़रूरी है कि हम सब जो है साथ में मिलकर काम करें, बिकॉज कॉम्प्लेक्स बीमारी है, जितना भी थोड़े बहुत अनुभवों से मैं समझा हूँ। और इसके बारे में बहुत सारी चीज़ें अभी भी अननोन हैं। काफ़ी सारा काम हो रहा है, रिसर्च हो रहा है, सब कुछ हो रहा है, लेकिन अभी भी बहुत सारी चीज़ें करने के लिए बाकी हैं। तो प्रॉब्लम क्या होती है, किस टाइप की प्रॉब्लम्स होती हैं हमारे यहाँ कैंसर पेशेंट्स में? जो सबसे बड़ी प्रॉब्लम होती है वो नेविगेशन की होती है। ये नहीं पता होता है कि जाना कहाँ है, किससे बात करनी है। मुझे तकलीफ है, जब हम दूसरे लोगों से मिलते हैं तो लगता है अरे यार इसकी भी तकलीफ ऐसी है, ये भी वैसे ही है, ये भी वैसे ही, अच्छा अच्छा अच्छा, चलो अब हम लड़ सकते हैं। फिर इमोशनल टर्मोइल होता है क्योंकि आपकी आइडेंटिटी जो है पूरी चेंज हो जाती है। आप कल तक मित्र होते हो, कल तक डॉक्टर होते हो, कल तक कोई प्रोफेशन आप कैरी करते हो, आपकी वो आइडेंटिटी होती है। लेकिन आज आप सिर्फ और सिर्फ एक कैंसर मरीज हो। या एक कैंसर केयर गिवर हो, पूरी आइडेंटिटी चेंज हो जाती है। देन बीमारी है, तकलीफ है, फंक्शनल प्रॉब्लम्स होते हैं, वो जो है हमें परेशान करते हैं। देन सोसाइटी जो है डिफरेंटली बिहेव करना शुरू कर देती है, बेचारगी की निगाहों से देखना शुरू कर देती है, या ओवर सिंपैथेटिक हो जाती है। कई कई बार जो है सिंपैथी नहीं होती है लोगों में, बड़ी मतलब अनप्रोफेशनल तरीके से उनको हैंडल किया जाता है। एंड यस, हमने हर जगह सुना है, देखा है, जाना है कि भाई कैंसर जो है बड़ी महंगी बीमारी है, एक्सेस को लेकर बहुत सारे प्रॉब्लम्स होते हैं, तो वो फाइनेंशियल टॉक्सिसिटी, वो चीज़ें यहाँ पे होती हैं। नाउ द थिंग इज दैट भाई हम इतनी सारी चीज़ें समझ रहे हैं, तो अब हम करें क्या? भाई देखिए, एडवोकेसी की बात करने के लिए मैं या ये प्लेटफॉर्म या कुछ और लोग जो भी हमारे साथ जुड़ते हैं, जुड़ रहे हैं, हम पहले व्यक्ति नहीं है। बहुत सारे लोगों ने बहुत सारा काम किया हुआ है, और कुछ कुछ टुकड़ों में करा हुआ है, एंड हमें ये भी पता नहीं है कि मतलब वो एडवोकेसी है। लेकिन मोटा मोटी अगर हम बात करें तो 5 लेवल पे एडवोकेसी बहुत ज़रूरी है। पहली चीज़ जो है, हॉस्पिटल एडवोकेसी ज़रूरी है, क्योंकि पेशेंट जो है आता है अस्पताल, वहां पे ही डायग्नोसिस होता है। दूसरी जो है, गवर्नमेंट की पॉलिसी पे एडवोकेसी होना बहुत जरूरी है, बिकॉज कोई बड़े अस्पताल या कोई बड़े ग्रुप जो है, मतलब एक बड़ा देश को नहीं संभाल सकते हैं, तो सरकार को बीच में आना ही पड़ेगा, और सरकार को ही जो है ये चीजें ड्राइव करनी होंगी। यस, देयर वुड बी लॉट ऑफ पीपल हु वुड बी रिक्वायर्ड टू सपोर्ट देम एंड गाइड देम। थर्ड इज कोलैबोरेशन विद ऑर्गेनाइजेशन। हमारे यहाँ या एक सोशल जो प्रवृत्ति ये है कि हम एक दूसरे को, जैसे मान लीजिए कि एक कोई कंपनी है दूसरी कंपनी को एज अ कॉम्पिटिटर देखती है, या किसी एक एंटिटी की नज़र से देखती है, लेकिन हमें इस संदर्भ में सबको एज अ कोलैबोरेटर की तरह देखना है। देन कम्स रिसर्च एडवोकेसी। भाई आज जो भी सुधार हुआ है कैंसर में, इट इज ऑल बिकॉज ऑफ द रिसर्च। एक जमाना था जब लंग कैंसर जैसी बीमारियों में लोग 3 महीने 6 महीने में चले जाते थे, डॉक्टर जवाब देते थे, बोलते थे कि अब इनको घर लेकर जाओ। लेकिन आज 7 साल, 8 साल, 10 साल तक लोग जी रहे हैं, और अच्छी जिंदगी जी रहे हैं, क्वालिटी ऑफ लाइफ बढ़ गई है। ये सब हुआ है बिकॉज ऑफ रिसर्च, क्योंकि नई दवाइयाँ आई हैं, नई टेक्नोलॉजीज आई हैं, नए नए आयाम उसमें ऐड हुए हैं, उसकी वजह से हो रहा है। और ये तो एक बहुत छोटा सा एग्जाम्पल है, बहुत सारी चीजें हैं। एंड इम्पॉर्टेंटली, इंडस्ट्री कोलैबोरेशन। बिकॉज देखिए, डॉक्टर ने अपना काम कर दिया, पेशेंट जो है उसकी अपनी सफरिंग है, उसको अपना चीज़ें चाहिए, लेकिन ये प्रोवाइडर है कौन? प्रोवाइडर तो इंडस्ट्री है, चाहे वो अस्पताल हो, चाहे वो फार्मा कंपनी हो, चाहे वो इंश्योरेंस प्रोवाइडर हो। ये इट विल ऑलवेज कम टू अस फ्रॉम इंडस्ट्री। तो इनका इंक्लूजन होना बहुत जरूरी है। अब इन इन लेवल्स पे अगर हम एडवोकेसी की बात करें, तो भाई फायदा क्या हुआ है, क्या कुछ हुआ है? तो अगर हम देखेंगे हॉस्पिटल्स में, आज की डेट में आप किसी भी अस्पताल में, किसी भी ठीक ठाक अस्पताल में चले जाएंगे ना, आपको एक मेडिकल सोशल वर्कर का डिपार्टमेंट मिलेगा। ये किसी ने कहीं तो एडवोकेसी शुरू करी थी भाई, किसी ने बोला था कि पहले पहले तो ये डिपार्टमेंट नहीं होते थे, किसी ने बोला कि भाई ये इसकी जरूरत है, और धीरे धीरे ये बढ़ते चले जा रहे हैं। तो एडवोकेसी के फायदे यहाँ पे इस लेवल पे ये हुए हैं। अब कई जगह पे कंसेशन टिकट्स मिलते हैं, फ्री टिकट्स मिलते हैं फॉर पेशेंट्स एंड केयर गिवर्स जो कैंसर के होते हैं। क्यों आया ये? एडवोकेसी की वजह से है ना। किसी ने बोला कि भैया जाओ बूटी लेकर आओ। देन वर्चुअल कंसल्टेशन। आप देखिए ना, कोविड के पहले एक टेली कंसल्टेशन करने के लिए कोई डॉक्टर रेडी नहीं होता था, बिकॉज वो मेडिको लीगल इश्यूज, लॉ, ये वो दुनिया भर की चीजें थी। तो आज एक, भाई एक, भले ही वो एक महामारी थी, लेकिन उसके थ्रू, उसकी वजह से एडवोकेसी हुई, लोगों ने मिलकर बोला नहीं भाई ये तो पॉसिबल नहीं है, आपको वीडियो कंसल्टेशन करना पड़ेगा, लिबरलाइजेशन हो गया। गवर्नमेंट लेवल पे अगर हम देखेंगे तो भाई महाराष्ट्र, सॉरी, झारखंड और राजस्थान, ये ऐसे 2 प्रदेश हैं जहां पे पेशेंट एडवोकेसी का बहुत गंभीर असर पड़ा है। पहली चीज तो उन लोग ने जो कैंसर है उसको नॉन कम्युनिकेबल डिसीज जो है वो घोषित कर दिया है, और कई सारे स्टेप्स ऐसे लिए हैं जहां पे वीकर सेक्शन को फ्री में या बहुत कम पैसों में दवाइयां और सर्विसेज मुहैया कराई जा रही है। कोलैबोरेशन ऑफ ऑर्गेनाइजेशंस की अगर हम बात करें तो देखिए, हर एक की अपनी अपनी कैपेबिलिटी होती है। और जैसे मान लीजिए कि अब अगर हम अस्पताल का एग्जांपल लें, हम क्योंकि स्वास्थ्य की बात करें, कैंसर की बात करें, डॉक्टर जो है वो नर्स का काम नहीं कर सकता, नर्स जो है वो क्लर्क का काम नहीं कर सकती, क्लर्क जो है किसी और का काम नहीं कर सकता। सबको एक साथ आना पड़ेगा, क्योंकि सबकी अपनी अपनी अलग अलग कैपेबिलिटी है। अगर ये एक इकोसिस्टम बन सकता है, तो हमें भी एक अच्छा बेहतर और बढ़िया इकोसिस्टम बनाने की जरूरत है। और वो तभी होगा जब हम कोलैबोरेटिव वे में एक साथ आएंगे, हम अपने प्रायोरिटीज को दूसरे की प्रायोरिटीज से अलाइन करेंगे, अपने कह सकते हैं कि बड़ी क्रूड लैंग्वेज में, अगर ईगो को जो है या हमारी जो चीजें हैं उसको पीछे छोड़कर एक कॉमन कॉज के लिए, बड़े कॉज के लिए साथ आएंगे। रिसर्च में एडवोकेसी, आज आप खुद ही देखिए कितना बड़ा इम्पैक्ट हुआ है। कि रियल लाइफ एविडेंस बिल्डिंग हो रही है आज। भाई 10 साल पहले, 8 साल पहले कुछ ऐसे लोग आए जिन्होंने बोला कि नहीं नहीं, ये दवाइयाँ अगर रिसर्च हो रही तो हमको भी मिलनी चाहिए, हम बनेंगे पार्ट क्लिनिकल ट्रायल का, और वो बने। उसकी वजह से उन्होंने कितने सारे लोगों के लिए वो रास्ते खोल दिए। इनफैक्ट फार्मा कंपनीज ने जो उनके प्रोडक्ट लॉन्चेस होते थे, जो उनको 2.5 साल 3 साल के बाद करने होते थे, उन्होंने प्रीपोन किए। ये फर्क है एडवोकेसी का, ये फर्क है सबको साथ आने का। इंडस्ट्री कोलैबोरेशन अगर देखा जाए तो भाई आज कितने सारे पेशेंट सेंट्रिसिटी की बातें हो रही हैं कि भाई पेशेंट 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 जो है पहले कोर में नहीं होता था, लेकिन आज जो है धीरे 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 करके पेशेंट कोर में होता जा रहा है, और उससे रिलेटेड सारी चीजें चलती चली जा रही हैं। और अब जो है पहले ट्रीटमेंट फोकस चीजें होती थी, अब केयर की बात होने लगी है। तो ये सब चीजें जो है एडवोकेसी के माध्यम से, एडवोकेसी की वजह से ही आगे बढ़ रही हैं, और बहुत जरूरी है। अब हमें करना क्या है भाई, यहाँ तक तो हम आ गए, भाई आगे भी तो जाना है, और आगे क्या करेंगे। पहली चीज, सबसे अच्छी चीज जो है हमने वो करी है, जो हम साथ मिलकर यहाँ तक आए हैं, वो एंगेजमेंट जो है, वो चाहे वो सरकार के साथ में हो, चाहे इंडस्ट्री के साथ में हो, इंश्योरेंस कंपनी के साथ में हो, फार्मा कंपनी के साथ में हो, दूसरे अस्पतालों के साथ में हो, दूसरे सपोर्ट ग्रुप्स के साथ में हो, डॉक्टर्स के साथ में हो, दूसरे पेशेंट फोरम्स के साथ में हो, इन सारी चीज़ों को साथ में लेकर आगे आगे बढ़ते चल रहा है। ये डिसकंटिन्यू नहीं करना चाहिए। ये तो एक छोटा सा पहल हमने लिया है, अभी तो आगे बहुत काम करना है। दूसरा, कोलैबोरेटिव एफर्ट्स। आज हम खुद एज उहापो, जो हमारी सोशल एंटरप्राइज है, उसके तहत हम बहुत सारे लोगों से जुड़ते हैं। भाई उनकी कैपेबिलिटी कुछ और है, हमारी कैपेबिलिटी कुछ और है, लेकिन साथ में मिलकर हम एक कुछ बहुत बड़ा काम जो है करने की कोशिश कर सकते हैं, और ज़्यादा लोगों को, ज़्यादा लाइफ्स को हम टच कर पा रहे हैं। डाइवर्स एडवोकेसी पार्टनर्स हमको ढूंढने पड़ेंगे, बिकॉज जैसा कि अभी मैंने बताया, कैपेबिलिटी, लाइक अगर मेरी कमी, कैपेबिलिटी जो है एक चीज़ है, मेरे पास कुछ कमी है, तो वो कमी को मैं पूरी कर सकता हूँ। आज आज वो जमाना नहीं है जब हम चिट्ठी और तार पे या टेलीफोन पे डिपेंडेंट है। आज तो एक मैसेज पे सारे काम हो जाते हैं। आज के दिन में अगर हम नहीं कर पाएंगे तो कैसे करेंगे। तो डाइवर्सिटी का सबसे बड़ा फायदा ये होता है कि हम एक दूसरे की प्रैक्टिस से सीख सकें। भाई रेयर डिसीज वालों ने कैसे किया, सिकल सेल वालों ने कैसे किया, अगर वो कर सकते हैं तो क्या हम उनसे कुछ सीख सकते हैं। क्या दूसरे डिपार्टमेंट ने कुछ ऐसा करा जिससे हम सीख सकते हैं, क्या हम उनके साथ में अपनी बेस्ट प्रैक्टिसेस शेयर कर सकते हैं। सो वी हैव टू हैव अ डाइवर्स एडवोकेसी पार्टनर्स। एंड देन यस, कैंसर ट्रीटमेंट से उठकर, हालांकि ट्रीटमेंट बहुत इंपॉर्टेंट है और बेसिक है, लेकिन स्टिल कहीं ना कहीं हमको शुरुआत करनी चाहिए केयर एडवोकेसी के लिए। क्योंकि कैंसर जो है सिर्फ फिजिकली इम्पैक्ट नहीं करती है, सोशली, इमोशनली, फाइनेंशियली, हर तरह से इम्पैक्ट करती है। और जब मन खुश होता है तभी तन जो है वो बेहतर हो सकता है। तो मुझे लगता है कि जो ये एडवोकेसी का जो प्रोग्राम है, मेरे ख्याल से बहुत सारे लोगों को इसमें बहुत कुछ सीखने को मिलेगा आज, क्योंकि हम बहुत सारे एक्सपर्ट्स लेकर आए हैं आपके लिए। और आप कहीं मत जाइएगा, जुड़े रहिएगा हमारे साथ। और मैं उम्मीद करता हूँ कि मतलब आपको जो पर्सपेक्टिव है मेरा वो शायद सही लगा हो। अपने विचार जरूर व्यक्त कीजिएगा और मुझ तक पहुँचेगा। आप लिंक में भी डाल सकते हैं, जो चैट बॉक्स है वहाँ पे भी अपने विचार शेयर कर सकते हैं आप। और अब मैं इनवाइट करना चाहूँगा मिस वंदना महाजन को। वंदना जी एक ऑन्को साइकोलॉजिस्ट हैं, खुद एक कैंसर पेशेंट हैं, खुद एक कैंसर सर्वाइवर हैं, और बहुत सारा काम करती हैं, बहुत सारे लोगों की लाइफ में बड़ा सारा ट्रांसफॉर्मेशन लेकर आती हैं। हम कई सालों से जुड़े हुए हैं, और कुछ कुछ काम जो है, जितने भी हमारी, जैसे हमने कैपेबिलिटी की बात करी, तो उनकी कैपेबिलिटी, हमारी कैपेबिलिटी, हम साथ में मिलकर कुछ ना कुछ करते आ रहे हैं, और उम्मीद है कि बहुत सारा काम करेंगे। वंदना जी नमस्कार, और बहुत बहुत स्वागत है आपका।
नमस्ते विवेक जी, थैंक यू सो मच फॉर सच अ वार्म इंट्रोडक्शन। और आज तो वर्ल्ड कैंसर डे है, तो आई एम ग्रेटफुल कि आपने मेरे को ये अपॉर्चुनिटी दी टू कम एंड टॉक अबाउट पेशेंट एडवोकेसी। सो थैंक यू वेरी मच। सो मैं आप सबके साथ एक प्रेजेंटेशन शेयर करूंगी, एंड आई विल टॉक अबाउट cancer advocacy in across the world, its changing face, the impact it has brought in, and how are we managing cancer advocacy in India. तो विवेक जी मैं शुरू करूं? I will share
जी
my
प्लीज
screen.
प्लीज।
जी, I'll just share my screen. Screen, am I visible? Is the screen
जी जी
visible,
जी,
विवेक जी?
फुल स्क्रीन कर लीजिए जी।
फुल स्क्रीन कर लेती हूँ। या एक मिनट, ओके एक मिनट। अभी दिख रहा है विवेक जी?
जी फुल स्क्रीन तो नहीं आ पाया है।
अभी?
हाँ जी।
अभी आ गया ना?
यस यस
जी ठीक है। तो इससे पहले मैं ये शुरू करती हूँ। सो आई जस्ट वांट टू टेल एवरीवन अबाउट हु आई एम। मेरा नाम वंदना महाजन है और मैं कैंसर केयर एंड पैलिएटिव केयर काउंसलर। आई एम अ वेरी वेरी पैशनेट पेशेंट एडवोकेट। इतनी पैशनेट हूँ कि आज फैमिली में शादी है लेकिन मैं फिर भी यहाँ पे आई हूँ। सो दैट इज द रोल ऑफ अ पेशेंट एडवोकेट. I am also someone who has the lived experience of cancer. So I relate very closely to cancer struggles. So when I was diagnosed with cancer, I did not have the support that me and my family needed. तो बहुत जरूरी है कि we need talk about the importance of advocacy in a family that has been affected by cancer. I did not get the emotional support. I had excellent doctors, but I did not have the emotional support. No one was there to guide my daughter about what to do. Nobody was there to support my husband. Nobody was there to tell me that what to expect. And post-treatment, survivorship support bhi nahi mila. That is when I decided that I need to step into this area and talk about and do something that will support the cancer community. So मैं अपने presentation शुरू करती हूँ. So let's talk about advocacy in cancer care. सबसे पहले we need to understand what is cancer advocacy. So the latest statement by WHO, जो अभी 2 दिन पहले release हुई है, it says by 2050, the cancer burden is going to increase by 77%. My God, that's scary, 77%. And अगर अभी हमने कुछ नहीं किया, तो कब करेंगे? So the cancer community worldwide actually believes that till हम सब मिलके we pitch in, we support the cause of cancer in various ways. जैसे विवेक जी ने बोला था, not only treatment, but also care, quality of life. So वो कैसे कर सकते हैं? उसमें then the role of advocacy comes in. What is advocacy? Advocacy, समझने के लिए, I'm just going to take you through certain points. Advocacy plays a pivotal role in cancer control planning and is necessary in any resource setting to influence policy and improve delivery of cancer control. The WHO 2008 Practical Guide on Cancer Control Policy and Advocacy and 2013 to 2020 Action Plan for the Prevention and Control of NCDs, Non-Communicable Disease, जिसमें कैंसर भी आता है, both articulate that advocacy is a critical strategy in improving cancer control and care delivery, not only nationally, but internationally. Definition of cancer advocacy is very varied, but in cancer care, we define advocacy as a systemic approach to promoting cancer-related issue and motivating others to take action. Now, cancer patient advocate का काम क्या है? This advocacy provides a framework to ensure meaningful involvement of the community in decision-making that affects the lives of the patients and the caregivers. It is recognized that cancer advocacy provides a voice for the patient and raises awareness of their needs. What is the most important concept of patient advocacy? ये सब तो बहुत definitions मैंने बताई आपको. It is rooted very deep in the concept of empowerment. When we talk of empowerment, we mean that we involve patients and the caregivers. We encourage them rather in participating in their own care. So I basically told you what is patient advocacy. How can advocacy happen? For any advocacy to happen, we need people who are called patient advocates. This slide that I'm showing you is very, self-explanatory. Different roles of a patient advocate. So what does a patient advocate do? A patient advocate supports a cause or policy regarding cancer. कहाँ काम करते हैं? They work on local and national levels. What do? They provide support to those living with cancer or those who have lived with cancer. They also provide support to people who have lost their lives to cancer और उनकी जो families रह जाती हैं. Raising awareness about the disease, advancing cancer research, very, very important. Improving the quality of cancer care, and addressing legislative and regulatory issues that affect cancer care and research. Now, we've spoken about what is cancer advocacy, patient advocacy. उसको करने के लिए patient advocates चाहिए. So what do they do? So basically, patient advocates, they act as a bridge or a liaison between patients, family members, the research community and the clinicians. तो सोचिए कितना important role है for the right information to reach the different stakeholders. Therefore, we need to strengthen patient advocacy. So what do? They support, newly diagnosed patients. They engage in fundraising activities for cancer research. They also sit on government review panels. They educate the local community about the different, advancements or availability of cancer treatment. They provide resources like transportation, accommodation. They moderate social media sessions like Vivek ji is doing, in collaboration with CRSF and with UTSA. They raise awareness about cancer events and advancements. Now, we have patient advocates. When patient advocates come together, then we form patient advocacy groups. So, अकेले तो कोई कुछ नहीं कर सकता. Therefore, there is strength in togetherness. Therefore, we need patient advocates to come together and form advocacy groups. What is the role of patient advocacy? So as per the NCCN, which means National Comprehensive Cancer Network guidelines, patient advocacies help patient families and their caregivers to navigate the complex cancer landscape. These groups ensure patients receive appropriate, timely care, education, financial assistance, emotional assistance, psychological assistance when needed. जब हम high income countries की बात करते हैं, cancer advocacies have been a potent influence in raising awareness about cancer burden and directing public and private efforts towards cancer control. Unfortunately, in countries like India and different LMIC countries, मतलब low and medium income countries, where cancer somehow abhi bhi low priority hai, advocacy is very, very underdeveloped. We need to prioritize cancer control because, like I said right in the beginning, by 2050, WHO says the cancer cases are going to rise up by an alarming 77%. So basically, that is why we need more patient advocacy groups to bring public's concern to the policy makers. जब तक policy makers के पास हमारे concerns नहीं पहुंचेंगे, we cannot bring about the much needed change. Now, there are different types of cancer advocacies in the world. This picture tells you about many. There is educational advocacy, which of course, talks about educating people and raising awareness. Then there is political advocacy, which is very, very important. Involvement of the government in approving and supporting the various concerns and bring about the much needed change is very, very important. So that's the political advocacy. Research advocacy, ये शुरू में विवेक जी ने भी हमसे बात किया है. Research advocacy में, at the support groups, they raise money for cancer research. They support cancer research through clinical trials. Then support advocacy. It improves the quality of cancer care. When we talk of cancer care, remember, like Vivek ji said right in the beginning, it's not only about treatment. It is about end of life. It is about survivorship. It is about pain relief. It is delivery of care during treatment. It is about psychosocial support. So support advocacy ka role ye hota hai. There is fundraising advocacy, which helps raise funds for various causes. Community outreach advocacy is very, very important. So I'll talk about this later. अब इंडिया में ये तो मैंने advocacies across the world की बात की है. Now, what are the various cancer advocacies in India? We have educational advocacies, we have support advocacies, we have fundraising advocacies. In areas में बहुत सारी support groups, patients individually, बहुत सारी NGOs, hospitals, they are doing a lot of work. So let me just cite some examples. For example, Capid India. Capid India is doing some amazing work for cervical cancer. We have Can Kids. Can Kids is doing some exceptional work for supporting cancer in children. I'm a part of Lung Connect India Foundation. We are supporting cancer patients pan-India and even in our neighboring countries through different advocacies, which includes treatment, emotional support, reaching out to the government. And then we have Indian National Congress, the Indian Cancer Society, which is doing some amazing work. So in areas में there's a lot of work that's happening in our country. But kaha kami hai? We need more advocacy for cancer research and clinical trials. I recently attended a conference which was done by NIHR, National Institute of Health and Care. इनका बहुत काम है towards advocacy in NCDs, which includes cancer as well. And political advocacy needs stronger, more emphasis, community outreach programs. Now, impact of cancer advocacies in the last decade. There's been a lot of impact. This slide to आपकी information के लिए है. So in 2017, Cancer Resolution, the Global Action on NCDs, WHO cost-effective recommendations for NCDs, and Sustainable Development Goals are global health commitments that are interconnected, building on each other to provide countries and other stakeholders with a framework to deliver and develop comprehensive cancer services. So, isme there is improvement in quality of life because of the various treatment modalities, survivorship. There are people survive for a longer time. So, post-surviving, there is emphasis on improving the quality of life. There is there are emphasis on prioritizing cost-effective interventions. There is emphasis on integrating the cancer advocacy in the NCD plans. And also, so alongside research investment, cancer advocacy efforts have helped improve detection, survival, and for some cancers, even cure. अब हम बात करते हैं that areas that need stronger advocacy. Caregivers के लिए we still don't have enough support in our country. So we need stronger advocacy for caregiving, for talking about the high cost of cancer, survivorship issues के लिए advocacy है ही नहीं. I am as a survivor, I still don't find the support that I need. Nobody talks about the long-term side effects of the treatment. Where is the advocacy for that? And palliative care. There is hardly any advocacy for palliative care. We are taking baby steps. We still have a long way to go. Communication and public policy. Public policy advocacy is much needed in our country. Stigmas. What are the challenges to advocacy in India? Simple, one line. Stigma and the myths attached to cancer. इससे ज़्यादा तो कोई बड़ा hurdle है ही नहीं. As we all know that cancer is still considered a disease of the untouchables. So if we start from there, it prevents people from reaching out for treatment. They reach out to alternative treatment and they lose their lives. So उनको हम, how can we convince them to be a part of advocacy when they are not ready to acknowledge their own struggles? Therefore, this is the biggest stigma. Then we have knowledge gaps. We have limited organizational capacity and resources. किस लिए? Because India is a huge country with different, people culturally, we are all very different. how do we collaborate and bring them together? Lack of funding. And like in the beginning, Vivek ji said, we do not want to collaborate. I don't know why we don't want to collaborate. Till we collaborate, we cannot strengthen the cause of patient advocacy. How can we build a stronger ecosystem to support cancer patients in India? बहुत जरूरी है. Yeah. Number one, educational advocacy. We need more organizations. We need more support groups. We need the government to step in. We need hospitals and doctors to step in to do this. If ये खुद ही slide काफी explain कर रही है. Then we need political advocacy. Then we need research advocacy to ensure high quality research that is sensitive to the priorities of cancer patients. This may mean more targeted therapies that offer higher quality of life and fewer and easier treatment visits. Support advocacy, जो मैंने पहले भी बात किया है. Fundraising advocacy. I want to pay a little extra time on community outreach advocacy.
Vandana ji, if we can wrap up fast.
Ji, this is the last slide, Vivek ji. This advocacy is very important to reach out to the community in a manner that encourages a two-way dialogue. Therefore, we need to have a two-way conversation with the community. Therefore, community outreach advocacy is very important. Why be an advocate? This is my last slide. Unless people like you care an awful lot, nothing is going to get better. I'm telling you, nothing is going to get better. So thank you very much.
थैंक यू सो मच वंदना जी फॉर द इंफॉर्मेशन एंड एक पर्सपेक्टिव शेयर करने के लिए कि मतलब पेशेंट एडवोकेसी है क्या, कैसे काम करते हैं. नाउ आई डोंट नो इफ बहुत सारे लोग जो अगर शुरुआत से जुड़े हुए हैं तो हमने एक पिक्चर देखी थी वो संजीवनी बूटी वाली, लक्ष्मण जी वाली, लेकिन उससे ही रामायण से ही जुड़ा एक और किस्सा है जहाँ पे केवट जो है वो पिक्चर में आते हैं एंड वो राम को जो है इस पार से उस पार लेकर जाते हैं, नेविगेट करते हैं उनको. ऐसे ही एक बहुत बड़े नेविगेटर देश के हमारे साथ हैं मिस निशु गोयल. निशु जी नमस्कार और बहुत बहुत स्वागत है आपका. निशु जी टाटा मेमोरियल हॉस्पिटल में केवट करके एक जो प्रोग्राम है उसको लीड करती हैं. केवट इज अबाउट नेविगेटिंग कैंसर पेशेंट्स ड्यूरिंग देयर जर्नी. Nishu ji, if I would request if you can, start your session.
Thank you so much, Vivek. Thank you for the kind invitation. And it's really nice to be a part of this Cancer Conclave 2024 and with CRSF, UHAPO and UTSA Foundation. And a very special thanks to Dr. Kumar Prabhash as well as Dr. Vijay Patil for getting this all together. And of course to you, Vivek. So I think the best thing about collaboration जो मैं अभी तक सुनती आ रही हूँ is the fact that we are here because of collaboration. We have clinicians, we have patient advocates, we have other support groups, all of them a part of this entire meeting. And that itself is a big start. So without much ado, I will start my presentation on navigating a cancer diagnosis. Because जब एक cancer diagnosis का जिसको कहते हैं शुरुआत होती है कि आप फैमिली से या आप पेशेंट से बात करते हैं तो इट्स अ वेरी ओवरवेलमिंग एक्सपीरियंस. नेक्स्ट स्लाइड प्लीज. तो दो चीजें जो प्रोमिनेंट होती हैं, व्हाई मी, मुझे ही ये क्यों हो रहा है और मैंने ऐसा क्या किया था कि मुझे ऐसा हो गया. सो रीजंस, पेशेंट्स ट्राई टू फाइंड रीजंस, केयर गिवर ट्राई टू फाइंड रीजन, एंड देन विल आई सर्वाइव, मतलब विल आई बी एबल टू कम आउट ऑफ इट, क्या मैं जिंदा बचूंगा या बचूंगी. So these are the two basic fundamental questions जो caregivers और patients दोनों के mind में होते हैं. And उस चीज को से बाहर निकलना and then to be able to concentrate on the treatment कि हमको आगे चल के क्या करना है, क्या steps हैं. And that is why my presentation I say taking the right step in time. And how do we mitigate any kind of issues, gaps, problems जो उस वजह से क्रिएट होती हैं और कैसे और कौन सी ऐसी एजेंसीज हैं जो हेल्प कर सकती हैं उन चीजों को मिटिगेट करने के लिए. नेक्स्ट स्लाइड प्लीज. सो फर्स्ट एंड फॉरमोस्ट आई विल इंट्रोड्यूस यू टू सम ऑफ द प्रॉब्लम्स दैट आर एग्जिस्टिंग इन द सिस्टम. नाउ वंदना जी टॉक्ड अबाउट हाई इनकम कंट्रीज, जो हमारी LMICs हैं या मीडियम इनकम कंट्रीज हैं, एक्सेसिबिलिटी की, रिसोर्स की, अफोर्डेबिलिटी की, ये सब मेन चीजें हैं फॉर either approaching cancer care facilities or continuing treatment. टाटा मेमोरियल सेंटर जो एक इंस्टीट्यूशन है, उन्होंने इंस्टीट्यूशनलाइज करा है केयर को, wherein we have now 9 institutes across or centers across the country. We also have NCG, which has about 131 members, hospitals, which are giving standardized care and quality-based evidence care across the country. So ये सब चीजें हैं जो शुरुआत में हुई हैं. आपने मेडिकल सोशल वर्कर डिपार्टमेंट का इंट्रोडक्शन किया था. मैं आपको बता दूं कि 1941 में जब टाटा मेमोरियल हॉस्पिटल की स्थापना हुई, उसमें मेडिकल सोशल डिपार्टमेंट था. और बहुत सी ऐसी चीजें हैं जो टाटा मेमोरियल से शुरू हुई हैं, एंड दे हैव बीन टेकन एज SOPs और स्टैंडर्ड ऑफ प्रैक्टिस और केयर throughout cancer care management in the country, and not only in India but also in other parts of the world. कुछ barriers to care जो मैं आप इंट्रोड्यूस पहले भी किया था कि क्या ऐसी चीजें हैं जो या तो पेशेंट को डिले करती हैं इन अप्रोचिंग अ हेल्थ केयर फैसिलिटी, या जब कैंसर डायग्नोसिस होता है तो उस हिसाब से उसको थोड़ा झिझकना होता है या हेजिटेंसी होती है in trying to complete treatment or start treatment. एक तो lack of awareness है कि कैंसर है क्या, उसका हम early detection से क्या फायदे हो सकते हैं. Also that not all cancers are incurable. There is a right management of cancer also. Cancer is not a death sentence. ये सब कैंसर के बारे में जो है lack of awareness है. आपके अपने symptoms हैं जो कैंसर जिनसे अगर आप उनको पहले नहीं बताते हैं या उनको नहीं डायग्नोस कर पाते हैं तो वो आगे चल के प्रॉब्लम में आ जाते हैं. तो लैक ऑफ अवेयरनेस होता है, फियर एंड एंजाइटी होता है. कई बारी हम पेशेंट्स को देखते हैं जो अपने ही फैमिली मेंबर्स से छुपाते हैं कि मुझे कुछ प्रॉब्लम है. एंड ज्यादातर हमने देखा है वल्नरेबल पॉपुलेशन जो जैसे लेडीज होती हैं, वो अपने सिम्टम्स के बारे में जल्दी नहीं बताती हैं. देन जब आप कैंसर ट्रीटिंग सेंटर में आते हैं, लॉजिस्टिक्स, अकोमोडेशन, फंडिंग, ये सब चीजें हैं जो आपको या तो जैसे ड्रॉप आउट होता है या आप अपनी ट्रीटमेंट आगे नहीं लेके जा सकते हैं. लैक ऑफ सोशल सपोर्ट, फैमिली में लोग नहीं हैं जो आपकी कैंसर ट्रीटमेंट को सपोर्ट कर सकते हैं, बिकॉज वी डू नीड पीपल अराउंड. जैसे एक कम्युनिटी होती है तो हमारा फैमिली मेंबर्स का कितना सपोर्ट है. अगर फर्ज करिए एक ही फैमिली मेंबर है या अर्निंग फैमिली मेंबर है तो उसका क्या सपोर्ट है. देयर इज अ लेडी इन द हाउस, उसको है तो कौन उसके साथ रह सकता है. सो लैक ऑफ सोशल सपोर्ट. एटीट्यूड्स, बिलीव्स एंड परसेप्शन, दिस इज वेरी इंटरेस्टिंग बिकॉज हमने जो ये नेविगेशन प्रोग्राम है ये हमने इंडोनेशिया में भी करा था, and we trained 21 doctors, nurses and psychologists in it. And they had to say that culturally, though Indonesia is very close to India, but आप ये मान के चलिए कि वहां पर भी कुछ अपनी cultural beliefs हैं. Like according to them, patients in India are more proactive towards their cancer treatment rather than the ones in Indonesia, because उनकी कुछ religious system beliefs हैं जो उनको ये जिनकी वजह से वो ये सोचते हैं कि मैंने कुछ गलत किया होगा इसलिए मुझे ये हो गया है. तो ये तो मेरे को जिसको कहते हैं कि this is something that is given to me as a part of my karma, or howsoever they construct that. So the health seeking behavior becomes poor. Their low health literacy कि हम क्या कर सकते हैं जिससे हम ये इस कैंसर से निकल सकते हैं, या हाउ डू वी मैनेज दैट, वो सब चीजें आर बैरियर्स टू केयर. और ये सब जो है poor preventive measures lead in delayed cancer presentation at a tertiary care center, then attrition and dropout at an early age, and gaps in the cancer care continuum, because cancer, जैसे आप जानते हैं, it is not a linear process. उसमें आपके बहुत सारे, it's a multimodal kind of treatment. आपका सर्जरी भी है, कीमोथेरेपी भी है, रेडिएशन थेरेपी भी है, then sometimes you can have recurrences, metastasis. So there are transitions of care. एक सीधा लाइन नहीं है, उसमें ups and downs हैं. तो when you are going from one transition to the other, how is the care managed for you? How integrated you are in seeking care and completing that line of treatment is also a continuum that you have to maintain. Then those who have been treated, उनका follow up जो है वो किस तरीके से चल रहा है. There are a lot of individuals that we have found in hospitals who are not very proactive about their follow ups. Some of them, we saw it in one of the centers, that if there is an adjuvant therapy, they feel one main therapy has been done, so there is no reason for adjuvant. These things require counseling, they require speaking, they require identifying individuals who might have these barriers and reducing the poor health outcomes. Next slide, please. जो मैंने डिले की बात करी कि कितना डिले होता है, ये 2013 में एक स्टडी हुई थी इन हॉस्पिटल इन उड़ीसा, एंड 3 महीने तक उनके जितने आईपीडी पेशेंट्स हैं उनका एक सर्वे लिया गया टू अंडरस्टैंड दैट फ्रॉम द अर्ली ऑनसेट ऑफ सिम्टम्स हाउ मच टाइम हैज इट टेकन फॉर देम टू अप्रोच टर्शरी केयर फैसिलिटी एंड स्टार्ट ट्रीटमेंट. सो आप जब हमने उसको स्ट्रैटिफाई करा तो appearance of signs and symptoms, first consultation with family and friend, consultation with doctor, consultation with other health systems, because they also try to seek alternate systems like Ayurveda, homeopathy, some natural healing, even some of them go to faith healers, and then finally referred by their own GP to an oncologist, and the treatment and diagnosis happens and treatment begins. So out of this cohort of patients, that the IPD ones that we were surveyed, it takes approximately 1 year, 8 months to start a treatment from early onset of symptoms. This had been done in 2013. I'm sure things are much better now with more cancer treating facilities and more cancer awareness that has come into, into the system. But it is very, very shocking कि इस हिसाब से हमारा जो even our own behavior towards seeking cancer treatment has this kind of a delay. Next slide, please. So before we started this KEVAT program, अब कैंसर डिफिकल्ट है, कैंसर ओवरवेलमिंग है, कैंसर की ट्रीटमेंट लंबी है, ज्यादा टाइम लगता है, ये सबको पता है. बट जो फेजेस हैं और ट्रांजिशंस हैं ट्रीटमेंट के, उसमें क्या इसेंशियल नीड्स हैं, और इस वजह से हमने एक क्रॉस सेक्शनल सर्वे किया था इन 5 TMC सेंटर्स in Maharashtra, Mumbai, Kharghar, as well as in Parel, Uttar Pradesh, Varanasi, Punjab, Sangrur, and Assam, Guwahati. So इसमें तकरीबन हमने 1674 पेशेंट्स को हमने सर्वे किया, और उसमें से हमने 4 फेज में इनको डिवाइड करा. 1, पेशेंट्स हु आर न्यूली रजिस्टर्ड, 15 days पोस्ट रजिस्ट्रेशन, मिड ट्रीटमेंट एंड लॉन्ग टर्म फॉलोअप. और इस सर्वे से हमें ये ज्ञात हुआ कि जितने भी पेशेंट्स की नीड्स हैं उनको हम स्ट्रेटिफाई कर सकते हैं इनटू इंफॉर्मेशन नीड्स, लॉजिस्टिक्स, अकोमोडेशन, फाइनेंसेस, ट्रैवल. कईयों को लैंग्वेज बैरियर होता है, लॉन्ग वेटिंग टाइम होता है, ओवरक्राउडिंग एट हॉस्पिटल्स, ट्रीटमेंट डिलेज के ट्रीटमेंट शुरू नहीं हो रहा है या टाइम लग रहा है शुरू होने में, प्रोग्नोसिस एंड टॉक्सिसिटी ऑफ ट्रीटमेंट, एक बार ट्रीटमेंट शुरू हुआ तो उसके साइड इफेक्ट्स या आफ्टर इफेक्ट्स, एंड लैक ऑफ इमोशनल सपोर्ट. सो ये सारी जो चीजें हैं ये एट डिफरेंट टाइम पॉइंट्स डिफरेंट फैक्टर्स प्ले करते हैं. एक और चीज हमने इस सर्वे से जो हमें वन फाइंडिंग विच वाज देयर कि अर्ली पेशेंट सेटिस्फैक्शन इंक्रीजेस as the patient goes on in the continuum. So जब आप पहले newly registered patients होते हैं, और इस the reason for showing you this survey is क्योंकि ये जो टॉपिक है आपने मुझे दिया है कि इनिशियल डायग्नोसिस. सो जो न्यूली रजिस्टर्ड पेशेंट्स होते हैं उनकी प्रॉब्लम्स बहुत ज्यादा होती हैं, और प्रॉब्लम्स होती हैं फर्स्ट गेटिंग अकस्टम्ड और गेटिंग इमर्सिंग देमसेल्व्स और अब्सॉर्बिंग द फैक्ट कि उनको कैंसर है. दूसरा, उसकी ट्रीटमेंट शुरू होना, ट्रीटमेंट के लिए टाइम लगना, फिर उसके बाद कौन से इन्वेस्टिगेशंस होने हैं, उसके लिए क्या जरूरतें हैं, हॉस्पिटल सिस्टम्स क्या हैं, क्लिनिकल केयर मैनेजमेंट कैसे करना है. तो ये सब जो चीजें हैं ये न्यूली डायग्नोज कैंसर पेशेंट्स के लिए ज्यादा प्रॉब्लमैटिक होती है, बिकॉज उन्होंने ये सिस्टम कभी देखा नहीं होता है. सो दैट इज व्हाई वी टारगेट as an initiative for KEVAT newly registered patients, and we have tried that all, like across all centers where we have our presence, we maintain the ratio of at least interacting with 90 to 80% of newly registered patients. So ये ratio हमने across TMC hospitals maintain करा है. Next slide, please. ये एक हमने ऑब्जर्वेशन प्रोजेक्ट किया था ऑफ न्यूली रजिस्टर्ड पेशेंट एट आवर एट्रिक सेंटर. 100 न्यूली रजिस्टर्ड पेशेंट्स इन द मंथ ऑफ मार्च 2023, 1 मार्च को जो न्यूली रजिस्टर्ड थे उनका हमने over 4 days, unka investigations ke kya hai, consultation ho gaya hai, what investigations have been advised, what is the follow-up. We observed or assessed it through the EMR reports. उसके बाद जिनका जो टाइमलाइन में नहीं थे या कुछ रिपोर्ट्स उनकी पेंडिंग थी या अपॉइंटमेंट के लिए नहीं आए थे, उनको हमने फॉलो अप किया. And we had 44 patients. We realized out of 100 newly registered patients, they had problems in incomplete workup, billing, workup not done, missed consultation, and financial help. 39% did not require any assistance. 5 patients treatment outside le rahe the. 2 were referred for treatment, and there was 10 no communication established and dropout. But isse mota mota ye dekh sakte hain ki at least more than 40% of the patients required assistance and had not approached the healthcare facility ki mujhe assistance ki zarurat hai. We had to approach those patients. So proactive advocacy is very important. Waiting for the patient to come to you might lead in a complete meltdown of lot of verticals. So instead, we should try to concentrate and integrate what we have. Next slide, please. You'll have to go down. Please, can you press again? So these are the various stages that we have been able to identify of running the patient navigation program since 2018 in Tata Hospital and other centers. So in screening and early detection, the kind of barriers and concerns that play are religious and cultural beliefs, financial concerns, lack of awareness, and fear of diagnosis. When diagnosis is done and the patient realizes that there is a cancer diagnosis, then there is delayed referral. तो उसपे जब आपका कैंसर डायग्नोसिस इवन एट एनी काइंड ऑफ ट्रीटमेंट फैसिलिटी है तो उसका एक रेफरल जो है वो प्रॉम्प्ट होना चाहिए. Psychosocial concerns, then financial concerns, logistics again play a very important part in diagnostics and also in the communication barriers. We have patients in Tata Hospital that come from different parts of the country. First, understanding what is medical terminology of their cancer prognosis and diagnosis. Secondly, you might have a patient who's coming from Assam who only knows Assamese. So either there has to be a translator. What we have also tried to do is involve, whenever we are selecting navigators, we try and involve individuals who have at least one more Indian language. So it is Hindi, English, and one more language. So it could be Marathi, Bengali, etc. So that we can, then address a diverse population. Next slide, please. Now, what are the solutions? The solutions are like we have a multidisciplinary team for treatment of cancer and management of cancer, there should be a multidisciplinary approach towards support. And this support involves everyone. It involves advocates, it involves MSW, it involves support staff, it involves home care individuals, it involves caregiver. But a communication honi chahiye between each of these verticals so that everyone knows where the patient is. Because here what happens when the patient is registered under one vertical, there is no communication from one to the other. We cannot work alone. That is a given. We have to work together. And also that multidisciplinary approach should be offered to the patient right at the onset of as soon as the treatment starts, so that he knows there should be a resource directory available for patients to be able to access and approach whenever necessary. And you should have individuals who can then interface with the patient at different standpoints, especially during transition of care. And as Vandana ji said, that there is nothing that can prevent you from being a cancer advocate. Yesterday, I had a call from a 12th class student who said that, ma'am, what we are planning to do is create 3 fundraisers, and the benefits we want to give a part 50% to treatment and 50% to those institutes who are doing cancer research. I mean, I was so happy that these are the kind of people who are coming across and coming forth with getting the patient advocacy together. And I really wish, and the next slide, please. And we only can learn from each other, and collaborations is definitely the way ahead, which has been spoken very many times on this platform. Last slide. Thank you very much for listening in. And I really wish that the testament to cancer control and cancer management is when there will be a cancer day that we'll be celebrating no cancer. Thank you.
Thank you, Nishuji. And it is a very powerful statement that we should be celebrating no cancer day rather than celebrating or observing cancer day. And with this, I would like to invite our next speaker, Dr. Vanita Norona. Dr. Saab is a avid clinical researcher, टाटा मेमोरियल हॉस्पिटल में काम करती हैं, प्रोफेसर हैं, कंसल्टेंट मेडिकल ऑन्कोलॉजिस्ट हैं. एंड डॉक्टर साहब आज हमें बताएंगे कि कैंसर रिसर्च और पेशेंट एडवोकेसी में क्या कनेक्शन है और हाउ डू वी काइंड ऑफ मूव फॉरवर्ड, क्या एक्सपीरियंसेस हैं, क्या आप शेयर करना चाहेंगे प्लीज.
Thank you so much, Vivek ji, Umesh ji, Dr. Kumar and Vijay for this opportunity. Can I have my presentation?
जी.
कि मैं शेयर करूं?
You can also share, or you want us to share, we can share.
I can try and share.
We're sharing.
Okay, you're sharing. Okay.
Yes.
Okay. So, next slide, please.
Just give me a.
No problem. So in the next maybe शायद maybe 10 minutes, 7 to 10 minutes मैं थोड़ा बात करूंगी कि cancer research and advocacy, how can we meet, what has a patient advocate got to do with cancer research particularly. तो क्योंकि हम सब सोचते हैं कि cancer research बहुत hi-fi चीज होती है, and you know what can a patient or a patient advocate or a caregiver have to offer. And that is absolutely, अगर ये हमारी concept है तो this is an absolutely wrong concept. This is not cancer research is not meant to be conducted एक ivory tower में or and then given to the patients. It has to be done. We have to work hand in hand. Next slide, please. So I think शुरुआत से हम यही बात कर रहे हैं. So I'll go quickly. What exactly is a patient advocate? So a patient advocate is any patient, so someone who has an experience, a lived experience of cancer. So or either a patient who currently has cancer, yeah, somebody who has gone through the experience of cancer is now cancer survivor, or the caregiver. So somebody who's an informal caregiver or a carer. This is one aspect. And the second aspect is that person is engaging in advancing the good of people like themselves and the community of cancer caregivers and cancer patients. So this does not include paid professionals. Next slide, please. And why should a patient advocate get engaged in research? So on the right side, this is Candice Henley. She is one of the leading cancer advocates worldwide. And what she has said is that every patient का जो experience है with cancer, वो अलग चीज होती है. Everybody has a different experience. But together, when patients and caregivers come together and share what is good for them, what worked well for them during the experience as a community, they can add their thoughts together and make everything about cancer care and cancer research relatable and relevant. So this is important for representation, and that gives the patient's voice an important aspect, an important seat at the table, and it is very important. So when we are cancer research, we all have our degrees in oncology, we have DM, we have MCH, लेकिन a patient has a PhD in the cancer experience, and that is a very valuable insight that can help to guide what is the best research, cancer research. Next slide. So what are the roles of a patient advocate in cancer research? So from every step of the process, a patient advocate can contribute. So right from the start, what is the most important question that we should be asking? How can we improve cancer care? Which is that one question. What are patient concerns in the design of the trial? How can we get more patients included in the research question? How can we accrue more patients on the trial? जब patient enroll होता है trial में, we normally give them a consent form so that we ensure कि इनके पूरी समझ में आ रही है कि हम क्या करने वाले हैं. How can we ensure that consent form is appropriate for the patient? Patient advocates also will provide feedback कि जो भी हम कर रहे हैं ट्रायल में, जो हम बायोमार्कर कर रहे हैं, जो हम बायोप्सीज कर रहे हैं, ब्लड टेस्ट कर रहे हैं, वो सब एक्सेप्टेबल है पेशेंट्स के लिए. जो इंक्लूजन एक्सक्लूजन क्राइटेरिया है वो सारे एक्सेप्टेबल है. कैंसर रिसर्च स्टडी के लिए हम फंडिंग कैसे मिलेंगे, that the patient advocates can help. Feedback during the study while we are conducting the study, and study खत्म होने के बाद how do we disseminate the results to the patients. Next slide please. So various steps during the research process, from the conception of the study to the conducting of the study and the completion of the study, patients and patient advocates are vitally important at every step. So from identifying the research question, guiding the trial design, identifying what is an important endpoint. Normally, as cancer research, our endpoints are survival. How can we improve survival? How can we improve cure? After many years of discussing with patients, we have now understood that also, other than the survival, so the quantity of life, the quality is important. So quality of life, the toxicities, how can we reduce the toxicities of cancer treatment? How can we improve quality of life? All of these are also important endpoints. And that can come only from actively engaging with patient advocates. While conducting the study, the patient advocates can define the relevant patient populations we can go to help improve the accrual, in complete the study faster, identify the patient burdens in participation, etc. And then after completion, to disseminate the results, the importance of the study results. Next slide, please. So what are the roles and opportunities of a patient advocates at various levels? And that depends upon the patient's experience as an advocate and the scientific understanding of the patient and the advocate. So depending upon the experience level, at a low experience level, there are multiple opportunities to participate in various clinical trial research. And as that experience level increases, the opportunities decrease, but there are multiple opportunities to sit on the national boards, various cooperative groups, etc. Next slide, please. So starting from patient advocacy in framing research questions. So when we start to do clinical trial research, the question that we are asking, how do we improve the care of the patient? How do we better cure this cancer? That research question is one of the most important steps in doing research. And while we decide that research question, there is an interplay between the need of the patient, what the researcher has a priority for, what the funding agency has a priority for, what the institution has a priority for. So all of these things have to meet together and then decide which is the best and perhaps the most possible research question that needs to be taken forward. So it may not be the best, but the most possible that can be done. And ultimately, at the end of it, the patient need has to be the priority. Next slide, please. So a very good example, which all of us may know, Dr. Abhay Bhang, when he returned from the US, his priority was to work on sickle cell anemia. That was his area of expertise. And then when he engaged with the locals, and he had a local council, a meeting of the local council, he realized that infant mortality was the big question there. That was a huge problem. And he was convinced that he needed to work on infant mortality. And I think the rest is history. So after listening to people in the villages, he started working to reduce infant and maternal mortality. Next slide, please. And we, in a very small way, we have tried to involve patient advocates in our research planning. So this is a study which we have not started yet. We have just got approval by our ethics committee. In this study, we are trying to see in older people with cancer, how can we use an intervention which consists of thoda exercise, meditation, cognitive training. These patients, can we reduce the effect of chemotherapy on their cognition? So an intervention to lower the chemotherapy-related cognitive dysfunction. Next slide, please. So this, I have just taken a picture of jo hum likhte hain in the protocol to send to the ethics committee. So we had interviewed 10 patients with cancer who came to our outpatient department, who were on chemotherapy, and we discussed with them ki ye hum soch rahe hain to do this study. What do you think? Would you be able? So this study will include going for exercise, visiting the physiotherapist, doing बहुत सारे क्वेश्चनर्स हैं जो आपको भरना पड़ेगा, यू हैव टू डू द कॉग्निटिव टेस्टिंग, ये पॉसिबल है, आपको क्या लगता है, दिस इज इम्पोर्टेंट, and we had taken their opinions and we put it together, we changed a bit. So many of them said कि हम हर दिन तो नहीं आ पाएंगे, we'll be able to come maybe once or twice a week. Half of them said कि उनके पास smartphone है, so they might be able to join online for an exercise program. So we incorporated that in our protocol. So this is ये थोड़ा सा baby effort ही है to try and get patients' inputs during the planning of the study. But I hope that with a more concerted patient advocacy, we can do this in a far better way to improve the way that we plan and write clinical trials. Next slide, please. Next slide, please. So, बहुत सारे advantages here to engage patient advocates. They will improve. It will definitely make all our research, cancer research, patient-centric. It will improve feasibility, acceptability, better rigor, more relevant to patients, higher quality. There will be mutual learning, building of new skills. We will be able to help disseminate research findings and improve the trust of the research community, and therefore increase the impact of the patient voice. Next slide, please. But everything is not rosy. There are definite issues with patient engagement. One is the challenge of engaging patient advocates. There is a perceived lack of scientific knowledge, and that may be frustrating both for the advocates as well as for the researchers. Same patients are recruited for engagement who have been part of the research with the principal investigator researchers, so that pool is very small. And sometimes there is a tokenistic approach. ये एक tick mark से check mark हो गया कि हमने बात किया है patient से. So that should not be. It should be a true collaboration and a true meeting of minds. Next slide, please. And there are multiple barriers. It's not clear why patients, not everybody recognizes that patient advocates should be included in research. And thank you, Vivek, for bringing this subject to the fore. So we must encourage granting agencies to require that patient advocates should be a part of the planning. And in the long term, there should be a project to demonstrate that the value of patient advocates in bringing patient advocates and researchers together. Then researchers are worried about saying the wrong thing, because these are, we are talking about, there are various maybe delicate things that we are discussing during the trial, and we don't exactly know how to communicate well. So there should be, there should be safe places to communicate. There should be training programs in the long term. Researchers don't know how to begin to work with advocates. We don't know how to include advocates in research. So multiple issues are there, and there are multiple barriers and multiple ways that we can bridge these barriers, both in the long term and the short term, and both in the short term and the long term. Sorry, next slide. And this is from the point of view of the researcher. Now, what about the advocate? There are multiple benefits and there are also burdens. So this was a survey that was done in 176 patient advocates, and most of them said that they found the work rewarding. Almost everybody said it was rewarding, it was empowering, it had a positive impact on their lives. But at the same time, at least a third of the patients said that they did experience symptoms of burnout. And being advocates said that it did result in exhaustion. So 51% said it resulted in exhaustion, sadness. A third of them said it made them anxious. And more than a third said that grief of their own cancer, their grief made it hard to maintain their work as advocates. Next slide, please. So we need training and evaluation for patient advocates. Why do we need it? Because if we don't have training and we don't evaluate the impact, then it just becomes tokenism again. So next slide, please. There are multiple organizations, ASCO, BMJ, Force, all of them have various in-person as well as online courses for training, and they have evaluated impact as well. I showed you one of the surveys. So multiple surveys have been done to evaluate the impact of advocacy. Next slide, please. And there are multiple training options. I'll skip this. I think we are running a little late in the week. So I'll skip this. There are multiple training options that we can include patient advocates in journal clubs, in discussions, in lab meetings, teaching, etc. Next slide, please. I think I'll skip this as well. So this is patient-centered outcome research and patient advocates, what kind of actions we can do. So from the planning to actions to the outcomes. Next slide, please. And most of the societies, the major scientific bodies of oncology, so ESMO, ASCO, they are great supporters of this concept of patient advocates, and they do incorporate patient advocates in their meetings at a reduced rate, some of them free of cost. And there are various fora in these meetings and in these societies for patient advocates. Next slide, please. So patient advocates have to be an integral part of cancer research. They should be involved in all aspects, but all this involvement will require training as well as education and evaluation of the impact. In India, there are very few patient advocates, and we actively need to engage to increase the involvement of patient advocates. Thank you so much.
थैंक यू सो मच डॉक्टर वनीता, बिकॉज आपने जो भी बातें करी हैं बहुत एप्ट हैं, बिकॉज इन चैट बॉक्स ऑल्सो वी आर गेटिंग सिमिलर काइंड ऑफ फीडबैक जो आपने कंक्लूजन में दिया है, और वी लुक फॉरवर्ड टू कोलैबोरेटिंग एंड वर्किंग टुगेदर एंड इम्पैक्टिंग मेनी मोर लाइव्स. And with this, now I thank you for having this informative and knowledgeable session and empowering us in terms of knowledge कि research में advocacy को कैसे काम करना चाहिए, and we look forward to be working together. And with this, now I would like to invite Dr. Vijay Patil. Dr. Saab is a medical oncologist, ex-TMH, and currently he is working with the Hinduja Hospital, Mumbai. And he's also director of Sunrise Oncology Center in Mumbai and Sunact Center. Dr. Saab, I would request you to now lead the panel and.
Yeah, so let me invite my dear friend Dr. Hasmukh Jain, who is a professor in Tata Memorial Hospital. Hasmukh, you are there. If you can just on your video. Dr. Sarvana, if we can, again, a dear friend, a surgical oncologist from Namakkal. If Sarvana can also on his video. Dr. Venkat Radhakrishnan, the head of Department of Medical Oncology at ADR and one of the pioneers in pediatric oncology in India. Dr. Srinivas Chilikuri, who is a professor and a senior consultant in Apollo Proton Cancer Center and an expert in proton treatments. Dr. Raman Rao, who is an active cancer patient, and Mrs. Urvashi Prasad, who is the director of Niti Aayog, New Delhi. Vivek, everyone is here?
Yeah, except Dr. Sarvana.
Okay.
He said that he's joining in a while. Urvashi ji is here, but she won't be able to switch on her camera, but she's here. And
Okay. So I can't see Dr. Hasmukh. Dr. Hasmukh is there?
He was there. Let me just give a call to him. He was there. Probably because of some network issue,
Yeah, okay,
he might have dropped.
So we will start. No issues. We can pitch in Alok. Alok is also there. I can see Alok. They also been there. So the first thing, and can we move the slides, Vivek, to the next slide? So
Sure.
the topic we are going to discuss is patient advocacy and the role in access to newer therapies. And let me start with asking Alok. Alok, how important is targeted therapy or immunotherapy in patients with cancer? How important do you think is that these therapies need to be given to these patients? Alok, you are muted.
So, am I audible now?
Yes, you are audible, Alok.
So like any treatment modalities which we talk about for treatment of any disease, we have to balance the efficacy and toxicity of those therapies. And there is how the research happens and development happens, that we move on from, as our understanding of the molecular pathology of a disease comes on, we move on from a therapy which is non-specific to a therapy which is specific. So when we are treating our patients, our aim is not just to give an efficacious treatment, but to give a safer treatment as well. And there is where the role of these targeted therapies and immunotherapies, which are based on understanding the basis of the disease, comes in, where we can give personalized treatment to the patients, hereby improving their treatment outcomes, but decreasing their toxicities so as to give them a right to good quality of life while they are on treatment. So they are utmost important armamentarium in our medical oncologists.
To summarize, what you're saying is that targeted therapies and immunotherapies are important. Let me
Yes,
go
sir.
to Venkat. Venkat, when you look at therapies like immunotherapies and CAR-Ts and targeted therapies from pediatric oncology point of view, how important, or hematology point of view, how important are these?
So I work in a charitable hospital, and patients expect us to cover everything, including targeted therapy and immunotherapy. So it all depends on the finances. When the hospital is paying, then we are looking for bang for the buck. We cannot pay treatments which are very expensive, treatment which do not prolong survival that much, that is statistically significant but clinically insignificant. Then in that case, the more traditional transplants and chemotherapy become important. But if you're in a setting where money is not a question, the parents are willing to pay, you definitely not deny them, because any treatment, even in few months, can prolong life or improve quality of life. Definitely should be given. So it has to be based on the patient, the sponsor, the physician. So it's quite complicated. There's no simple answer to that.
Okay, so what you're saying is that if finances are not an issue, if access, let's say that access to these new therapies are not an issue, you would prefer to do these therapies in your patient. Am I?
Absolutely,
Yeah.
absolutely.
Sarvana is here. Sarvana, surgery most traditional way of treating, and robotic surgery has improved things dramatically. Do you really think that robotic surgery where indicated needs to be provided to the patient?
Currently today, if you cannot apply robotic surgery to the entire spectrum of patients currently in its current form and the cost factor. But nowadays, see, earlier around 10 years ago, what we used to be, it was difficult for us to convince patients for laparoscopic surgery. Today, patients want laparoscopic surgery. And in our place, we are in a two-tier place. Now I am seeing people are asking for robotic surgery. So in 10 years time, probably the cost factor and the demand from the population, the patient population will match together. And at that time, I think it will be an ideal situation where everyone, because we have an Indian robot which has come into the market just in the last year, and it has decreased the cost of robotic surgery by almost half. And more, as just like your generic drugs for chemotherapy decreases cost of treatment, even in these high-end technologies like robotic surgery and proton beam, in time, all these will come into acceptance. Today, we do around 20% of indicated cases who really that robotic surgery is indicated in those patients. Only 20% of the patients can afford and take robotic surgery in our institution.
Okay. Okay. Now, let me come to Dr. Hasmukh. Hasmukh, you did the study for CAR-T. Now, do you think that CAR-T showed such excellent results in second line and beyond setting that this is a very important achievement?
Yeah, thanks, Vijay. Yeah, I think it is important because considering the kind of patients where this works, where with the current available options, the outcomes are so dismal that median survival is less than 6 months, that even if you have a 30-40% chance of cure, that definitely becomes a very significant improvement.
Srinivas, the medical oncologist has told the importance of neotherapies. Sarvana has stressed the importance of robotic. I want to hear from your perspective. In radiation, proton beam therapy is something which is new in our country. So what's your opinion that how important is proton beam therapy?
So Vijay, in general, all technologies are important, and therefore we need to know which technology has to be used at which indication and in which situation it needs to be used. And probably for expensive treatments, not just proton therapy, but all these expensive treatments, we need to know where it should not be used, where the value addition is very little, where the value proposition is very minimal. So, but all these technologies, including proton beam therapy technology, adds value to patients, in selected patients. Of course, in selected patients, all these technologies improve either direct cancer outcomes or they improve the quality of life of patients using them.
Fantastic. So what we heard from experts is neotherapies are important, whether it's surgical, radiation, or medical related. Yeah. And Sarvana also touched upon the point that in a setup, only 20% patients in whom robotic is indicated can have access to robotic. We had a study from Tata which shows that immunotherapy, targeted therapy only 3.8% can benefit. Srinivas, can you tell us some figures that if 100 patients, let's say they are medulloblastoma children and they need proton, how many of them in the country can afford proton?
I'm sure it is less than 1% of childhood cancers would probably would have access. I mean, I'm not talking about actually getting treated, but actually even coming to the proton center, I think less than 1% would be doing.
Right. Hasmukh, any ballpark figure that now we know that the study which you did with the IIT brought down the cost of CAR-T very I won't say very low, but substantially lower than what it was. But out of 100 patients who require CAR-T, how much would be the ballpark figure who could afford them?
Yeah, at the current pricing, I think about 5% would be able to afford this. Yeah.
Now, this is my next question to all of you, and we'll start from Srinivas, then Sarvana, and then Hasmukh can take the question. What are these hindrance factors? Is finance only the hindrance factor? That if the cost comes down, we can use it? Or there are other hindrance factors also?
So, Vijay, I'll not talk only in the context of protons, but I also talk in the context of radiation therapy or advanced radiation therapy techniques in general. And there are, as you rightly said, cost is one of the hindrance factor, but also the, because treatments such as radiation therapy needs prolonged stays. They are not single day treatments, although things are improving because of shorter fractionations. Also, patients have to stay in a place where they have access to better technology for a longer duration of time. I think that becomes a big hindrance factor for radiation oncology perspective. So I think the cost and logistics in terms of access, quick access or close access. The third being awareness, understanding where is the benefit and how much is the benefit and how to get that benefit is also very poorly understood by many of our patients, including physicians as well. And therefore, I think these are the three top hindrance factors.
Sarvana, any other point to add? He talked about very nicely. Cost is one factor, accessibility is one, and awareness. Any other thing which would you feel that would training of more doctors would better improve the access?
I would just add one point because I do a little bit of administration myself. See, when you have alternates for any particular procedure or disease, you have protons. What is the alternate for proton? Who cannot afford proton? You have an alternative which patients are going to choose. If you have in surgery, robotic surgery, if they can't afford, they're going to have laparoscopic surgery or they're going to have open surgery. It is not the end of the road. So as an administrator, we are willing to invest in technologies or treatments which are going to drastically change the outcomes of the patients. And as long as multiple, see now Apollo has proton, and if really you want to create an impact in access, you need more people in the country installing proton for it really to become accessible and to drive the cost down. So if we have blockbuster kind of treatments which are radically going to change the outcomes of the patients, most hospitals are willing to invest. It is because there are one administrator told me recently that 15-20 साल से हम लोग सर्जरी कर रहे हैं और ये robotic surgery अभी आया. What difference it is going to make? So unless the administrators and the people who are making these institutions also believe in the technology, I don't think it will go to the masses. You will have, yes, centers of excellence like APFCC, like Tata, who are investing in these technologies, but then accessibility cannot be guaranteed because a few people are doing it. So I want to say that along the way, if everybody is invested in a smartphone, mobile phone today, everybody has a mobile phone. When the technology is applicable to all people, then all these things will move forward. More and more people have to come up.
That's an interesting point. I thought you would talk about learning curve for surgeons. You talked about learning curve for administrators.
It is very easy. It is very easy to operate using a surgical robot. It is very easy. It is easier. It is just similar like open surgery. Laparoscopy is difficult, but the cost will make you innovate, right? So most of the people, Indian surgeons are one of the best laparoscopic and thoracoscopic surgeons in the world. We are one of the best. So when you have an alternative that is equally good or just marginally inferior, most of the people say, why I need a robot? I'm doing the same thing
No,
using.
fair enough, fair enough. So what you are saying is, unless it is dramatically improving outcomes,
Yes.
and then there's something like what CAR-T did.
Yes.
So let me go to Hasmukh. Apart from the price, what do you think would help the CAR-T programs in this country to come up and do well?
Yeah, so I think one would be, because this is personalized therapy here, there's a little bit of a different challenge that every patient would need a product to be manufactured for that particular patient. And even though you can scale up this whole process, but there's only certain extent to which it can be scaled. So, I mean, there need to be, of course, multiple manufacturing sites, either from the same group, or you preferably would need multiple groups, multiple companies, so that you can keep the manufacturing times within what is acceptable. That I think is one challenge. Second is, of course, is the training, because this requires transfer of skill sets. This requires transfer of SOPs, and there is a learning curve here, particularly for some of the complications which are not very common. So you need to treat at least 50-60 patients before you see the whole spectrum, and then you're ready. Because in some of the complications, like in hemophagocytic syndrome happening because of CAR T-cell therapy, your rapidity of response could decide whether the patient will survive or not. So these are the parameters which will actually help us improve the access.
Okay, so that's good. That's a learning curve, and manufacturing should increase.
Yes.
So let me ask to this questions, and let me come to Venkat for this. Venkat, does this happen often in your institute, that you know that the patient cannot afford it, and let's say that the treatment is blockbuster, you know that, let me give an example of osimertinib in EGFR mutant, or lorlatinib in ALK. Does it happen that sometimes you even don't explain the options because the patient should not feel bad that he does not have the money, so he cannot afford that treatment?
We used to do that in the past, but in the current scenario of medical, legal, and all other issues, we do tell the patients whatever available options are. Things have changed now with the consumer protection. It's very difficult to judge who can pay and who cannot pay. Suddenly, the patient might turn around and say that if you had told me, I could have afforded it. So we do tell that these are options, but they are very prohibitively expensive, and give them the choice whether they want to take it or not.
Now I have a question for Srinivas, Sarvana, and Hasmukh, all three of them, and then I'll go to the Mr. Raman for this. Now, Vivek, can you just put the next questions on the slide? Can we rationalize these therapies? So we know that in few situations, let's say not in all, but in some situations, these are absolutely important. Let's say for a transplant in a primary refractory Hodgkin's, or in a medulloblastoma, a proton, or a robotic where Sarvana feels that, okay, this in this patient is going to benefit, or a CAR-T in a second line in ALL with CD19 positive. Can we have some rationalization where we could deliver this even to those people who cannot afford it, that we don't have financial discrimination here? Do you think, is this possible in the country, or this is not at all possible? We can start from Srinivas.
Yeah, it is possible, Vijay. I think we should have some bare minimum indications for all these expensive technologies which need to be responsibly used. And therefore, the insurance and the governments and, all these agencies can reimburse only those key indications. It is easier said than done, because obviously, there will be a tendency to keep many things in this, and very difficult to extrapolate results from the West directly into India. But I think straightforward indications should be rationalized for these expensive therapies.
Sarvana?
We, because we are a small organization and we are in a remote place, we use CSR a lot. So for example, if I know a prostate, for example, or a sleeve lobectomy, a case where you need to do an anastomosis, these are very complex operations to do by open surgery or by even laparoscopic surgery, a perfect indication for robotic surgery. So what we have partnered up with a few NGOs is, okay, there is a need for these patients. So we match, okay, they pay for this, and we use CSR to bridge the gap of these treatments. We are trying to...
You are already rationalizing the therapies and your own way.
We have a mechanism in which we have a committee which decides. It's not like as if I am a surgeon, I want to do more robotics. So I have to put my patient to that board, and the board will rationalize whether
Correct.
this patient really deserves, and then the CSR comes in. So the CSR
Correct.
is telling, sir, only if you have a board committee which is deciding on the particular case, we will give you money. People are there to give you and support money for many causes, and this is how we bridge that gap.
So let me jump on to the next question and let me get Dr. Rao here. Dr. Rao, so do you think a committee, like a patient advocacy group formed by experts and with patient involvement and with administrator, and I would want comments after Dr. Rao, Mrs. Prasad also, would help to make a broad program kind of thing? Okay, these are neotherapies. These are absolutely essential in this situation, and if we get recommendations from patient advocacy groups or a group which has patient advocates, experts, and then we can think about having a program to subsidize this substantially or provide it.
Hello.
Yeah, you're audible.
Yes, sir, we can hear you.
I'm Ramana Rao. Can I speak?
Yes, sir, please.
By the way, I am not a medical doctor. I am a professor in engineering.
Okay.
And it's very rare that a cancer patient is ever given a chance. Even here, you have given me the last opportunity to speak.
No, so the rest of the questions are for you only.
I'm actually a cancer patient who is waiting for, expressing our concerns to a forum like this, whereas it's a very rare case. And I represent thousands of people. And actually, 16 years back, I had a surgery for my kidney cancer. And I was all right for 10 years. Then suddenly, in 2006, I had 2017, it has become metastatic. It has gone to pancreas and other places. At that stage, the doctor decided to give me targeted drug. So I've been using RCC for RCC targeted drug since last 6 years. And I'm very happy to say that I got excellent result. So I'm a practical case. It's not just a theory about it. Definitely, it is a little costly, but then it is still something that saves a lot of trouble, a lot of effort. It's a very long process, the curing of cancer. So what I do is I regularly send my record online to my doctor, and he gives me online advice. So there are two things which I want to just advocate for. Number one, doctor should have definitely confidence that targeted drugs are useful and it can be given. And second thing is that there are so many new drugs coming. The last 10 years, plenty of new drugs have come, just like your awesome markets. And people, they are much better in their approach. And I found very few doctors actually recommending these things on the pretext that they are costly. Well, I think the cost of this drug compared to the cost of surgery and all that effort is not that big. And the only method for reducing the cost of it is to advocate it with the government to accept it as a part of HBA so that more people will start using it. Now it is not even covered by insurance. So if it is covered by insurance, it becomes easier for people to get, more people will use, and due to economies of scale, they will become, less costly and cheaper. So I'm advocating mainly for this. And the second thing, if you care to listen to me, is there is no record at all digitally available for any patient. You see, unfortunately, most of the hospitals, except very few, have no digital records. Then it becomes impossible for the doctor to give advice from a longer distance. And digital records help us not only simply for the patient, but to reduce the doctor's time. They got excellent clinical support systems, which can help the doctor himself. And, the effort should be to reduce the time of the patients and improve his quality of life than simply having hundreds and hundreds of patients' footfalls in the hospital premises. So that's what I wanted to convey. These two I've been advocating since last 3 to 4 years. Well, with very little outcome as usual, because as an individual, I can do very little. But I've been counseling patients and all of them agree. Even doctors said, please go ahead with advocating this particular case. Then only the result will come. Thank you, sir.
Thank you. Urvashi ji, your thoughts?
Yeah, so I mean, I'm, also speaking as not someone who's just, policy person, but I'm myself a trained public health professional and also someone who's living with stage 4 ALK positive cancer. So I can, speak from all these different perspectives. And, I would say that it definitely requires a collective effort. I mean, there is no doubt that, governments obviously have a huge responsibility in this space, and there is a lot that governments can and should do. I think that is definitely something that we can never get away from. But of course, the governments have this challenge where in a lot of the cases, we are starting, and we have started even in the last few years, still from fairly fundamental levels, when it comes to cancer care. Even certain basic treatments are still not accessible to people in many parts of the country, let alone, the extremely targeted therapies that we're talking about, like lorlatinib, which is, also a drug I'm on. So I think, it's for governments, it's really starting from that very basic and building up. So I think that is something that will always remain a challenge for a country as large as ours. So I think it's multiple things. It's obviously government, but it's also obviously trying to find as many cancers as possible at earlier stages, because then, as we know, that treatments are much easier, less expensive. The cure is much better. Of course, in my type of cancer, 90% of the times it is detected at stage 4 because, you don't have any kind of regular screening or risk factors for this. And so, in certain cancers, we can't help it, and they are diagnosed at a metastatic stage. So that, of course, makes it very complicated. But in the cancers that we can, we should obviously try to catch them as early as possible. That will always remain our best bet in a country as large as ours. We cannot afford to have millions of people coming to us with stage 4 cancers. We'll never be able to have enough money on the table for that. So that is why, the prevention aspects, the early screening, that is where a lot of the thrust of the government has to be. And that is some of the discourse that we've been trying to shift in the last few years. Then, of course, I think, even insurance, pharma companies, they too have a responsibility in terms of, like
insurance. Because these issues on the next slide.
Yeah. So, so insurance, because I personally struggle a lot with my insurance and what they reimburse and what they don't reimburse. A lot of them are not even aware of these newer treatments. For the longest time, they would keep calling my targeted therapy as chemotherapy. And so they would, not be able to even understand what is the difference between chemotherapy and targeted therapy. So, we're still grappling with these very, very basic, and this is for someone like me. So you can imagine what it would be for the majority of people in the country. So I think even the insurance companies obviously need to get their act together and need to upgrade their knowledge. And need to make sure that they have knowledgeable people on board to take these calls, in terms of treatments, etc. So that too needs to be done. And that is also something that we're trying to work on. So I think it has to be a collective effort for something which is as difficult, complicated as this. It cannot be any one entity which will be able to solve for it. We'll have to combine efforts from all the different stakeholders. Thank you.
Absolutely, absolutely correct. So one of the questions which we wanted, and Vivek, can we go to a slide back? Is now there's Alok here. Alok, do you think participation in research can improve access to these drugs?
So definitely. So one of the hindrance when we discuss these lot of neotherapies is that most of these are done not on Indian patients. So to justify, so there are a lot of resistance which comes that the results or outcomes might not be applicable to the Indian population. So a research first will make that doubt clear that yes, this works in this type of population also, Indian population also. Secondly, the research will make it accessible to more and more patients as a part of the research, and that will increase the awareness of various support groups, the government as well. So the research definitely will act not as the only thing, but act as a part of the collective effort to improve the access to these treatments.
Okay, fair enough. Dr. Rao, do you think patients, if given an opportunity to participate in research in which these newer drugs are been getting access, would be happy to participate? Dr. Rao, you're there? I can see Ganpati ji there, and I can ask this question to. He's also in. Ganpati ji.
I'm available, please.
Yeah.
Hello.
So go ahead, sir. Go ahead.
I'm 84, so I need a little bit of time more. No, definitely it will help. First of all, as the other doctor said, patients should know that there are new technologies. For that, there should be sufficient amount of, there should be some organization like social work department, because doctors do not have time to explain all these things. You hardly have 3 minutes to spend to a patient. So a good social work department can give the various options that are there, and I'm sure number of patients will definitely choose. In my case, that has happened. I was told about it and I said, yes, okay, I'll find money to spare for that. And then surprisingly, my case was registered as a research case, the drug supplier is supplying it free of cost for me since the last 4 years. Because they need data and I'm able to supply regularly. I keep my data completely, all test data, everything in graphical form, and keep on posting them. What are my actual blood reports, LFT, all the different reports, and my personal, physical phenomena. And these things definitely help a lot.
Agreed. Ganpati ji, your thoughts?
Sorry, I came in just when you uttered my name.
So we are talking about access to newer therapies. Many of them are costly. The question is, we know that we cannot have a magic wand and increase this access immediately.
Correct.
So would patients be happy if they are given these newer therapies in research setting?
I think that's the big challenge also. And I think, it depends on the patient's level of education, level of literacy, etc., to understand what the trial is. Because when they join, they think this new medication is going to help me and I'm going to come out of the disease. It might not be the case in many situations. So I think a very honest communication. But yes, as a treating doctor, we must keep the options open. But as I told you, even though I'm a PhD, if a doctor has to tell me something, I'm vulnerable. I'm going to believe the doctor more than my own thing. So, and hence, the doctor should play the cards very safe, and you must say that this will help. We are trying to find out whatever is the outcome of this. Okay, and we are very happy that you will be contributing to the society through your participation, is what we would look at. I think there is no, what do you call, a blanket statement that I can make that yes, all the patients will be happy to do that. Nor can I say that nobody will do it. It's not the question. It requires a lot of counseling, and that's one of the things that we do in our NGO. Besides the fact that we give them a lot of information about the disease and the new therapies, etc., we also tell them that what should they be considering the pros and cons of this. And if you're getting somebody who is absolutely illiterate, does not know anything, then I think, I don't know whether we are doing really a great thing or a harm that you're doing is what we're supposed to look at. That's my thought.
Okay.
Sorry, Vijay. I don't know whether I said it correctly.
No. Your thoughts are welcome, Ganpati ji.
Thank you.
You and Dr. Rao suggested is that communication, if done properly, then you could have more. My question, this is to Urvashi ji. Urvashi ji, can we think about having patient advocacy groups which actually can, with the expert, think about which are the therapies which are required and they cannot be regularly covered in Ayushman Bharat, and can Niti Aayog help us with development of such advocacy groups?
Yeah, I think, I mean, there are obviously, I think there's already some groups which exist, but we need a lot more, definitely. And I think, I mean, a lot of the times our efforts are focused at the national level, and that is obviously fine because a lot of the decisions, especially for centrally sponsored schemes like Ayushman Bharat, etc., are made at the central level. But I think sometimes we forget the state government level, which in a country like India is just as important, sometimes even more important. There have been states where the central government is only providing X amount of support, but the state government is further topping it up with a lot more support from their side. So we need to also push state governments that you also need to do your bit, and not just rely on the central and the central sponsored schemes. So I think that those efforts of advocacy need to be not just at the central level but equally at the state level, because that we can perhaps make a bigger and quicker difference. Things can happen more quickly at a state level than perhaps even at the national level.
Fair enough, fair enough.
Vijay,
So,
quickly
Vivek,
add,
yeah, Ganapati, sure.
to quickly add to this, the umpteen number of support group that we have been having online can be channelized as one of the point to have a very focused interventions of advocacy group, and it's very important. Having said that, to each individual, his disease is his own, his experience is his own. So I think we should also be able to empower that support group by talking about what happens, when we have an advocacy group, what are we advocating for, why are we advocating for, and how does the society at large, come to win in this situation, is what I think we should do. I think we should focus our support group. Vandana Mahajan's support group meeting is what we have to look at. Thank you. Thank you.
Correct. Correct. So I think, Vivek, what has come out is that neotherapies are important, and there are certain neotherapies which actually change the course of life. At present, we have efforts like what Sarvana is doing at his level, Srinivas is doing at his level, Hasmukh is doing at his level. We have individual efforts which have been done, but we need a cohesive platform where these efforts can be taken care. And I think we should have a white paper coming out of this, where we should think about volunteers who can come over the board. We would need much more patient advocates, and probably one advocacy group is not going to help. We might need a separate advocacy group for head and neck, a separate for lung, a separate for every site, so that there is that information. Even experts nowadays are experts in one cancer, and the same expert cannot be there everywhere.
Right.
So we would need such multiple advocacy groups which can then talk about patient rights, and that voice might be much more stronger than only us among doctors speaking amongst ourselves. With that,
Absolutely.
I thank all my panelists. I think I have grossly overshooted the time which was given to me, but it was a lovely panel, and I learned a lot more new things and more point of views today. Thank you all. Vivek, over to you.
Thank you, Dr. Saab. It was really quite an interesting and knowledge empowering session, because जैसा आपने बताया कि advocacy group के बारे में, and we on this platform I would like to share that we started an initiative called Space, a safe space for cancer patients, and we'll be kind of cohesively working together, and I'll be coming back to you for the integration. And let me share that Urvashi ji is kind of mentoring us in that initiative. The idea is the same, that we identified the the gap that has to be bridged. And now let me move to Dr. Akhil Kapoor. Dr. Saab, namaskar. And it's always a pleasure to see you. And without wasting time, I would like to introduce Dr. Akhil Kapoor. He's officer in charge, Tata Memorial Hospital, Varanasi. And Dr. Saab is going to take us through the role of advocacy groups in the management of public funded hospitals and setups.
Thank you, Vivek. Thank you, Vijay sir. So let me share the slide. We have an expert panel consisting of experts from throughout the various parts of the country, including from Northeast Assam, Dr. Venkat, and from Team Sangru, Dr. Alok, then Dr. Amit Agrawal from the Central of India, AIIMS Raipur, then Amol Akhade sir, my favorite from Mumbai, and Dr. Atul Batra from newly formed AIMS Hajjar. Apart from Dr. Kushal Gupta, who was my senior at TMH and now working as a medical oncologist at AIMS Kalyani. So, yeah, so I would like to share my slide. Please allow the same. Yeah, thank you. So, a very important discussion just happened about the importance of the various advocacy groups and the importance of how to support treatments, which includes costlier treatments, including targeted therapies, robotic surgeries, and proton beam treatments and CAR T therapies. So that was very important to see that all the experts are coming to a single consensus that yes, these are important to be incorporated for the best possible outcomes for our patients, including the quality of life, not only the efficacy. So I would like to start with Dr. Amit Agrawal. Dr. Amit Agrawal, I would like to get your comments. So you have got settled at AIMS Raipur now, and what do you see? And when we were working at TMH Mumbai, now you are at AIMS Raipur. What differences and challenges you face, which are completely different from the work which we were doing at TMH Mumbai?
Thank you, sir. So, sir, there is a lot of difference which I noticed and found while I am working here, because ours is a newly established center where the department is new. The things are not that streamlined, because we know that cancer treatment just not comprises of surgery or chemotherapy or radiotherapy or immunotherapy. It's a whole process, starting from the disease diagnosis, and even before that, the screening and the awareness amongst the public, then treatment, obviously, then palliative care, support. So patient support groups and the patient advocacy groups, these play a very vital role to streamline all these things, because patients, especially in our the countries like us, patients are many a times illiterate. They have so many constraints, like financial constraints. They have limited place to stay. They travel from far distances. So these challenges ultimately, they because of these challenges, the patients are not getting proper treatment. So these advocacy groups and support groups are very much needed, and probably over the period, the government and the policy makers will realize the need for these groups in each and every hospital, whether it's a government funded hospital, public funded hospitals, and that's the need of the arts, sir.
Yeah, thank you, Amit. So you beautifully summarized the important points. So this is an important problem. Though the treatment might be available, the importance of proper follow-ups, proper reach to the patients, and making the patient understand is very, very important, and seems to be easy on the outside, but when you start working on the real work front, it seems to be actually difficult. Now, coming to Alok boss, Dr. Alok, you got settled at TMS Sangrur, which is a newly, comparatively a very new setup, and now the footfall of patients is significantly rising. Now, how do you see the role of advocacy groups for improving the patient care at your center?
Thank you, Akhil. Thank you, Vijay sir, and all for the invitation. So, very simply, I would just want to say what I understand advocacy group is. So, for me, an advocacy group is something, any intervention or anything which is making the patient's journey through his treatment easier. So, that to me is an advocacy group. It can come from anybody who is helping the patient to understand the treatment, improving access to the treatment, making his compliance better, making his follow-up better, acting as a bridge between a doctor and a patient. Anything, it can be a medical social worker, it can be a keyword which we have at our centers, it can be any volunteer which is coming. So anything which is, so this is an essential part, as Amit told, that it's not a single person who can treat a disease. This is a multifaceted treatment, and how much our treatment is effective is dependent on how much the patient understands our treatment, how much he can assess the treatment, and how compliant it's for treatment. So advocacy group is as important as the treatment we are providing to have the outcomes which we expect from the treatment, which we see in clinical trials. So we have to have that outcomes in the real world to make it accessible. Advocacy groups are very, very important.
Yeah. So it is now the answer seems to be loud and clear from Dr. Alok that advocacy groups are actually very important, and it is anything which is helping the patient to start and continue the treatment journey, and it able to take the journey comfortably. Because what happens, it's very distressing for a patient to get first diagnosed with a cancer. It is a very big challenge at that point, and at that time the patient and the family is usually very devastated, and they are not able to understand what might happen in the subsequent steps. It becomes very difficult. First, understanding of the treatment, the stage of the disease, then the treatment perspective, all seems to be very much difficult, because this is a difficult disease and it has significant effect on the mental health of the family as well. So it's not only the patient's problem, it's the caregiver journey is also very difficult. And we understand that, yes, the caregiver burnout is also very important, and we have seen that. And now we have started a study on caregiver burnout, caregiver fatigue as well. So that is very important to understand in the busy setups where the caregivers have to do a lot of work and take care of the patients. So I would like to take comment from now Dr. Kushal. Kushal was, if you are available for comment. Now, you can see that new setups are coming throughout the country. Multiple AIMS Institute, multiple new TMS setups are coming up. Now, sometimes patients, those who are somewhat affordable to travel, they are always in a hurry to travel to metro cities. Instead of taking the treatment which might be available at the local place, they always want to rush to the metro city for getting treatment, because there is a sense of belief that there might be better treatments. So what should be done? How should what might be the role of advocacy group in this, and how should the things will change? What do you think?
Dr. Sab, I think Dr. Kushal and Dr. Amol Akhade could not join.
Okay.
Can I reply this, Akhil? I may not be doctor, but as
yes,
a group, can I do this?
Yes, please go ahead.
Okay. So I'm going to take only TMC Varanasi as an example, because we have exodus of patients coming in, especially thoracic and head and neck patients. I don't know if they're coming to the city for what reason exactly. But in palliative, when I ask them, or even for that matter, early palliative care, when I go and meet the patients, one thing I get to hear, I'm very sorry to say this on a platform like this, but I think as somebody who's now so much wanting to create a advocacy group, you must know this as to why they are marching the thing. So हर बार मैं उनको पूछता हूँ, the answer that I get is, I tell them, you people are taking so much trouble, with your bare minimum money that you got, you're selling your establishment, one person is here, half the families are there, double establishment have to be done. Why are you traveling to Bombay? I mean, it's not that you should not be very happy to do, but when you have a facility, such a nice facility, within 100 kilometers, as close as that, so you could save so many indirect costs, and you can also concentrate on the, the wellness of the patient. And flat, they give us one reply telling them, sir, हमको बम्बई आना है क्योंकि हमें यहाँ पे इंसानियत मिलती है. This is the answer that they give. So therefore, I think as a torch bearer of this, advocacy, a lot of thinking has to go behind not only the physical structure of the advocacy, but why the advocacy is being aimed at. And when you're looking at quality of life as a whole, then how this advocacy group is going to play a role in various aspects is what I think some kind of assurance of patients is what has to come from all of you.
Yeah, so it seems that the social support is very, very important, just beyond the providing the quality treatment. So the counseling, proper somebody should be there to hear the patient and their family properly. And that's, I think, most of the centers which are newly set up, they have a poor infrastructure in terms of the social support and medical social worker department. That seems to ramp up. And I think we should take this point to our authorities and administrative teams that social worker team needs to be strengthened at all the centers which are getting newly developed, because these are the heart of the patient support, and whatever the best possible treatment a doctor might provide, it has to be guided properly. It has to be uh, the patient should be able to share their problems with the social team and talk their heart out. So that is an important point.
Akhil, I'm not a panelist over here. Can I come in if the organizers permit
Sure,
me?
sure, sure.
Yeah. So, see, as an oncologist, what I feel, so we have been trained in Tata, and now see, lot many patients go in private. So, if there is a uniformity of treatment, we can guarantee, and patient is assured whether he's treated at metro or at his native place. If there is a guideline, we all follow together, and if there is a uniformity in it, I think that fear, no, going to Mumbai will have, as he rightly said, no humanity and other factors. Because see, the Tata Trust has built over a period of decade. So, and now we are going to the no places, and after COVID, the healthcare also strengthened in the rural or 2, 3 and 3 tier cities. And the word cancer comes with a lot of fear, right? Everybody wants the best possible things. So if you have a guideline and everybody follows the same guideline across the institution, I think that is one of the important factor which can no lead to getting down this fear, and people will start treatment at native place rather than rushing to the metros.
Yeah.
Akhil, Dr. Akhil.
Yeah. Please go ahead.
Dr. Alok here. So I agree with Dr. What Venkat sir said and what Ganpati sir and what Bharat sir said. But I said that if we take a DMS as an example, it has been 75 years. It is a pioneer always in the cancer treatment, and a new center which is coming will take time to get to a level and a trust building which will come. But definitely, if as Dr. Bharat sir said, the treatment protocols through NCG now are getting uniform throughout the country. And when you will talk to the patient, the trust which you can give to the patient, the confidence which you shows in the patient, and then as you said that the medical social worker, the patient navigation which is there, the ease of treatment. So one is treatment, one is the ease of treatment which you can give at these centers. If that is even lesser than what it is in TMH Mumbai, the hassle of traveling to Mumbai, we can have a lot of decentralization which can be done, and which we are seeing now with Varanasi and Sangrur and Mullapur. We are seeing that a lot of patients which are going to Mumbai are coming because now when they talk to us and the trust and the type of treatment which are able to provide here, the exodus has definitely decreased now, and that trust need to continue as TMS has made, and that advocacy groups helping and telling the patient, counseling them that yes, the treatment could be equal, and the patient should see it in the ground that the same is happening. That will help in making that a reality, and the decentralization which we are aiming for to give the treatment at the doorstep.
So it's very clear that this confidence builds up over time, and this is a mouth to mouth. As for we say for any commercial product, we say is a mouth to mouth publicity. It is mouth to mouth conviction which goes through the institute as the institute matures actually. So I think that is rapidly coming up for some of the centers which have now established in the last 5 years. Hopefully, this will be helpful for a large number of patients. In fact, what happened, what we see now, the number of patients at TMH Mumbai have not decreased, but these patients who are now coming to TMH Varanasi or Sangrur or Muzaffarpur, they were never able to reach Mumbai. So we see a lot of those patients also, those who were not able to reach any of the dedicated cancer centers, and they are now able to get a quality care. Hopefully, this can improve further over time. And again, here comes the role of advocacy group to guide the patients, to guide their relatives. And as it was discussed in the last panel as well, that it is important to form a advocacy group disease-wise, like we have started doing for lung and bladder cancers. Similarly, head and neck advocacy groups are coming up. So these will be pioneer, and this will be very, very important to set up the context and bring out the best. So now let's take a comment from Dr. Atul Batra for barriers of comprehensive care at Tier 2, Tier 3 cities. Sometimes it is difficult, but what are the actual barriers and what should be done? Dr. Atul, are you available for comment?
अतुल ये ठीक कर लो, ब्लूटूथ ऑफ कर दो।
Dr. Atul? If not, I think I can ask this to again to Dr.
He's
Amit
there. I
Agarwal.
think he's facing some challenge related
Yeah,
to.
yeah. Dr. Amit, now what are the important barriers? I think you put a small comment on in during your answer to the last question that there might be some barriers. Can you highlight those barriers and what could be done to tackle those barriers?
So, sir, as I told you, it starts even before the diagnosis because in tier 2, tier 3 cities, we generally get patients, especially in setups like ours, public funded hospitals, who are not that much literate or many are illiterate. They have financial constraints. So, the lack of awareness amongst the public, which precludes them from reaching to the hospitals, it is one of the greatest barrier which comes and it leads to a significant impact on the quality of life, impact on the journey of their cancer treatment. So probably advocacy groups can help in this regard. They can create these awareness camps, and they can create they can actually influence the policymakers and the government administration to create awareness amongst the public regarding the early diagnosis, regarding the screening of cancer, and they can make them aware about reaching the hospital on time. They can make them aware about importance of compliance and follow up. So these are one of the challenges which we regularly face. Apart from this, financial constraints are always a problem. So, but now we have various government schemes like Ayushman Bharat. Like in our state, the Mukhyamantri Vishesh Swasthya Sahayata Yojana is there, which can give up to 20 to 25 lakhs if the needed and if it is justifiable. So, but many patients are actually not aware about these schemes. Many who are actually who can actually avail these treatment, but they are not aware. So, make them aware about these schemes because there is a lot of fear about the finances, the distance which they need to travel, their place to stay in a far away distance. So and also these social support groups can influence the policymakers to streamline these available schemes. These schemes are available, but many those are actually who are in need of these services cannot avail these treatment because of some probably किसी का राशन कार्ड नहीं है, किसी का कोई आधार कार्ड नहीं है. So because of lack of these things also, so we need to streamline these things as well. And also, as I told, the role of social workers, the policymakers and the institute administration should be very much important services like social worker groups should be available in the all the hospitals.
Yeah, so it's very important that sometimes patients do not have the knowledge that they can apply for some of the funds, some of the schemes which are already available in the hospitals and in their states or at the central level. So it's very heartening that most of the time at our center we have now a dedicated lung support team actually available with me throughout the OPD, that all the patients who are consulting us, they are at the same time, just after consulting the doctor, they are being counseled in detail about the various funding options, various treatment options, and apart from that, the government health schemes which might benefit the patients. So I think that is one of the way to improve the patient adherence, because you might talk of the most advanced treatment options which are available, but if it is not financially feasible, the patient is not going to come back the second time itself. And in spite of thinking and doing best on your part as a doctor, the patient will have a poorer outcomes because there will be no good follow-up. So here now I would like to discuss, I come to Dr. Venkat. Dr. Venkat is doing an excellent job at one of the corner of the country's northeast, which was initially significantly lagging behind, but now with the setup of the cancer foundations and the funds with the help of Tata Trust, I think that has completely changed the ball game in the Northeast states. Dr. Venkat, your comments, how you are coping up and how the advocacy groups can help you further.
Yeah, Dr. Akhil, good afternoon. So happy to see you. Yeah, so I sit in an area, Tejpur, it's quite far from, even in Assam, the Assam is a very large state, so very difficult to access. Till 2 years ago, till 2021, there are only two districts which have main facilities for oncology treatment. The Guwahati, the Kamrup urban area, and Dibrugarh. They are the two extremes of the Assam, and most of the people have to travel like 8 to 10 hours even to get a single chemotherapy or any investigation for that matter. Now, Assam Cancer Care Foundation is opened by Government of Assam in collaboration with Tata Trust, 7 centers across the Assam. I work in Tezpur, which is adjacent to Kaziranga National Park, and believe me, although it is integrated, it is really the capital, cancer capital of India. So here, I in a small center like in Tezpur, I see on an average 5 to 10 new cases of various types, which is really high for such a small center. So when we come to this question of gaps on the patient side for proper follow-up, yeah, there are so many. The first factor is the awareness. For example, while I was working in Delhi, women finding a small lump in the breast will come for mammography screening or to go to a physician. But here, the women, there are some of the women, I'd say I cover 5 districts in Assam and some parts of the Arunachal till Tawang, the China border. So all these patients, they have this hospital at the nodal area. So they seek opinion from here. Previously, they used to go to TMH, CMC Vellore, Apollo Chennai, etc. Now, one of the most important thing lacking is awareness. As one of the previous speakers is telling, the prolonged treatment, if it is not discussed initially, they think that after surgery, adjuvant treatment may not be needed, and they default. And and awareness among the doctors is also very much lacking because so many patients operated for simple cholecystectomy have gallbladder cancer. They do not collect the HPE report. After 1 year, they come with a metastasis. When we ask for the surgery, when we get the report, it's actually malignancy. So they didn't follow up. So educating the patients, educating physicians, because initial contact for many of the patients are these primary physicians in the picture. So not treating breast cancers on FNACs, to do ERPR, how to at least. So practicing basic minimum standard of care is also challenging in the picture. In the initial 6 months, majority of patients didn't believe that chemo can happen in their hometown or in the home district. So they used to come to us, talk to us, and then go to TMH. So what I used to do is, I used to write the opinion. This is my plan. As Bharat sir said, uniformity in the protocol. I used to say that this is the duration of treatment. This is the chemotherapy we are going to give. This is the duration of radiotherapy. This is the surgery we are going to offer. You go there, show this to the physician, and if it is same, if you want to take here, discuss with the physician in TMH that oncology facility is available here. And many a times we get the referrals back and they take treatment with confidence. So that's how I think we can close some of the gaps. And if we discuss only treatment, only 30% of patients will have compliance. So we need to take into account so many factors, particularly in the periphery, like the distance from which the patient is coming. So if the patient is coming from Tawang, if we want to go to Tawang, we will plan for 2 days. How to go there, where to stop and all. So if the patient, unless we take this factor into consideration, if the patient has to come we offer a weekly chemotherapy, we are sure that we are going to lose the patient for follow-up.
Completely agree.
We need to take into the type of protocol given, the toxicities, because in those areas, there is a patient from Tawang near the Chinese border. There is no PHC even, very difficult. There is no CBC facility as well. So we should not give very toxic protocols where patient may succumb to neutropenia. So taking these factors into consideration is really important, while taking family source of income, because there may be 2 to 3 patients in a single home and a single earner, and social aspects. So initially I used to tell so many things to the patient. Now first 10 minutes I listen to the patient. What is the main concern? So they one of the main concern religion is about biopsy. So biopsy करने से फाइल जाता है क्या करना. So uh, so there comes the role of advocacy group. So what I do now is I give the phone number of a woman who was treated for breast cancer, and they who actually regrowing her hair. So they tell about the course of the disease. Initially, I lost the hair. Now I am getting my hair back. So the patient gets belief. Okay, it's a process that I will lose hair, I will get it again. So, but the disease will be curable. So all these things will play a lot of role, I think.
Yeah, so beautifully summarized, multiple points covered by Dr. Venkat. I think so. What is important is advocacy in each and every form. We might not think that it is actually advocacy, but it is everything. Such steps like giving contact details of a previously treated patient who might guide the patient is also a part of advocacy. So this is actually very important, and taking consent from the patients who can act as a guide, who have completed treatment, act as a guide to the subsequent patients. This is also important. It is a small form of patient advocacy itself. So these small things will change lives of a large number of the patients. And as we can see, till now, around 7% of the population who is reaching at the age of 75 years is getting malignancy in India. And this is expected to increase to 10% after 20 years. So it is a very huge numbers of cancer is going to come up in the next 2 decades, and we need to prepare for the same. We need to have better advocacy groups, better lifestyle support, and better and we need to focus on close the care gap. This is the tagline for this year World Cancer Day. Hopefully with the availability of many new centers and better facilities, this will be feasible. And the most important thing is what I see is that India is now becoming the hub of randomized cancer clinical trials. I always highlight the fact that this should be highlighted through various advocacy groups, that participation in a cancer trial is not bad. It is the most recommended point in any NCCN guideline. Be it any guideline, you will see the first best possible treatment is patient should be offered to participate in a clinical trial. So this should be a message in the discussion during any advocacy group meetings. And now, for just to give a perspective, we have now 7 clinical trials in the first line treatment of lung cancer. So that paves us way to give the quality treatment which is affordable, because it is not out of the pocket. Even if the patient does not have any reimbursement, the patient can get the treatment most of the time free of cost, and that is one of the standard of care treatments. So I hope that more and more centers can adopt this practice, and through the advocacy groups we can empower our patients to do much better outcomes. I hope I could do justice. I would like to stop here. Thank you.
थैंक यू सो मच डॉक्टर अखिल. एंड आपने बड़ी अच्छी बात बताई कि आने वाले 2 दशकों में जो है कैंसर के प्रेवलेंसेस बहुत बढ़ने वाले हैं. एंड हम दोपहर से देख रहे हैं कि बहुत सारे एडवांस ट्रीटमेंट्स हैं, बहुत सारी चीज़ें हैं. इसकी वजह से लाइफ जो है वो प्रोलॉन्ग हो रही है. जहाँ लाइफ प्रोलॉन्ग हो रही है वहाँ क्वालिटी ऑफ लाइफ भी बहुत इंपॉर्टेंट है. और जैसा कि हम सब बॉलीवुड फिल्में कभी ना कभी देखा होता है हमने, और देखते हैं डॉक्टर कई बार ऐसा बोलते हैं कि भाई अब तो इनको घर लेकर जाओ, इनका कुछ नहीं हो सकता है. लेकिन उस स्टेज को बहुत एम्बिगिटी है आज भी. कुछ लोग एंड ऑफ लाइफ बोलते हैं, कुछ लोग पैलेटिव बोलते हैं. काफ़ी सारी कंट्रोवर्सीज भी हैं और काफ़ी सारी मिसअंडरस्टैंडिंग या अनअवेयरनेस भी कह सकते हैं कि वो है. हालांकि अवेयरनेस जो है धीरे धीरे बढ़ रही है. और इसी सिलसिले को मैं आगे बढ़ाने के लिए इनवाइट करूंगा डॉक्टर नवीन सालिंस को, जो कि एक फिजिशियन है. डॉक्टर साहब, प्लीज टेक द लीड सीट एंड इनवाइट योर पैनलिस्ट, एंड लेट्स कंटिन्यू द डिस्कशन.
Thank you, Vivek Sharma ji, for giving this opportunity. And for this panel discussion, we have 4 panelists. One is my very good friend, Ganpati sir. We work together at Tata Memorial, and he continues to support us. He is the CEO of JASCAP Foundation. The second person, I know her very well, is Dr. Smriti Khanna, who is a physician like me who has transitioned into palliative medicine, was working in Wardia, now working at Hinduja as in a private cancer center. Dr. Biji works as a palliative medicine specialist in a cancer setting in Malabar Cancer Center. And Manali works as an intensivist and has keen interest in palliative care in the ICU. So we have a really diverse group of professionals who would speak on a common theme where we will touch upon advocacy in several settings that are there. Vivekji, is there a patient or a caregiver representative for this panel?
He could not join, Dr. Saab. Actually, he was willing to, but he could not.
Yeah, no problem, sir. Yeah. Okay. So I'll start with Ganpati, sir. Sir, your advocacy work in India has been mainly through disseminating literature in various language through JASCAP books, which is very popular across India, and which has been, I felt, it's very successful initiative. So can you briefly share your insights about this work?
Sure. Thank you very much, Dr. Naveen, for all the kind introductions. It's always a pleasure to be a part of any panel where you're there. Thank you, Vivek, also. Now, to specifically answer your question about advocacy through disseminating information. I, in fact, come from a family where I had the misfortune of seeing two cancers very, very, very closely. I'm not saying, we could have done something to revive the patient or get the patient back in life. But I still remember what was plaguing our mind is that we could have done something better had we, if we had with us relevant, pertinent information, we could have asked the doctor. And from that is where JASCAP is coming from, that we want to channelize our grief by educating others. That's the primary interest of coming with this information. Now, I would say my experience or JASCAP's experience vis-a-vis disseminating information for advocacy is pretty mixed. In the last 2 decades that we have been, on one hand, the number of languages and the quantity of books and the oncology centers seeking our books are continuing, and it's in some cases so in the increase. But I'm not sure that the purpose for which we started this information book helps the patient in terms of understanding the basics of the disease, ask relevant questions to the doctor, and thus reduce their initial anxiety as well as also that abandonment of the treatment. So slowly we have started picking up certain loose pieces, and I can say, and we want to go ahead further in that to come to a real conclusion as to what happens. And to that extent, I'm working very closely with Brain Tumor Foundation, where we are doing extensive education. In fact, our in-house doctors writing this book started with brain tumors. So thanks to the consultants there, we are now across pan-India. In fact, before coming to the session, we also had a Brain Tumor Foundation meeting. So there we are scientifically, through patients advocacy group, through patients meeting, we are trying to see when did they get the book, who recommended them to take the book, and how did the information help them. So as of today, I can see that out of every 10 patients, 4 of them have said definitely that they never knew, first of all, cancer can be curable at this stage with proper treatment, with proper diagnosis. So reading this book to a certain extent is giving them some reassurance, some comfort. Also, hematolymphoid, where I had my PhD study about, how these adolescents cope with the challenges of treating. I got many, many responses from there that they never knew that there was a bookstall in Tata Hospital. Actually, they happened to be passing by that annex building, and there they saw the bookstall, and from there they picked up the book, and they said, my God, if had we known this before, then we would have been much relieved. We unnecessarily got into a lot of negative thinking, and we even at point in time we thought of letting go the treatment. So that didn't happen. So I would say that the experience is very, very mixed, but we are not losing hope. With people like you, we still are going ahead and seeing that how we can scientifically construct a group and get the data from them to see what the outcome has actually been. I think I'll stop here. Thank you.
Yeah, thank you, sir. And what if I understood you correctly? One of the profound statement that you said was could have something better if we had information.
Yes, yes,
And
yes.
that is what is your motivation
Yes.
to go ahead with the books. And that's a very noble motivation. But you aren't not very sure about the empowerment potential.
Yes, yes,
literature, you started with the aim that it will empower
right.
them to engage better with the doctors, ask questions, make better decisions.
Yeah. Yeah.
So, but I feel that it does, and it has, and I think that's a way of advocacy, isn't it? Through
Yes.
literature,
Yes.
when you say advocacy, it need not be always advocating directly. There are
Correct.
many ways of advocacy.
Absolutely, absolutely. Sir.
And this is a very novel way of advocacy, is to create literature, and this literature having this empowerment potential, isn't it? Yeah.
Just I want to add only one thing
Yes,
that
yes,
in the
yes.
last recently we have come up with videos on head and neck cancer specifically with the help of Tata Medical Center. So what they have done over there is they have created a business card kind of a thing, which is a QR code. So any patient who is getting registered for the treatment, along with the file, we also give the QR code in the form of a visiting card, and they can, wherever they go, they sit at home, they can see the videos, and especially about speech and swallowing therapy. What happens to the head and neck cancer patient? And we have been getting very, very positive reports from the patient group over there. So yes, thank you, sir. Yeah.
Thank you. Other work that I have closely witnessed in terms of advocacy is that you have an unique talent of connecting philanthropy to care.
Yeah.
So you are, when I say philanthropy, it is not extracting money. It's actually people who have the resources. You are giving them an opportunity to use those resources well. And not everybody can do that. So can you briefly let the audience know about your successes and challenges in connecting philanthropy to care? It need not be palliative care alone, but to all forms of care.
Coming from a background of psychology, I always thought that if I have to work for the patient's benefit, then I must know where my resources are going to be used and how is it going to benefit the patients in a very measurable form. So towards that, first thing, of course, I started off working with hematolymphoid, and there I was, looking at the ALL patients. But very concretely, I had a huge discussion with the consultant of bones and soft tissue, because I learned that that's one of the cancers that comes in that adolescent age or teenage age. And I also learned that how early detection and treatment can help the patient come out of it. At least 7 out of 10. And also, I learned that this was one of the cancers where the side effects or the treatment-related burdens are much lesser, and cost-wise also it can be contained. So that's when I first started supporting the adolescent group of bones and soft tissue, cancer patients. And I'm very happy to say that I could really see, we consciously, with the help of the consultant, looked at the early diagnosed young boys and girls. Because I looked at it that my philanthropy should not result in something only quantitative, but definitely qualitative. How can my organization return the support which the family would otherwise lose? And adolescent who is in the throes of his life, his dreams, his aspiration, very, very important support to the family is very crucial. That's how I started. So like this, the next group I went is to work for the thoracic department, where they started off this, crisotinib molecule. I was told that they have an arrangement with the pharma organization that NGO funds one strip of 48,000. Again, that they will get the pharma company will give the other one. And therefore, I studied that. On the other end of the spectrum, this is adolescents and teenagers who are settling their life, and they're 55, 56-year-old, when they have kind of worked, most of their life, and they've consolidated some money, and they want to waiting to use that money for their son's higher education or a daughter's marriage. This blessed disease comes, and it's very, very difficult. So I said, how do I give the support back to the family? But I spoke to the consultant. He said, what can happen with this is they can at least lead 3 or 4 year productive life. They can still work. That's what they did. Then I went and spoke to the corporate and discuss with them how we can look at truncating the superannuation benefit that they would get. So typically you have to be 60 years old. Can we look at somebody at age of 58? Probably you might not be able to be productive. Some way of consideration that you can do. So all these ways, it did not only look at money, funding, that of course is there even in palliative care, but essentially these are two cases that I can look at. One is adolescent giving support to the family, and here at the other end of the spectrum, 55, 56-year-old, where we are trying to preserve and see how we can help that gentleman or the breadwinner of the family to realize some unfinished pursuits or dreams that he would have. Now, coming to palliative care also, for example, as we all know, Tata is a very high volume, high dense, patient cohort we've got. So they started having home care. Of course, they've been having home care for last decade, and we have been doing a wonderful job. But we realized that as the patients become more and more advanced, they're coming to the hospital financially also, otherwise also was extremely getting difficult. So we funded one of the projects where we said nurse-led home care. We essentially, the nurse would be part of the group. Every Wednesday we will have a triage system where advanced care patients are being highlighted identified, and this nurse would coordinate with their family physician to ensure this patient, whatever is symptom is causing him trouble, is taken care of immediately. So that we will also trying to preserve the quality of life. And I'm very happy to say that this nurse-led home care movement really showed us how this perceptibly we can make this difference. So we kind of enrolled 87 family physicians for the patients who did not have a family physician, and the nurse and the hospital together handheld the patients through these facilities. So at least more than literature, I think this philanthropy has really brought in some satisfactory, measurable outcomes for patients' quality of life.
Thank you, sir. Thank you for your insights and wisdom. Much appreciated. I'll go to Dr. Smriti Khanna. Now, as a physician, you have transitioned into palliative care, and you are now working at Hinduja Hospital, Mumbai. How are you able to advocate for palliative care among the colleagues? It's a multi-speciality hospital, so you would probably interacting with the many different specialists. How are you able to do that?
Thanks, Dr. Naveen, for that question. And thank you to Mr. Vivek Sharma and Cancer Conclave for having me on. I think that one of the ways to advocate for palliative care is to understand the sense that patients in different setups actually have different palliative care needs. And that is something that my transition from home care to sort of government patients in government setup to patients in a private setup, that actually taught me. And so what I have found quite useful is when I see a patient that has been referred, trying to zoom in on that one or two key things that would be very important for that patient palliative care wise, and then going back to the referring consultant and then speaking to them about them. This kind of gives them extra insight into the case. Many a times, oncologists are quite busy and may not have the time to look into the other aspects of it. So, for example, if I see a man living just with his daughter, and that's just the family there is, I know that teenage daughter is going to require a lot of extra additional support, and then counseling is going to be something that's going to be beneficial. But the treating surgeon may not have the time to be able to kind of focus on that. And so going back to them and telling them that this is what I feel was most essential, and this is how I have liaisoned with the counselor or with a home palliative care service to be able to get in touch with this family. Another way is something that we have started at Hinduja is setting up joint clinics. And this is something that that can be useful in both oncological as well as non-oncological settings. Most joint clinics have two doctors sitting together and looking at patients from different kind of systems or different frames of mind. And that has been also quite interesting in changing the patient's thought process also about what palliative care is and how useful it is for them, and also to some extent changing the doctor's point of view. And then the third thing I think that has helped is patient-led or volunteer-led support groups. So having the support groups stay in touch with doctors, on a basis like say once in 3 months or once in 6 months. So having different support groups stay in touch with doctors. And the support groups also themselves advocate for the use of palliative care or how useful they found palliative care to be. And that feedback, when it reaches doctors directly, really helps.
Thank you. Just a follow-up question about the joint clinics, which you mentioned. So when you sit in the joint clinics, and I've been many joint clinics, the predominant discussion is around the disease. There is very less discussion around the person who is having the disease. How is that barrier you are able to overcome?
I think that when it comes to long-term treatment and different treatment options when they are there in front of the patient, that is where I would say that the primary doctor kind of sort of gives treatment options and then waits. And that is kind of my cue to, get in and say that, okay, this is what we have. And now I want you to know that we don't have one right answer over here. And usually what families do is that they kind of take our help and choose what is best for them based on their situation. It could be finances, it could be social support, it could be distance from the hospital, it could also be goals of care. And that is where I can then introduce the goals of care concept.
Right. And often, maybe Hinduja is an exception, is that private institutes are very return of investment in terms of revenue rather than value. How would you be able to advocate for palliative care where value supersedes revenue in terms of return of investment? You are the investment there, isn't it? So how would you be able to advocate that for the administration?
Couple of things, I think. I was lucky enough to have a predecessor who laid the base, sort of made a case for palliative care when I joined Hinduja, and they were already convinced when they came in that they needed a palliative care person on board. But I think that what happens is that when you put in the years of work collaborating with different physicians, it could be ICU, it could be the oncology department, it could be the non-oncology department also, they then begin to advocate for you. So I was fortunate enough to have enough sort of buy-in from other senior doctors in the hospital, who then said that we are glad to have palliative care on board. We would like to have palliative care on board because we have seen how it works, and we have found that it has been beneficial for the patients. One other thing that we noticed was, of course, this was informal, that after the involvement of palliative care, patient complaints against hospital administration reduced. And this is something that we then brought to the notice of authorities. And I think that was also a good selling point.
And thank you so much. A very similar thing that we have noticed is that our discharges against medical advice came down, like how you had mentioned about. Next question is to Dr. Biji. There is so much of evidence on integrated palliative care in cancer. So much has been written since Jennifer Temal's time in the last decade or almost 15 years. How are you practically able to do that or advocate for that among your oncologists in the public cancer institute?
Thank you. Thank you, first of all, Cancer Conclave, for giving me this opportunity. And thank you, Dr. Naveen Salins. Like you said, I work in a tertiary cancer center, and we have all the oncologists, surgical, medical oncologists, radiation oncologists, all working. And the thing is that in a patient, and we work as an independent department. Cancer palliative medicine is an independent department in my institution, and we have a stoma clinic, we have a lymphedema clinic under us. So when any patient comes for treatment to any of the oncologists, these patients would be referred to us in the initial few visits itself. If the symptoms are very much, the first visit. Otherwise, depending upon the patient load, it is actually we have it's an adjustment. Like they call us and ask if you're free, all that. Otherwise, the intention is that the first visit, the patient has to see a palliative care physician. So, even in the ward, when the patients are admitted maybe under the other oncologist, but still for their symptom control, we are always pulled in. We get a reference. We have to see them during radiation or during chemotherapy, whatever be their symptom problem, we have to be with them. So we actually, for their treatment, it's a hand-on-hand we go with the oncologist. Secondly, as you know, as part of our Kerala government's palliative care policy, awareness on palliative care is given to all the staff in our institution, right from the security, administration, or all the medical people, even up to the cleaning staff. Everyone has to get an awareness session on palliative care, and that is given regularly in our institute. Third, all the residents, our director is very, all the residents, we have DNB courses, we have fellowship courses going on in oncology departments, surgical, radiation, all that. So they have to compulsorily, they have to undergo a palliative care course. So mostly they take the IAPC course, which is run thrice in a year, or they have to undergo some foundation course in palliative care, which we do in our department. So that is one more thing. So as a result, it's a very good input we get from these residents. So the care of patients is much good after that. We have a nursing college attached to our institute. So the nursing students, they keep coming in for their practical work. So we are very sure that when they come into our department, we definitely will give one session of awareness class for the budding nurses also. Okay, and another thing is that we are also a part of the medical specialty, the multi-specialty board, which occurs in our institute. That is there every day after the working hours, like in the evening, we have a multi-specialty board, and palliative care physician is also a part of that multi-specialty board. And now when the patient is inside the hospital, definitely palliative care goes on along with the oncology treatment. And once the patient has to be only on palliative care, then what we do is, we have a very good network of palliative care in Kerala, very good network. So we can very safely hand over our patients to the local palliative center. Now, who are the people who help us there? The volunteers there. With this such a good network, we have an innumerable number of volunteers working in palliative care. So, and these volunteers do come to our hospital also for some training purpose. In between, we give them training. Also, we always have a good relation with them. So we have their address, we have their phone numbers with us. So whenever we have to refer a patient to the nearby local palliative center, we contact them and we hand over them the patient, and so that the patient is very safe. And any concern they have to, they have to come back to us, like when they have to get sometimes they might have palliative radiotherapy or something to improve their quality of life, even after they leave the hospital. So in that time, also the volunteers, they speak to us and we ask them to bring the patient and we give them care after that. So definitely oncology, and I have a lot of support from my oncology team. And everyone, I'll tell you, they're all, they are aware about palliative care, and they give me good support in taking care of their patients. So and we do research activities also along with them. So like in our stoma clinic, we do research activity and we show the quality of life of stoma patients when the patient is being addressed by a stoma nurse who is in our department. So the surgeons are shown that. So because of that interaction and showing the research activities, we have the result. So we have a very good, we all work together for the patient. I'd say it's like a teamwork, we say, absolutely, it's a teamwork. Another thing is about the pain. We know it's the most distressing symptom for a patient. So once a patient is into our hospital, the pain assessment is done. On the case sheet, the pain score is written. In the ward, regular, it is every shift the nurse goes. The pain score will be also assessed like they assess the other vital signs. We say pain is the fifth vital sign. Definitely in our institute, it is the fifth vital sign. It is recorded in the case record. And we do have an uninterrupted supply of morphine. So pain management is absolutely fine in that respect. So I think integrating is a.
I have one more follow-up question. Sorry to interrupt you, which you answered mostly, is in terms of community advocacy groups, which you mentioned a lot with the volunteer work that you are doing, and Kerala per se has a lot of the neighborhood network program.
Yes,
but are there any specific community advocacy groups for oncology that exist, which helps the patients and their families?
One is about this neighborhood network in palliative care, that is IAPC Kerala. That's an umbrella organization for coordinating all the activities in the 14 districts of Kerala with the help of these palliative volunteers. So in our district, we have around 500 volunteers, I should say, because we have more than 60 palliative care units in our own district. So I told you the volunteers, they definitely help us in that. They undergo training, and they take training from our center, they take training from IPM. And so they keep increasing their number. And so we have a very good help from these volunteers. There is another one, I should say one consortium, which our director has created. It's called the Kannur District Cancer Control Consortium. So though the main objective of that consortium is early detection and prevention of cancer. But most of the members in this consortium are our palliative care volunteers and the survivors of our cancer. So they themselves are an ambassador for that, to bring in our patients and tell them what we do. So because they're all palliative care volunteers are also part in this KCC, what we say, Cancer Control Consortium. What they do is that they come to our hospital, they sit in the help desk. So whenever a patient comes in, they take care of them, they help them to fill in the forms for these schemes, opportunities which is given to them, financial support, then how about to go into the hospital, whom to contact, how to contact. All this is done by our volunteers and the support group people. And they also bring in certain funds from the other organizations. When they find that the patient is financially poor, they try to bring funds from the other organizations and help them complete their treatment. Recently, I'll tell you one more thing they have brought in is something called the Birthday Challenge, one new program. So what they do is the nearby schools and colleges, that is each student, when he spends some amount for his birthday, celebration of his birthday, one small amount he donates to our institute for the poor patients fund, into the poor patients fund, which goes, and that is utilized for our patients treatment. So that is one group. Then I told you that is we have these support groups. We have support groups for various cancers, like head and neck support groups. We have gynec malignancy support groups. We have stoma clinic support groups. And all these people, we give them some rehabilitation program also. Like recently we had, not just 2 years back. So they've been learning how to do mural painting. And it's a distraction from their work, but it adds color to their life, I'll say, because I have witnessed them painting that. And we kept an exhibition for that, and they were able to sell out those pictures, and they could earn some money for themselves, and they had also given some for the Poor Patients Fund. So I should say that
for your input. Sorry, because of the paucity of time, I have to ask the next panelist, but I can clearly see the diversity of work and the advocacy that happens. It's really a multi-level and multifaceted, and very thankful to you for all the insights. Going to the next panelist, Dr. Manali Patel. Ma'am, you work in the ICU space, and this is some work that's very close to my heart. So as a critical care physician, are you able to advocate with your colleagues for appropriate care of the patients when ICU measures are unhelpful? You're muted probably. We are unable to hear you. Vivekji, can you hear?
No, Dr. Is your computer connected with the speakers?
Are you able to hear?
Better.
Yes, now we can
now we can hear. Now we can hear.
Yeah.
Okay. So this is the most difficult group to advocate. And let me start with my short story that I have started with critical care in 2005. And from 2005 till 2018, till I went to AIMS and attended Dr. Sushma Bhatnagar's lecture, I wasn't really aware of actual palliative care, which I can offer in the ICU. So bitter truth start with me that in 2018, I understood about palliative care. And that point of time, I realized that I can do something for my critically ill patients. And still there is lot of, like, it has been included in our critical care curriculum. Palliative care has been included, but still lot of things to be done for intensivist as well. Unfortunately, still intensivists, they do feel that death is defeat, and they are not able to accept that defeat. So we need to work something on this, where we do understand that just correcting physiological parameters, just correcting correctables are not going to be helpful. When patient, they have started with absolutely compromised quality of life and they are going through the critical phase of illness, they will go back home with a poor quality of life once they discharge from the hospital. And unfortunately, these parameters, many of us are failed to understand or assess. And we are the people who guide families for going ahead with the aggressive treatment. So sometimes I feel that sometimes family insist us for aggressive treatment, and sometimes we are unable to convince ourselves that this is the point where we should just consider comfort care. So right now I'm doing two different jobs which are absolutely opposite to each other. So whenever these are critical patients who come to me and they should do everything aggressive, I convince them for aggressive treatment. And there is a point where I feel that now aggressive treatment is just deterioration their quality of life and probably deterioration in their quality of death as well. At that point of time, I put my palliative care physician forward and I offer them that at this point of time, I think it's right thing to stop. Right thing not to go ahead with the further aggressive treatment. But unfortunately, it's still...
You are doing your part, but how are you advocating for the cause with your colleagues?
Sir, advocating is mainly communicating with them, but this is the most difficult part. I feel it is easy to advocate patient and their families. It is difficult to advocate different specialties who are involved in the care. So
Right.
Still I'm trying to find out better ways how to advocate them. But probably more awareness about palliative care and more acceptance of death, more acceptance of physiological limitations of the treatment. We need to understand that these are the limitations and we should not be putting our limits. We should not be stretching patients' financial and physical limits, and we should not be stretching our expectations as well.
Right. Thank you, ma'am. A follow-up question to what you just mentioned. Do you think that the patient families, I'm not telling patient, families are empowered to ask for palliative care in an ICU setting?
Unfortunately, there are two diverse groups of families are available outside the intensive care unit who are waiting, who are in that waiting area. So there are families who would like to do everything when things are non-salvageable. And there will be different group of families where would not like to do anything when patients are salvageable. So still these two diverse group are very difficult to communicate with. And still I feel that there is not enough awareness for patients' families as well, that they have option to stop somewhere. And whenever I have faced challenge at that phase also, whenever I'm trying to tell them that these are the options we have available, that we can refuse for invasive ventilation, we can refuse for further aggressive treatment. But many times there is improper agreement between the family members. One family member would like to go ahead with the aggressive treatment and other family member would like to go ahead with the non-aggressive treatment. That point of time, it becomes difficult for us to get them at the same point where they get into the agreement and go ahead for one single mode of plan of care. And unfortunately, same disagreement persists for specialty consultants as well.
Right.
So
Thank
we
you
need
so
to have more awareness about palliative care in critical care as well.
Yes. Thank you so much, ma'am, for those insights. And these are all coming from your experiential account of working, isn't it? And we are very grateful to you. So what we saw in today's panel was a very diverse advocacy. When we understand advocacy, we always have a very one-track thought about advocacy. But advocacy can be done at many levels and in many ways in our own work. And what we saw Dr. Ganpati doing advocacy through literature and philanthropy. Dr. Smriti Khanna doing advocacy in a private setting through interacting with various clinicians through joint clinics. Dr. Biji doing advocacy at lot at community levels, and especially for the vulnerable groups, and how she liaises with many people in the society and how the care is being provided. And Dr. Manali Patel, how she does her own advocacy in a very unique way in an intensive care unit. So with this, I end my session moderating. I'm very grateful for all the panelists on a Sunday afternoon, now it's Sunday evening, to participate in this. And thanks Vivek and Dr. Kumar Prabhash and the Cancer Conclave for this opportunity. Thank you.
Thank you so much, Dr. Saab. It was really wonderful experience and understanding about the palliative care segment, which is so less known, and जहाँ पे clinicians खुद भी challenges face कर रहे हैं, advocacy के लिए. And I'm sure that this conclave or this piece of conversation जो हमारे white paper है उसमें बहुत valued role play करेगा. And as on the other screen, I was seeing the number of people who are watching us live. It has crossed 20,000. क्या इंश्योरेंस का सब्जेक्ट आने वाला है, ये रीजन है, बिकॉज कैंसर इंश्योरेंस लाइक बड़ी तोड़ फोड़ चलती रहती है, बिकॉज लाइक इट्स लॉट ऑफ इट्स क्वाइट अ बिट कॉम्प्लेक्स प्रोसेस एक्चुअली. सो उस प्रोसेस को और स्मूथ करने के लिए, रेदर जो अवेयरनेस है उसके बारे में, उसको इंक्रीज करने के लिए, उसको और अच्छे से समझने के लिए, लेट मी इनवाइट डॉक्टर भरत भोसले. He is a director of SANACT and Sunrise Oncocare Center. They run daycare chains, and they are also working on increasing the access to CAR T-cell therapies. He's also associated with the Jaslok Hospital and Bombay Hospital. He's a medical oncologist by profession and a singer by passion. And he and his team are trying to close the care gap by bringing various things under one umbrella. Thank you, Dr. Bharat Bhosle, for joining us today. And I would request you to take the seat and invite the panelists.
Thank you, Vivek and CRSF Foundation, UHAPO, Dr. Kumar. Last year, I was a panelist sitting and answering the question related to the insurance, and now I'm moderating. So my job is easier to ask the questions to the experts. I'm very happy and honored to moderate experts in the field. So today's panelists are Mrs. Dipti Bhaskaran. She's head strategic initiative, clinic healthcare. The next panelist is my mentor, teacher, guru, friend, and senior colleague, Dr. Kumar Prabhas. He was the head in the medical oncology department, and he has been guiding us more than a decade. Mr. Maulik Choksi, he is the deputy country director, Access Health International. He has worked in public health sectors and government policies, designing government policies. Dr. S. Prakash is a former MD at Star Health. Again, I have read about him. He has been instrumental in getting mass healthcare. Dr. Samar Bakshi is a professor at AIMS, and he has been instrumental in many protocols in pediatrics. Dr. Vijay Sankaran is a group chief medical officer at Mediassist, and I assume before Mediassist he has worked in other insurance like Religare and other insurances. So we'll start. Do you have the slides, or I'll start with the questions to Dr. Kumar Prabhash. Kumar sir, so the cancer treatment is evolving. Decades before, there was hardly any systemic treatment. Surgery and radiation was the key factors for cancer. Then slowly, chemotherapy has become backbone, pediatric tumors, then solid tumors. Then various treatment in the form of the immunotherapy, bone marrow transplant, oral targeted therapy evolved. I remember 2009 when the use of Geftinib started, and the cost of Geftinib was at what cost we get osimertinib today. And the responses we started getting, and we knew that this subset of patients are going to get response, but the cost was a major hindrance. And we knew, there were government patients, like say railway, but on the other side, there were patients with limited insurance, and this treatment through insurance, they could access only for a month. So there are differences in terms of the access to the healthcare. The second thing is these patients were in the transition from chemotherapy to the targeted therapy, which is oral therapy. And most of these treatments can be designed by the biomarkers. So we need to do investigations. And if some patient is stable, you don't need to admit, you get the biopsy done. And when the report comes as EGFR or ALK, you just have a treatment for ALK in the form of tablet. Now you don't need to admit. So there are insurance perspective to this, because different insurance companies may allow for the admissions, don't allow for the admissions. If there is an oral treatment, there is no need of admissions. So these are the challenges I do face on a regular basis. The investigations done without admissions are rejected. So the treatment is very different for different patients. There are complications arising from it. And now we are heading towards immunotherapy and CAR T therapy and very expensive therapies. So how do you face these challenges in the Apex Institute like Tata Memorial Hospital? Because you have many support groups, and then I will take the second questions.
So, hi Bharat, thank you for kind introduction. And what you rightly suggested, that there are many issues and there are many hues to the problem people face as far as insurance is concerned. Yes. And one other thing, first, it starts with that at this moment, if you think this amount of insurance is good enough, and then you have some good therapy tomorrow, and what you also suggested, and suddenly you realize that that was not good enough. You could have taken, but somehow where to have those lines drawn that you say, hey, what amount of insurance I take, which will be good enough for me next 10 years, 20 years down the line. Because if you take insurance at age of 30 or 40, by and large, you end up requiring in age of 50 or 60. And whatever insurance you take, that devaluation, the way of money happens by the time it reaches there, and you keep wondering. So that is the first aspect, that some way that you should be able to get treatment needs to be there. Some perspective to people who take insurance, that what amount will be good enough for them. Second, that whenever newer therapy comes, somehow the agreement, what has happened between the customer and the insurance provider, what was there 10 years back. So immunotherapy came now, and someone who has taken insurance 20 years back, given the best of the premium, now suddenly they realize in that heading, immunotherapy is not written. But it is none of his fault. He put the best of the premium possible. He paid all the premium for 20, 30 years. Now today has the treatment has come. It is good. We want to take it. We say, because the treatment came now, what do I do now? In spite of doing the best effort, what I did at that time. Third is, I think so, I'm sure many of people can blame us also, knowing the details. The way we say, hey, agar hum doctor ke paas jaate hain, doctor should provide all details, and then say, hey, do you listen to each line and each word? Same way for insurance, the pages are so many that you sign it. You don't read each and every word and every line of that agreement what we signed. And then you realize again what you were suggesting, admission required or not, tablet or not, how many days admission required, does the daycare qualifies for treatment or not, and then the patient was smoker or not. I know that is something pretty surprising which comes on daily basis or I will say regular basis to us. That patient was a smoker, and that's the reason that patient should not get insurance claim for the treatment they received. but I don't know. Somewhere the clause is written the way it is interpreted. It is that it's that way that if you are taking tobacco, then they don't get insurance claim. So these things are issues there where the consumer and the provider has to have the dialogue, how to ensure that they don't face this issue when they have paid the premium, when they have agreed with well-meaning people. At the end of the day, when they require those money to get the treatment done, and I think so, it primarily comes from that does the company is able to have some form of profit or not, and that's a challenge because of how much is the penetration of insurance in our country, how many people take it, and then how many people required to have the money to get the treatment done. That may be partly deciding. So many factors to it, but yes, at the end of the day, you have a whole lot of people, in spite of having only 8 or 9% people having health insurance at this moment. If that was the last I remember, people do get frustrated when they have paid the premium well from their side.
Yes, you have almost covered all the aspects which I do know come across in private setting, right from paying the huge amount of. Right now, I'm treating a 87-year-old of hepatocellular carcinoma, fit, young-looking guy, 87-year-old, and he has a background of working in advocacy for the insurance, from the insurance angle, not for the patient's group. And his claim was rejected with a cap as well as the oral because lenvatinib was the first line, and now he is on immunotherapy and targeted therapy. So in spite of paying for 10 lakh, which could have been 30 years back, is a huge amount. 10 lakh is a huge amount 30 years back. So what I feel, yes. So what I feel, like what the addendum we get in our histopathology report, something news comes up to the pathologist, or some mutation which not actionable 10 years back, and down the line you get a molecules, right? So it is like the insurance agencies also should have addendums coming up. If the new treatment come, and the dialogue has to happen that you have taken an insurance 30 years back. Now the treatments are also evolving. So we are providing a package, you can upgrade this. There has to be a dialogue. You can't just simply deny. From as a caregiver, I really feel a pain of not getting after paying for 30 years or 40 years. So there has to be a dialogue, which you rightly quoted. Now, as a clinician, we have limitations. We can't go and fight with them, because I have personally tried going and talking to insurance companies for my patients. Now, apart from our clinical work and lab work and research work, this is an additional thing, and it requires a lot of follow-up. This requires a lot of follow-up. So I feel, do you think that the patient should form a group like an advocacy group, or you have a lung connect group, which may help to solve? They don't have anything in their hand to solve, but do you think that will be of any help? And how should they have their approach?
I have no doubt about that. It require a patient advocacy group. The saying we have saying in Hindi and English both. You need to be in their shoes to know it. As much we think that we know it, what the patient goes through, what they require. But having said that, we know that we are not in their shoes. As much we claim, we end up being a doctor. As much we talk to them, as much. So yes, I think so. The patient and the caregiver, they know the best. Their voice needs to be there, and also they are the most neutral voice. As much I may keep talking about my patient requires this, I am a biased person as a doctor. So as a patient and the caregiver, they are the people who are the most neutral. Not only being neutral, they are perceived neutral in the society. So they speaking and their voice will be heard far better. The people will be far receptive. Any administration will be far receptive to the voice from patient and their caregiver than as compared to anyone from either clinicians, from any healthcare worker, or from the companies who may be willing to present things, or from insurance. But I think so. It will be ultimately a patient and the caregiver. So their voice is important, and we know that worldwide, if they speak, people do hear them.
Thank you, sir. You have always shown a vision. Decade ago, you shown what molecular work can do. and setting up a advocacy group, helping them and designing them. And I think many advocacy groups are coming up and trying to solve these issues to what they can do. The next, please go back to the previous slide, Vivek. So our next panelist is Dr. Vijay Sankaran. He has an extensive experience of different insurance companies. So now we always talk doctor's perspective, advocacy group, and patients. But there are some queries from the insurance companies also side. We have to hear those. Like there has to be a crosstalk. One cannot have only one group talking. But Dr. Vijay Sankaran. So the claim settlement and the reimbursement denial, it's a big thing for us. It happens on daily basis, not for all. There are companies who don't ask unnecessary questions. I'm very serious about asking, putting that word unnecessary questions. When the data is in public domain about a disease and the drug, sometimes, I'm not saying every time, the questions are really, asked repeatedly. One example, I'll give the exact cause of the cancer. Now, everybody there are oncologists over here, very senior oncologists over. The day we'll come to know the exact cause of cancer, and Dr. Kumar also agreed to my statement that we will come to the cure. So it's a multifactorial disease. There is no single cause, apart from few cancers where there is single cause. So many times the claims are denied. So I agree that there are two ways problems. There is a lack of awareness and education at patients level also. They don't follow with proper documentation. But there are problems at the other end, on the other side of the table also. So do you think there has to be awareness, there has to be education on both the parties, also the policymakers? As I mentioned in the previous question, that the points which are laid down when the agreement is signed decades before, with the evolution of treatment, new treatments come into picture, which are curative and may not be, chemotherapy is the only treatment offered to the patients. So with that angle, what is your take, or what is the thing which comes from the company side or the insurance perspective?
Thanks, Dr. Bharat. I think that's a very good question you have asked. See, the thing is that when somebody is applying for insurance, number one, the most important thing there is that they should research it properly, the type of insurance they are taking up, try to understand the coverages and the exclusions, and try to disclose everything that is possible, because insurance, after all, is given on utmost good faith. That is what is true, right? Even the insurance companies cannot go out and investigate and try to find out everything that a person has. It is almost impossible. You understand that. So there are so many diseases around. So that is number one. The patients or the people who are taking up insurance need to first understand the insurance policy and then get into a contract. The second important thing is that there are different types of health insurance. So one is the indemnity insurance, which we are talking about, where insurance covers basically the hospitalization and, as you have mentioned, pre and post treatment. Right? That is the limit of cover which is there in such covers. But there are a lot of other insurance products available in the market, like critical insurance covers, which specifically are designed for critical illnesses, including cancer. These are products which people are not aware of, where a bulk amount is given on the diagnosis itself to the customer. So this bulk amount is what, cancer treatment does not end with pre-diagnosis consultations and investigations or the post hospitalization, right? It goes on for years. So it may be a year, a couple of years, and there are a lot of associated expenses like traveling, palliative therapy, the nursing care, etc., etc., etc. There are a lot of things. And if you invest in products like a critical insurance, where a bulk amount is given to the customer at the diagnosis itself. So people should start investing in those covers where they get that amount in the bank, which they can utilize to cover the financial expenses over a period of time. The second problem is that I think even today in India, insurance is not seen as a necessity. Everybody will agree on this standard, right? People don't. People feel that I'm okay. I don't need insurance right now. Only when something happens do people invest or try to get insurance. So that is the second thing. So I think there is a role for patient advocacy groups where they can try to. So these advocacy groups can help the larger public to make them aware on the uh, dangers or the financial strain that cancer cause on the entire family financial situation. I think it requires a lot of education either from the government side or through private organizations or through advocacy groups to try to disseminate this information to people and bring them on board as early as possible. One of the panelists just now mentioned the penetration of insurance is very low. It's one of the lowest in the world. The health insurance is something that is the last on anybody's mind. I think once you, so the people have to be aware on the type of product they need to invest in, and the earlier the investment happens, it is better. So that would be my take on it.
So thank you. So you partly answered about the education and penetration. So my second lead question here is the how do we how do we deal with the reimbursement denials and the claim settlement denials? Because see, there are people I do understand no penetration is a problem because of the social background. Largely people stay in rural area. We can't expect everybody to know and read those. As Dr. Kumar rightly said, this is how there's a big book comes and there are middle agents who are involved. No, partly they facilitate the enrollment, right? Many a time I have come across that the people have told that no, they ask us not to disclose particular facts. This is what happening because no, the agent also acts to increase their numbers. So the middleman is handling and taking the insurance and facilitating when it comes to the settlement or reimbursements. And lot many denial, from the insurance, how we can reduce that number. So it's a fact that it is being denied, not for all, but as a caregiver or advocacy group, they would want that at least whatsoever return. And one other point which is mentioned is we should not go into detail that anti-cancer therapy is moving from chemotherapy to immunotherapy and targeted therapy. So lot many companies are coming forward with no cancer insurance, dedicated cancer insurances that may help in the future. But right now, based on the agreement which is signed decades back, the right is getting rejected in few of the cases. Few companies are very good. I will not mention good and bad companies, but there are very good companies, but at the same time, sad to say that some companies are really behind denials. So what is your take on that?
So I agree. See, a lot of these denials usually happen because there is lack of understanding on both sides. Maybe from the medical side, the documents coming in are not that clear, and there is another party sitting there. So you need to understand that the doctor sitting in the hospital is a primary caregiver. He is into his clinical work, right? The other side is the other doctors panel, which is sitting away and judging something on what documents come in, right? So if the documents are not clear, either a question will be asked about further detail. If they are answered adequately, the approval may happen. But if the answers coming in are not convincing, then it becomes difficult for even the insurance company people or doctors to be able to judge whether this is acceptable as per the policies, terms and conditions or not. So that transparency has to be there. There has to be a dialogue between the two partners so that there is much ease in the transaction as such. Today, that transparency is not there because there is so the doctor does not directly speak to the doctor. The treating doctor does not speak directly to the insurance doctor. There is some in between. There is a TPA desk. People manning that are basically graduates. They don't understand medicine. So one doctor is not directly talking to the other doctor. So this is the problem in between, which leads to a lot of these rejections uh, in first place. So that is that. And another thing that you brought up is that types of evolving treatments which are coming up. Right? So it is not that insurance does not cover the newer forms of treatment, even though your policies are old. So from time to time, even the regulator sends guidelines, and people also keep updating their products. So the product which was bought maybe 10 years back, today the same product may not be in place because the terms and conditions are changed. And especially for cancer, there has been a lot of change in the last couple of years where the modern treatments, the robotics, or even the oral chemotherapies which have come in, uh, companies have been advised to give cover to this. So those the covers may be limited. They may put limits on payability because these are things that the insurance company is not able to understand. What is the cost going to be? Because we need to understand that after all, insurance is where we take money from 100 people and we expect that 6 people or 7 people or 9 at the most will get admitted. So that is how it is done. If insurance keeps covering for everything, then the cost of the premium will go so high that other people will stop affording that. So it's a catch-22 situation. So insurers also have to understand over a period of time as these become more and more mainstream treatments, the cost also starts coming down on the medical side, and insurance also starts to understand how it works. There is statistical data on which they can work. So that's how these things will come into place over here.
Yeah, I take your point. Very well said. There has to be a interaction. So I personally do try to talk. Many of the companies, if they have a problem, they do talk. But yes, there are skewed deviation, and few of them are not in a position to talk or they don't want to talk. But largely the channel is open. Again, there is awareness. The awareness should go to all the treating doctors, the patient groups, the advocacy groups, as well as the doctor sitting on your end. So, and that solves the problem. This is the transparency, right word you use. Yes, I completely agree.
I'd like to add one thing. I'd like to add only one thing. I remember as a medical graduate, I think in 2000, so there was an opinion that health insurance should be a subject for medical graduates. I think we are the generation actually who are the senior consultants and all, and I think that lack of knowledge is what's currently hurting both the sides. I think over a period of time, I think it will ease out and people will become
Sure.
more mainstream.
Yeah. One has to take the opportunity to educate all. No, once. So I see unfortunately, I have a young doctor who suffered from a brain lymphoma, did not have insurance. His father suffered from cancer way back. He did not have insurance. And I have seen, even a financially well family, how they collapsing. And then what must be happening to a common public? Educated class is also way away from the insurance coverage. So our awareness should start from getting into enrolled. Forget about applying. Obviously, we are there to help to facilitate from the patient end. I request, and most of the companies are doing trying to help out to the patient, because this disease is something which doesn't affect a single patient. It's the entire family. It's a mental burden. It's not only the financial toxicity. There is a mental toxicity equally involved. So we are evolving in terms of all these factors. Thank you so much, Dr. Vijay Sankaran. Next, I would like to move to Dr. Prakash. Now, with your experience on the clinical side, sir, Dr. Prakash,
Yes.
Your experience from the clinical side, more than 2 decades, and then moving into insurance, establishing a company, taking in milestone ahead. You must have and you have been instrumental in getting a mass insurance coverage in South India. So I read about it. So you have touched from the beginning point of enrollment in the insurance and tackling all the issues which we have been discussing, including the rejection. So it's a fact that there are rejections, but the rejection must be going down in terms of the percentages. So now we are talking a lot about the advocacy group. Have you come across such groups influencing, or do you see any role this group can play while getting awareness or get more enrollment, or handling the conflict in between the two parties?
Yeah, Dr. Bharat, Am I audible?
Yes, sir. Yes.
Yeah, Dr. Bharat. So I foresee a lot of positive role for the advocacy group, because here we need to bridge the gap.
Yes.
A lot of information asymmetry between the customers, the hospitals, and the insurers. So insurers also want to design product, as my colleague Dr. Vijay was talking about. They want to design product based on the market feedback. So advocacy group are the right people to give the exact information on how a product can be designed, because he was talking about insurers being worried about increasing the premium getting increased if too many cancer conditions are covered. But cancer conditions can be covered because there are a lot of problems among survivors and also among people who are early detected and treated, where the financial liability is very less, but insurers are apprehensive about covering those individuals. So they need to be covered. Someone survives from a cancer, they need to be covered for non-cancer related medical conditions. What if they are going to live for another few decades and suffer from a fever or a fracture? They should get a health insurance. They should be considered like any other normal people. So the right information should reach the insurers for designing a health insurance product which can cover people who are diagnosed with cancer, treated with cancer, or was surviving out of a cancer. So here, I think an advocacy group have a very, very strong role to play.
No, that is why more and more doctors should go and join the insurance side also, so that they do understand what are the patient's problem. So as you mentioned, the advocacy group can help to know what are the actual demands and how the insurance company can meet. But the rejections, what we see, I don't know whether they are intentional or technical. Technical in the sense based on the agreement which happened between patient party and the insurance company, or is it something which is incentivized? No, then the word come intention, that more and more rejections would be better. I don't have doubt that everybody is there to help, but then when a genuine claim is rejected, there are certain questions comes up, and then how to deal with it. As the previous panelist mentioned, Dr. Vijay, that now people are ready to discuss, but unfortunately there are certain circumstances where the parties are not ready to discuss also. So, and I'm not saying the number is big, but yes, the patient parties are producing all the reports, the doctors are ready to discuss, all the questions are answered, but on certain occasions the claim is still rejected. So then the question comes, the reasons are really intentional or technical? Dr. Prakash.
Yeah. Yeah, Dr.
Yeah, how we can reduce that?
It's very difficult to say whether it is intentional or commercial. So honestly, as a doctor in the health insurance space, health insurance is not a commercial product alone. It has got a lot of values,
yes,
and there is a serious intention, but it also requires capital. And people have to infuse capital, and they will be expecting returns. So when I talk about rejection, I can foresee one of the main cause of rejection is people not understanding what they are buying. There is a waiting period. There are standard exclusions. There is a pre-existing disease. There are some endorsements. So the policy holders are not, unfortunately, spending time to know what it covers and what is not covered. So that is the main reason for rejection, as I could see. The second thing is, in the designing of the product itself, insurance policies sometimes are very complex, that people in the same industry also cannot choose the right product for them. So this is a continuing challenge I could see. The third is, as a senior doctor, I know the patient, the family for so many years. When they come to me and say that, sir, please don't mention that I'm an alcoholic, because the hepatocellular carcinoma, there will be a lot of questions. Sir, I had some instances of hepatitis in the past. I don't want that to be mentioned. And the doctor also knows them and the family for 10 years, 15 years. He thinks that he's doing a help. But actually, it is not a help. In the eyes of the insurers, it is a substance of material fact. And it will be amounting to financial fraud. So these when there is a suspicion of such things, insurers tend to reject. So the rejection is due to products, due to the features in the products, due to the customer purposely not closing, and due to the customers being naive and innocent. Some customers are very naive, very innocent. Some of them are very demanding and very vulnerable.
Yes.
And insurers want to protect themselves. Even, as a doctor, I could see that now a lot of defensive practice, multidisciplinary approach is helpful to treat the patient. At the same time, multidisciplinary approach can safeguard a treating doctor.
Yes.
So this is the era of cross consultation, and with every cross consultation, there are a lot of investigations, and the treatment cost adds up. So every one of us should understand. Insurance works on two things: what is the incidence rate and what is the average we spend for a claim. So if there are people, even 10-20% of the people suppressing the information and trying to come for a claim, it will affect the balance because the incidence rate will increase. My outgo will depend on the incidence rate and the average IP. If there are, out of 100 hospitals I service, if there are 10% of the hospitals which are trying to do unnecessary investigations, extended length of stay, unindicated procedures, and unwarranted professional cost, all these things will increase my average cost.
Absolutely.
Even if 50% of the people are doing a genuine service, 10-20% of the outliers can tilt the balance. So this is what is bothering the insurance companies. So I think there is a fair role for the advocacies to study the pain points from both sides. And then I am willing to sit with the advocacy group. I'm not talking theory today. I am willing to sit with them and design a product which can cover people who are diagnosed with cancer, and take it across to the nation and show to the insurers that it is a viable proposition.
Yes.
For post this conclave, we can organize for a small group where I can take some volunteers and I can design something and show to the country that people with cancer can be covered, and to the insurers that they can safely do that without much financial liability. This is possible, but it requires a team and a brainstorming. I look forward to the organization arranging for it after this.
Yeah, this is very important point, and the transparency is the key to go ahead, because the incidence is unfortunately increasing, and very rightly said, there are no really genuine patients, and the outliers, there are some fraudsters. Because of them, everybody screened, scrutinized in details way, but largely our cancer patients largely. Yeah, so going to the next question.
Dr. Bharat, could I come in here?
Yeah, please.
Hi.
I'm going to come to you, but you can cover in brief.
No, I just wanted to touch upon rejections, I think, because it's a very, very important point. And just wanted to echo some of the points that the panelists before me have already made. But I think when you're looking at rejection, right, the one thing that I think we still need to think about is, why do rejections happen? Okay. And in that, one of the practices of the industry is to, focus more on a very smooth selling process, right? Where the sale is not sort of hampered for, let's say, lack of documents, for a lot of health checkups, for a rigorous investigation and all of that. But what happens at the time of a claim is that's the time when actually there is underwriting, where the patient who reaches the hospital does not lie to the doctor. You will always truthfully disclose to the doctor all the problems. And that is where, you are in a soup if you have not disclosed in the past, or let's say the person who sold you the policy encouraged you to sort of lie or, suppress information. So I think somewhere as an industry, this practice of underwriting at the time of claim rather than at the time of the sale That shift also needs to happen. Now, if you look at the way industry has evolved, new regulations have said that after a moratorium of 8 years, you cannot deny a claim for non-disclosure, or other than fraud, you can't deny a claim. Now, that's a very good step, because that's sort of pushing all of us as an industry to make sure that I am selling the policy right. I am encouraging, or I'm making my customer aware, the importance of proper disclosures. So I think that is a focus area that we should not lose sight of. So I just wanted to make this small point in this particular aspect.
Then I would like to extend the question, because what I was supposed to ask you is about the coverage. People take, as Dr. Kumar also mentioned, what is the optimum amount I should take, because the cancer treatments are evolving and the future treatments probably are more expensive. So designing the coverage and the premiums paid, but after that, when the patient gets hospitalized, only the hospitalized amount is claimed. And again, there is a cap on the coverage. Restrictive amounts are paid based on the premiums. So what is your take, and what is your advice to the advocacy group as well as patients? How should how should they upgrade their insurance, or while going for a new product, what should they look into it? Because hospitalization, the entire hospitalization is not covered in many of the patients. It's the restricted at some percentage.
Sure. So I'm going to take that question slightly differently. I'm going to answer this question slightly differently. Let's first start by understanding why is health insurance right now just sort of confined to covering hospitalization expenses. So in that sense, it's restrictive. And I believe you've also mentioned that if it's oral administration of care, it's excluded. But if it's inpatient, it's hospitalization, then it's included. When you have a financing scheme, so health insurance is essentially a financing scheme. When you have a financing scheme that does not have visibility on a person's health and is not able to make an impact on a person's health, but is there only to sort of pay for a medical expense, especially at a tertiary level, what do? You have a product that's restrictive. You have a product that comes with certain caveats to avoid fraud and abuse. And you also will have a product which will be very, very pricey, especially at an older cohort. So you have been paying insurance for, let's say, 10 years, but suddenly you're 45 and you see your premiums jump to an extent where it does not become affordable any longer. Right now, yes, there have been reforms that have been done in the industry that's made insurance more comprehensive. But as long as the payers and the providers don't interact with each other, you will always find a product that's narrow in scope, right? So you will cover hospitalization, but you will not cover, let's say, oral administration of drugs. But in cancer, it's important that we cover all modalities of treatment. Right? So you cannot, I as a customer or I as a policy holder, I should not be at the time of making a claim, should have to worry about, hey, this line of treatment is not covered by my insurance policy. Yeah. And I feel as an advocacy group, that is where, you need to come in to sort of say that the kind of insurance that you imagine needs to be end-to-end. Because you cannot have a product that is only covering for hospitalization, because that's creating wrong incentive. That's pushing people to hospitalization. It's not really bettering any health outcome per se, right? So that as an advocacy group you need to do. But what that will do in return is it will encourage the payers and providers to come together, work together, and form a preventive and promotive healthcare layer. You've talked about how much insurance is enough, Today, sitting here, I could answer maybe a 10 lakh is enough, but is it really enough? You have treatment cost of 50 lakh, you have treatment cost of 80 lakh. So how do you look at insurance? You have to look at insurance from the lenses of preventive, promotive healthcare. Make every possible effort in the book to prevent hospitalization from happening, right? So if you can embed healthcare in insurance, that's how you will ensure that all the stakeholders in the value chain are aligned in terms of incentives, and that incentive is for a better health outcome. And I think that is the role that you play, the advocacy group need to play.
Yes, well said, well said. End-to-end coverage, and this needs to be again discussed by the advocacy group with the healthcare insurance providers. Very well said. So we'll move to Dr. Samir Bakshi. Sir, Samir sir, my question to you.
Yes.
No, at AIMS you work in pediatric solid mainly, no, and for kids we are very sensitive, no, and no, cure rate is also very high for pediatric solid tumor. So at your institute, how do you see, any example of advocacy group? We have been talking a lot about advocacy group. So in terms of availability of the insurance, lot is talked about. No, the advocacy group should penetrate the awareness to the groups or the patient parties, accessibility, and inclusion of the some drugs, newer drugs into the schemes. Are they doing a work on this improvisation of the availability, accessibility, and inclusion of newer treatment into the claims or to get the claim passed? And
So I'll give you two examples that I've faced. So I don't have too much experience about insurance companies because I don't deal with them directly. So I don't have experience, but I'll give you two examples, specific examples where drug approvals required an extra effort. In one, it was successful, and in another, it was not. So one was when immunotherapy was approved for lung cancer in India. That was the first drug approval, if I remember correctly. Yes. But it was not approved for melanoma because the market was very little. So obviously the company approached the DCGI for approval for lung cancer because that was a much bigger market. And this is back in, I think, 2017 or so, if I remember correctly. And in 2018, I had a middle-aged lady at the age of 50 with a recurrent metastatic melanoma. And obviously, she was a CGHS beneficiary, and there was no approval for this drug. And this was a curative intent. I consider this as a curative intent treatment for metastatic melanoma. And it was not getting approved. And we had to write 3 or 4 series of letters, appeals from the institute and from our side. And then committees were formed to look into the claim. And after probably 3 or 4 months, the claim got approved. And this lady then got the treatment for a period of 2 years. And I'm glad to say that she is a survivor today. So that was one example, not through insurance, but through a public insurance. I would say CGHS is kind of a public health insurance. The second example I would say, which I did not succeed, was a 17-year-old Hodgkin's lymphoma who required availability for, again, immunotherapy in a post-transplant setting for a relapsed Hodgkin's lymphoma post-transplant, and how the family wished that the patient was just 10 months older. So that creates a problem that had this patient been 10 months older, the same therapy was approved and would have got it. And I want to give you examples that in the US, the Medicare and Medicaid, if a drug is approved in general, but there is an overall approval in the scenario, those claims are considered.
All right.
So those claims are considered, but so in one we succeeded because there was international data. For the other, there was data, but not an approval. But then always approvals may not actually translate into for insurance. I mean, so that humanitarian ground or that kind of approval has to be considered, I would say, in such things. I would just end by saying one more thing, that while these were genuine cases, there are others where advocacies of a different nature may result in approvals based on what you call the passion of getting approvals for the patient or that feelings, but when the success is very minimal, the success quantum is very minimal. And I think one of the classic examples is that there was a push for the Duchenne's muscular dystrophy disease drug to get it approved. And while the benefit was very modest, so from that perspective, I'll say we have to look at the financial aspects of the insurance companies as well to see that they don't get milked out, as rightly pointed out by Dr. Prakash in his previous talk. So it has to be a balanced way of advocacy so that things get done for genuine cases. I would end here.
Well said, sir. No, so your crosstalk with the companies or discussion with the companies at least has a success rate of 50%. One patient approved and the other patient not. As you rightly said, the survival outcomes and the cost effectiveness is also very, very important. So the last panelist is Mr. Maulik. You have been working in public health as well as government advisory to design. So my question to you, when it comes to a large population like India, the number is huge. There are certain gaps, and what gaps do you see when it comes to insurance coverage? There is huge gap. Now, everybody knows that, everybody agrees on the point. Then comes the sum assured, whether it's adequate or inadequate, the premium paid, and the penetration. These are the issues. And what are your views so that we can bridge this gap, so we can close the cancer care gap pertaining to the cancer? And do you think the advocacy group can help it? Because we have been talking to many advocacy groups in India. Fortunately, the momentum has come that these groups are helping to patients, helping to smoothen the journey in cancer treatment. Over to you, Mr. Maulik.
Thank you very much indeed, and it's a pleasure to be here. I think so. I'll give even an economist kind of response to it. Indians are, if you look at our population, we have got high income group, we have got middle income group, and we have got low income group.
Okay.
And I think so that when we talk about covering them, we don't need a same instrument or a same tool to cover them. I think so high income group, we have got private sector, private sector insurance can play a significant role in enhancing the coverage of access to cancer care. Middle income group is an area which I think so we have been struggling for a period of time. There have been some kind of headways done, but I think so we are still struggling. And when we talk about a low income group, I think so where a sizable population is there. I think so around 60 to 70%. I think so we should be kind of, the patient advocacy group should be kind of instrumental in directing them, linking with what state supported health insurance schemes are. And why I'm using state supported, because we have got a federal level scheme like PMJ, Pradhan Mantri Jan Arogya Yojana, and when you've got a state supported scheme where a lot of states like Rajasthan or Kerala or Tamil Nadu have got top up above what PMJ is offering in terms of more than 500,000 rupees. So I think so when we talk about covering cancer care, we need to look at how the different instruments could be used to cover different population. That's one thing. And that looks at the coverage in terms of numbers. But when we talk about coverage within a policy, I think many colleagues have made a remark earlier also, that when you take 10 lakh rupees coverage, when you take $1 million coverage, what is it covered? And I think so Dipti made a very valuable point that it needs to be continuum of care. The gentleman also made there. There are certain critical illness plans that are available right now, which gives a lump sum amount based on what their initial diagnosis is. And I think the patient advocacy groups needs to kind of start playing role in making sure that all this basket of options which are available is known to the consumer. I think so there is selective information which is going on. We don't need to kind of rely entirely on private health sector or private health insurance. We completely don't need to rely on public health, publicly supported health insurance, but we need to start using these tools as and when come. So that's one broadening in terms of coverage as well as depth of insurance coverage is concerned. I think so. Second thing that's working now, and I think so it's going to be very important is what bringing in the cost of coverage. I think it's a lot of when we talk about premiums, one of the artifact of premium, or what is the input cost of premium, most of the companies do that. They know that certain proportion of premiums are going to get rejected because of XYZ reason. And a lot of times the XYZ reason is information is not available, reports are not submitted. And I think so what, again, at a federal level, what we are doing is creating a HCX, a kind of health exchange, which is trying to kind of digitalize and kind of harmonize this claim processing. I think so it will bring a lot of efficiency in the system. And efficiency can be a driver of decreasing the cost. And if the cost goes down, it gives an opportunity of more penetration. So I think so there are multiple efforts which are going on right now. And when we start doing that, patient advocacy groups also need to play a significant role in kind of making sure that people are aware of all this. As a lot of panelists have mentioned earlier, that lack of awareness is one of the biggest driver of not being able to access something. Let's say if I'm based in Rajasthan, till $2.5 million, 2.5 million Indian rupees, my health things are covered. Within that package, rates might vary, but I think so there are movements which are going on towards increasing coverage as well as within a package and at a population level. Thank you.
Thank you. Well said. So all the panelists have contributed a significant amount of information. The patient part and patient advocacy groups also do need to educate the general population while going for enrollment of new insurance. Need to have discussion in detail when such unfortunate incidences happen of cancer diagnosis as well as the claim rejection. There has to be effort from both the parties to understand what is the exact problem. I think the discussion, a sound discussion, can solve majority of the problem. Yes, there are still areas where both the parties has to evolve, but awareness, knowing the product, designing a good product for your newer product for specific population of cancer patients is also one important aspect we how to take it forward. And I think we have covered most of the questions. And thank you again, CRSF, UHAPO, Vivek, for the opportunity. And I conclude here. Thank you. Thank you all my panelists. Thank you.
Thank you, Dr. Bharat.
Thank you.
Thank you so much, Dr. Bharat. It's always a pleasure to have you, and you kind of make the smooth ride when it comes to the challenging situations. Thank you so much. So grateful to have you today. And as we move on to the next panel discussion, our panelist, expected panelist, she could not make it because of some health emergency in her family. So I'll be moderating the session, and let me invite the panelist. Let me invite Mr. Sanjeev Sharma, who's the CEO of Utsav Foundation and also the founder of Lung Connect. Dr. Kunal Oswal, who's from Karkinos Healthcare. He is the lead for screening and early detection. Dr. Rushabh Kothari, he's a medical oncologist and director of Oncovin Cancer Center in Ahmedabad. Dr. Chitra Gupta, she's lead patient advocacy at Pfizer. Mr. James Rajakumar, he is associate vice president at Natco Pharma. I welcome you all on the panel and thank you so much for being here and contributing to the cause. Let me start with Dr. Rushabh, because see, what we are going to address over here is like public-private partnership for the development of advocates or advocacies in the cancer care to enhance access, because access is something that cannot be like one of the panelists earlier said that advocacy is something not that cannot be done by one person, or even the government itself is not able to completely drive a big elephant like cancer. So we all have to come together, be it public or be it private players, and that's how the economy or everything has evolved over the period of time. Let me ask Dr. Rushabh that because I'm starting from Dr. Rushabh because he's on the ground, he's facing the patients every day, and he's seeing the real challenges. People ask questions, and things are very different when it comes to the ground level. Dr. Rushabh, what do you think? How is the implementation when we come to the public-private partnership model? Like you are probably one of the centers who provide Ayushman Bharat or PMJ services to your patients. एंड कहते ना कि खाना कितना भी अच्छा बना लो, अगर खाने वाले को मजा नहीं आए तो मजा नहीं आता है. तो हाउ इज द इम्प्लीमेंटेशन ऑन ग्राउंड एंड व्हाट आर द ट्रू फेसेस ओवर देयर?
So, PMJY Yojana obviously helps a lot of patients. I think that at least 40-50% of the patients would be such that if not this Yojana was not available, they would not have come forward and took treatment or get diagnosed. Having said that, there are some real challenges when we, as a community oncologist, treat patient because the framework is quite restrictive. The biggest challenge is that patient will come with a CT scan. We don't have any biopsy report or anything, and there is no way that PMJY will cover the investigations needed to diagnose a cancer when there is a suspicion of cancer. So that is a challenge, especially when you are not in a government institute. So challenges start there. Again, the second important challenge is the supportive treatment. When you are treating cancer, you see a lot of issues where it is not just chemotherapy or surgery or radiation to be done. but a lot of supportive care goes in. You need nutritional supplementation, you need psychological advice or consult sometimes palliative care advice, and all this is not covered unfortunately in Ayushman Yojana. So obviously, as I told, that at least 40-50% of patient would not have been treated or would not have reached hospital if this yojana was not there. But these are some points which should genuinely be taken care of. One important point is that see, we once for any molecule a patent is over, our is a country where pharma industry is very quick. They will come up with cheaper molecules, cheaper generics, which again can be catered in Ayushman. So for clinicians, they would be able to understand. We had a drug for breast cancer like palbociclib, which was 70 to 75,000, say in January, it is 5,000. Now, after 1 year of these generics available, it is still not covered in Ayushman. And this is a drug where you can, with the help of which you can delay usage of chemotherapy in breast cancer patients, which improves their quality of life and it improves survival also. So why not to add all these medicines once it is available? So it has to be a dynamic thing, but Ayushman Yojana, once the packages are made, I think the revision or update of the packages are not happening as it should be. Again, unfortunately, some rare malignancies are not covered in Ayushman Yojana, like neuroendocrine tumor or something like that. Though they are not common, but if treated, they can be controlled or cured for longer time. So that is something where oncologists, patient advocates, and everyone can chip in and probably say to the authorities that these are the treatments or these are the leg, and it is not like they're very costly. It is similar to other treatments which are available in Ayushman Yojana. So I understand that we can't have all standard of care, all the best possible treatment in Ayushman Yojana, but it is largely for a general population. But if not very costly but cheaper medicines are available and they can be made available under Ayushman Yojana, that would be of great help to the patients. So this is from patient perspective. The second perspective which we face a lot in our state is the management. The hospitals which run largely or are dependent on Ayushman Yojana, the cash flow is very erratic. Because cash flow is not appropriate, with time hospitals getting discouraged whether to work under this Ayushman Yojana or not. That is getting challenging for some hospitals to survive because most of their patients are under Ayushman Yojana. So that is also something which should be looked at from administrative point of view. I'm not the right person to tell that how it can be done, but sometimes 3 months altogether, and you continue to treat patients, you continue to spend on staff, you continue to spend on drugs, and you don't get the money to run the hospital. So that is something challenging for many of the hospitals.
Very valid, Dr. Saab, because खाली टैंक तो गाड़ी चलेगी नहीं, पेट्रोल तो चाहिए, and then it has to be continuously pumped in. And point well taken. Do you have any vague idea, like what do you, because this is one platform, we would be making white paper out of it that will be going to the NHA, Niti Aayog, and all the policy makers and other stakeholders as well. Do you have any recommendation, vague recommendation even, that how patient advocacy groups can pitch in between and can bridge the gap?
So see, there are some things which can be taken. I think that it is not their intent that they don't want to add something or they don't want to approve something. It is that message should reach them. How would someone know, or how would someone change if they don't know generics are available? So I'm not sure, but that is something which we can convey. We can convey the problems which we are facing. So probably all the oncologists who are working in such schemes, at least you form a group of them and they come up with their problems while they are treating patients. Patient themselves can tell the problem that in spite of this yojana, they have to spend XYZ amount on, say for example, nutrition, on this, on that. And if that can be taken care of, that is something which we as a community, both oncologists and patients, and that patient advocacy can help to imbibe. So at least we can send our message there. And I hope that because it is not very heavy on cost for them, they would be able to comply to most of the requests.
Thank you, Dr. Saab. That was a very nice perspective. And I'll come back to you because there is something that we really want to develop and we really want to help patients or other cancer patients at mass level in our country. And let me move to Mr. Sanjeev, who is founder of Lung Connect, and he also runs Utsaah Foundation. संजीव जी, जैसे डॉक्टर साहब ने बोला कि एडवोकेसी ग्रुप जो है वो बड़ी इंपॉर्टेंट रोल प्ले करता है और आप बहुत सारा काम कर रहे हैं लंग कैंसर में, हेड एंड नेक कैंसर में एंड इन ब्लैडर कैंसर. सो ये बताइए कि कितना आसान या कितना मुश्किल है एक पेशेंट एडवोकेसी रन करना. बिकॉज देखिए डॉक्टर साहब ने तो अपने चैलेंजेस बता दी कि भैया पेट्रोल नहीं होगा तो गाड़ी नहीं चलेगी. आपका क्या मानना है?
सो विवेक जी, मेरा आवाज आ रहा है?
बिल्कुल लाउड एंड क्लियर.
थैंक यू. सो थैंक यू विवेक जी. सब जैसे जिस तरह से डॉक्टर साहब बता रहे हैं कि चैलेंजेस है उनके लिए, उसी तरह से एक एडवोकेसी ग्रुप को भी चलाना बहुत चैलेंजेस है. सो इसमें खास के अगर हम बाहर के देश में बात करें और अपने देश में बात करें, जैसे कि कुछ दिन पहले मुझे भी पता चला कि एडवोकेसी क्या होती है, जबकि हम लोग कर रहे थे बहुत पहले से. अलग अलग तरह की जितने भी काम है सब एडवोकेसी के ही अंदर आते हैं, लेकिन अभी जाके पता चला है उसका असली महत्व. ठीक है. दूसरी बात है कि एज ए सच कोई फिक्स इनकम नहीं होता है जो भी एडवोकेसी ग्रुप चला रहे हैं. हाँ, तो एक कोई सैलरीड पर्सन नहीं है कि इनको कोई कंपनी है या कोई जैसे कि
फाइनेंशियल मोटिवेशन नहीं है.
फाइनेंशियल मोटिवेशन नहीं है कि कोई उनको फंडिंग दे रहा है या कर रहा है और वो सब अपना काम धाम छोड़ के और पूरा एडवोकेसी में लगे रहे. तो एक ये सबसे बड़ा चैलेंजेस है. दूसरी बात जो हम देखते हैं, जो कि पेशेंट की बात होती है, बहुत अच्छा, बहुत सारे पेशेंट हैं जो कि अभी अपने बात कर रहे हैं, बात को उठा रहे हैं एडवोकेसी में. लेकिन आप सोचिए कि जब भी हम कोई भी कॉन्फ्रेंस में बैठते हैं तो वहां पे बात होती है कि पर ईयर 14 लाख पेशेंट डायग्नोस्ड होते हैं कैंसर से. उसमें से कितने परसेंट सर्वाइवर है? 50% मानते हैं, 40% मानते हैं, 30% मानते हैं, किसी में 70% भी बोलते हैं. इतने पेशेंट जब इससे अच्छे हो रहे हैं और इसमें से जबकि सबको पता है कि फायदा आगे चल के सबको होने वाले हैं, फिर भी बहुत कम लोग आगे आते हैं इस चीज को करने के लिए. तो ये भी एक बहुत चैलेंजेस है जो कि हमें पेशेंट और केयर गिवर को आगे बढ़ के आना चाहिए. और हमारे यहाँ एक कहावत है, जब चुएंगे तो छाड़ेंगे, और जब वो काम हो जाती है फिर उस चीज को भूल जाते हैं. तो दोनों तरह से है कि एक स्टेबिलिटी नहीं है कि कोई ऑर्गेनाइजेशन की फंडिंग की कोई लाइफ नहीं है इसमें, कोई कैरियर नहीं है इसमें. और दूसरी बात, पेशेंट और केयर गिवर में बाकी देश की तरह अवेयरनेस नहीं है. जैसे अभी आपको पता है विवेक जी, पिछले साल हम गए थे मैड्रिड गॉल ब्लैडर कैंसर कंसोर्टियम को रिप्रेजेंट करने के लिए. वहां पे एडवोकेसी के लिए हैं बहुत सारे लोग, उनके स्पेशल सीईओ हैं, स्पेशल लोग काम कर रहे हैं, सब चीज उनका काम ही है सिर्फ एडवोकेसी करना. हमारे यहाँ अनफॉर्चुनेट अभी ये चीजें नहीं है, बट धीरे धीरे होगा. इंडस्ट्री आगे आएंगे, लोग आगे आएंगे, वो होगा. तो ये सबसे बड़ा दो चैलेंजेस है विवेक जी.
तो हमारे यहाँ जो काम फुल पार्ट टाइम है उनके यहाँ फुल टाइम है, और जो उनके यहाँ फुल टाइम हमारे यहाँ पार्ट टाइम है.
जी जी जी.
अच्छा संजीव जी, जैसे हम बात कर रहे हैं एडवोकेसी के जो चैलेंजेस हैं, ठीक है, नाउ मान लीजिए कि इतने सारे लोग देख रहे हैं, करीब 20,000 लोग जुड़े हैं हमारे पास. कोई अगर इसमें से यक्ष बन के सामने खड़ा हो जाए कि बोलो मांगो बच्चा क्या चाहिए, तो क्या 2-3 चीजें होंगी जो आपको लगता है कि जो अगर हमें मिल जाए तो हम बेहतर तरीके से जो है रन कर सकते हैं?
एक तो सबसे पहला टाइम चाहिए. जैसे कि सभी लोग यहाँ पे, मैं जितने देर से सुन रहा हूँ कि सभी लोग बोल रहे हैं कि डॉक्टर अपने तरफ से, जैसे अभी समीर सर बोल के गए कि मैंने अप्रोच किया, एक को मिला एक को नहीं मिला, 50% ये हुआ, चीजों को हुआ. तो सबसे पहले तो टाइम चाहिए जो पेशेंट और केयर गिवर हैं देने के लिए इसमें. दूसरी चीज फिर मैं वही बोलूंगा कि ऑर्गेनाइजेशन रन करने के लिए आपको पैसे की जरूरत है. तो जिस तरह से CSR या कोई भी ट्रस्ट आकर कोई पेशेंट बीमार है, उनके लिए मैं ही बोलता हूँ कि मुझे आज किसी को बोन मैरो ट्रांसप्लांट है, अगर उसको गाइड करना है, उसके लिए 12 लाख रुपया जमा करना है या 20 लाख रुपया जमा करना है, हम बता देंगे, गाइड कर देंगे, हो जाएगी। लेकिन अगर किसी एक नेविगेटर के लिए ढूंढना है कि वो महीने में 300 पेशेंट को हेल्प करते हैं, पर पेशेंट 100 रुपया का खर्च आता है, तो देने के लिए कोई तैयार नहीं है। चाहे जो भी रीजन हो, हम रीजन में नहीं जाते हैं। तो ये दो चीज, एक तो सबसे पहले जिस तरह से लोग बाकी चीजों के लिए व्यवस्था करते हैं, उस तरह से लोग इसमें भी हेल्प करना चाहिए, स्पेशली एडवोकेसी के लिए। और दूसरा है पेशेंट और केयर गिवर को टाइम देना चाहिए। और तीसरा, बिना डॉक्टर्स के सपोर्ट के हम लोग कुछ नहीं कर सकते हैं, क्योंकि उनके भी हेल्प, मेडिकल के भी लोगों की हेल्प उतना ही जरूरी है हमें गाइड करने के लिए। बोलो जी विवेक जी।
जी बिल्कुल, आई कम्प्लीटली अग्री, बिकॉज इवेंचुअली पेशेंट्स आते हैं डॉक्टर के पास और ट्रीट भी उनको डॉक्टर ही करने वाले हैं। वी काइंड ऑफ लाइक एडवोकेसी ग्रुप्स और forums like you and me, probably we need to bridge the gap and stay as a bridge amongst both the stakeholders. Now let me come to Dr. Kunal. Dr. Kunal, आपने सुना कि कितने सारे challenges हैं, डॉक्टर लेवल पे भी challenges हैं और एडवोकेसी लेवल पे भी challenges है। और ये challenges तो हम वो बात कर रहे हैं ट्रीटमेंट रिलेटेड challenges, और इसमें तो आप बहुत मुश्किल सा काम कर रहे हैं, मुझे ऐसा लगता है कि बिकॉज यू आर वर्किंग ऑन अर्ली डिटेक्शन एंड स्क्रीनिंग, how difficult it is, like what all roadblocks you get when it comes to early detection and screening, because as Sanjeev ji mentioned right away, like people are more willing to contribute, or be whatever way, be it financially, be it time wise, or any other way, for the treatment rather than early detection or something, because we take motor insurance 100%, but for our health we go to temple or whichever place of worship we have. So how difficult is your work? What all roadblocks you are facing, and do you think that patient advocacy groups can play any role in that?
Thank you, Vivekji, for having us, Karkinos, and thank you, Cancer Conclave and Dr. Kumar Professor. All of you all are instrumental in shaping this, especially the World Cancer Day, where Close the Cancer Gap is. And Vivek, you are right. You have hit the nail in the coffin. Everyone talks about early detection, but when we go and ask people to come forward for screening, there will be n number of reasons why they don't want to come. And per se, if I see historically, the disease is, how it has portrayed through the media, through the whatever media we say, whether it's a social media, print media, online media, it's always like C is equal to death. So पहला वो सी वर्ड सुन के लोगों को रहता है कि ओ इट्स डेथ, फियर, अनसर्टेनिटी रहता है. एंड इवन इफ व्हेन वी वांट टू, we know that there is an evidence that early detection save lives. Cancer can be picked up early. Few cancers we have a proper screening test which are available. Still they will not come as compared to other diseases when we talk about say diabetes or hypertension, where everyone will come forward कि okay, I need to check my blood pressure or I need to go for my sugar check. But when it comes to cancer, it is a lot of stigma still, fear. I think if we look from the other diseases, when in 1990s HIV was at the peak, the social media and was very revolutionized, and they really came forward with a very mass media campaigns where you destigmatize a particular disease. So same way we need to learn from the other disciplines and other practices key how this C word can be tackled. We all know the government reports that hardly 1 to 2%, except Tamil Nadu, where the percentage is high, hardly 2% people come forward for screening. And when we also rolled out our campaigns across the country, we started from in Karkinos, from Kerala and Manipur. We adopted the local cultural influences. In previous speaker also, when palliative care I was listening, is the volunteer support group. So Kudum Shri, the self-help groups. These are the champions who are there, who are existing networks which are available in our country. And if we can imbibe our programs to them, it creates a last mile. Coming to patient advisory group or patient advocacy group, I think they are the core. If you want to get certain things done, the PAG, patient advocacy group, would be at the forefront. And we have demonstrated the results. In previous role, we had created the, say, for tobacco, Voice of Tobacco Victims, which was the brainchild of Dr. Pankaj Chaturvedi from Tata Memorial Hospital. We created this forum for advocacy itself. And we were able to put government policies, whether it's, ban of smoking in public places, ban in gutka, educational sales. It has a wider impact at the policy level as well as at the state level, where the policymakers wants, okay, what you want, tell me what the policy is. So similarly, whatever materials we are designing, the advocacy group can give a lot of insights. When we design our a screening program, is this material communicating rather than being more confrontational or scary? Can this information be communicated in a better way? Can this be simplified so that the local people can participate? How can we engage them? And time to time, they can give a lot of vital insights which can change the program.
डॉक्टर साहब अच्छा पर्सपेक्टिव दिया आपने एंड आई एम रियली ग्रेटफुल टू यू। मेरा एक फॉलोअप क्वेश्चन है, यूं कह लीजिए कि जैसे आपने जैसे HIV की बात करी और स्टिग्मा की बात करी। हमारे देश में जब HIV की बातें करते हैं, आज HIV एक काइंड ऑफ हिस्ट्री हो गया, मतलब इट्स क्वाइट वेल एक्सेप्टेड थिंग। पोलियो तो अभी खत्म भी हो गया है, बट देयर प्रोबेबली लोगों को पता होता था कि भाई ये इसकी वजह से होता है, ये 1 2 3 4 कारण है उसकी वजह से होता है। कैंसर में ठीक है, लाइक देयर इज 1% ऑफ, जैसे आपने पंकज सर का नाम लिया कि मतलब वो इतनी बड़ी इनिशिएटिव चला रहे हो प्रिवेंटिव ऑन्कोलॉजी की, बट स्टिल इट इज नॉट 100%। सो उसमें स्टिग्मा एंड जब लाइक इफ वी कंपेयर लाइक जो पास में, बिकॉज दिस इज हाउ वी लर्न कि पहले क्या हुआ था, उससे कुछ सीखते हैं और आगे बढ़ते हैं। तो उसमें कैंसर को लेकर जो स्टिग्मा है उसको कैसे कम किया जा सकता है? दिस इज अ क्वेश्चन टू एनी ऑफ द पैनलिस्ट कैन shed light on, because we are going to work on these things and we need a lot of intervention, we need a lot of guidance and support. So when it comes to stigma, because देखिए कैसे हम कितना भी काम कर लें, जब तक डिटेक्शन अर्ली नहीं होगा, लोग the deaths, cancer will remain death sentence unless we detect them earlier and we screen. बट दैट इज अ वेरी बिग डील। लाइक आपने जैसे बताया कि जब स्क्रीनिंग की बात आती है, छोटे छोटे रीजन देके लोग आते नहीं है कैंप के लिए, जो कि फ्री स्क्रीनिंग होती है। उनके डोर स्टेप पे आप जाके करवाना चाहते हो तो भी नहीं आते हैं। सो हाउ डू वी लाइक, क्या वो 1 2 चीजें हो सकती हैं जो आपको लगता है कि फॉर ओपन फॉर एनी पैनलिस्ट?
You want me to go first? I'll go first.
Please.
Like, I think these forums, like what Vivek, you and Kumar sir is doing, is really, instrumental. And now, as you said, 20+ K people are seeing that. So the more we talk about, the more we share that it's normal to, and we all know that in every family, there will be one cancer patients, either family or relatives, yeah, in their neighborhood. It's not that कि पहले था कि कैंसर ये बाजू वाले का डिजीज है. It's not that कि मुझे नहीं होगा, बाजू वाले को होगा. Now it is that every person or has that experience. So the more we talk about it, now the recent budget also clearly says that vaccination for girls. So at policy level there is a thrust. At local level, state and the central level, the hospitals are coming up, and as a movement, participatory movement, the more we engage this, especially with the young generation, they are amenable to information. The way सोशल मीडिया हो गया है आजकल, टिकटॉक और रील्स ज्यादा देखते हैं रादर देन एक एंटी टबैको कैंपेन मुकेश हरने का. सो वी हैव टू लर्न कि क्या चीजें होती है एंड क्विकली एडप्ट एंड रिकोर्स आवर एक्शंस कि ओके ये चीजें चल रही है, हाउ कैन आई पेनिट्रेट माय मैसेज, हाउ कैन आई, इट्स नॉट ओनली अर्ली डिटेक्शन, इट्स डिटेक्शन है, डायग्नोसिस है, ट्रीटमेंट, फॉलोअप केयर, एंटायर जर्नी में ईच वे पे हाउ कैन आई डू माय best communication, which is non-confrontational, non-threatening. So one is that. And second, through a support group and through this initiatives where access to information can be given to the patient, whether not only the patient but caregiver also, ताकि उसको पता रहे कि ओके अभी मेरे को नेक्स्ट स्टेप ये करना है, आई हैव टू गो हियर और आई हैव टू डू 1 2 3. That will help us to bring down the cost significantly, because 2 things are there. One is the fear of death and second is the cost implications. Previously, the insurance segment covered extensively, but through this constant dialogue and your white paper with constant advocacy, I think we'll have some roadmap to go ahead. I'll pause here.
Thank you, Dr. Saab. Anyone would like to add, or we should move to the next question? Okay, so yeah, James, you wanted to say something?
Yeah, Vivek, I think Hope I'm audible.
Yeah, absolutely.
Yeah. I think we both have discussed this at one point of time in today's penetration of YouTube videos and digital media. I think we can use the advocacies, patient advocacies, and can use the patient survivors as their ambassadors of the good news. Like Dr. Kunal is talked about fear. There's a lot of fear even among the educated society, even in metro cities. I have a friend of mine, PhD in organic chemistry. His own wife, well-educated lady, ignored all the early signs and finally had a very dismal prognosis. Dr. Kunal was mentioning about the early signs, early detection. Many of the people ignore because of the fear. I mean, they are compelled to ignore because of the fear. So we need to get out of this fear psychology only through positive messages. And Dr. Kunal also pointed out another psychological aspect, that this cancer as a word is always related to death. I think we need to change that. We need to give a positive outlook that there is a lot of hope with the kind of immunotherapies and the CAR T cells and the kind of therapies which are coming out. The survival graph is always looking brighter and brighter day by day. This message, instead of you and me, or instead of a medical professional talking about it, if patients could talk as an ambassador of this good message, I think the reach will be better. And we have been using digital media to a great extent in this front, but there could be some limitations when it comes to rural, wherein advocacies can have their own regional or their local groups to take it forward.
Thank you so much. Thank you so much. It's very valid thing, and I think probably if Sanjeev is also here, we quite a lot work together, and probably taking the cue from your statement, we think that we are moving in the right direction. And let me come back to Chitra. एक सवाल है, जब कैंसर की बात करते हैं तो बड़ा ही कॉम्प्लेक्स चीज है ये। मतलब जैसे मैं वो यक्ष की बात कर रहा था, तो अगर यक्ष आ जाए तो आज यक्ष भी परेशान हो जाएगा, यार इनको ये भी चाहिए, ये भी चाहिए, ये भी चाहिए, ये भी चाहिए, इतनी सारी चीजें हैं मांगने के लिए। सो जहाँ एक तरफ एकोमोडेशन से लेकर खाने तक के चैलेंजेस होते हैं, लोगों को ट्रैवल करने के चैलेंजेस होते हैं, दवाइयों के चैलेंजेस होते हैं, बहुत सारी चीज़ों के चैलेंजेस होते हैं। तो एक कंपनी जैसे फाइजर को आप रिप्रेजेंट करती हैं, तो मतलब कुछ ऐसे इनिशिएटिव्स हैं जो आपको लगता है कि हमारे प्लेटफॉर्म के माध्यम से लोगों को जानना चाहिए कि इस तरह के कंट्रीब्यूशंस हैं, एंड आप उम्मीद बनाए रखिए।
Thank you so much, Vivek, and thank you so much for inviting for this conference. I'm hearing it for last few hours since its beginning, and it's really a fantastic discussion which is much needed to continue and more regularize. So answering to your question, and first of all, the topic of this panel is PPP, public-private partnership, which we generally use it's a cliche. And I think one P is missing here, which we all are talking about, the public, private and patient partnerships, which we are discussing. And, and what you're asking is like, there are so what we do. No, but that partnership is very, very important, because that is whatever we do, or as a government, they do, everything is around patient. And your voice is very important as a patient. And that has to be represented, and that's getting even more stronger with this information and right kind of capacities and empowerment of the patient groups. So when you talk about the hope and the kind of things which we do when it comes to the access programs, maybe I can just talk about that little bit. So as a pharma company, and the cost and affordability are mostly talked about. Access and affordability and coverage, which so far has been discussed in every panel, and you are going to discuss this again in the next panel also. I think to do our bit, we have, and not only we, means entire industry has innovative access programs around their therapies, and where we support patients, those who are inadequately or not covered by any scheme or a private or public scheme. So and paying mostly out of the pocket. So that in those cases we have patient assistance programs, where part of the cost of the treatment is borne by the patient, and part of the cost is borne by the company, and that helps the affordability piece. And as we are growing, having more coverage by and I hope this discussion is going to really lead to a lot of advancements and hopes in future. And Dr. Prakash, as he has just upfront offered his support in designing new packages, I think it's going to be very bright. But when it comes to patient assistance access programs, we are trying to support as many as patients through this model where we lift part of the cost and patient lift part of the cost. And the patient groups certainly have a big role in partnerships when it comes to the patient access programs, because your voice is very, very important in this case. And some information dissymmetry is and your voice is missing, because in this case we are not the one who are dealing with the patients, or we are in touch with the patients who are getting benefited. Because of our regulations, we are dependent on the third parties who deal with these things. And so in this case, like we don't know, except numbers, we don't know what is the impact. So I think the patient groups will be very important to help us in getting the impact and talking about this broadly, so that these programs have a long life. These programs have ability to support many more people, and they are continued in the long term. So this is something. And apart from that, there is a lot around in these programs, the patient access programs, because as I said, it's the third parties who implement these. So there's a whole cycle around these programs where the enrollment happens, validation happens, then the dispensation, the distribution of medicines happens, and there are various chances of where patient is finding any challenges, and whether the time or the process, cumbersome process. So again, as a patient groups, the representation of the voice, where you can talk to us, you can let us know what are the challenges you are facing, and we can always help improving the efficiency of this entire process in a patient-friendly way. So these are a few points, if that answers to your question. And means I can say, like, we have also discussed a lot in previous panels about various funding mechanisms. So there are possibility of even reducing the burden which is currently there in patient access programs or otherwise, who are not even able to get this support of access programs also. So there are various ways where you can create the fund, where the means if I think upfront, like their superannuation fund was discussed, CSR fund is anyways supporting. So there are various ways where funds can be created, where the interest-free loans can be given to the patients. So means I think these innovative financing models are very, very important to be discussed, and you will find a lot of practices around you which can be then taken forward from other disease areas, or means within the cancer itself, from country outside the country, that can be explored.
जी, जब हालांकि हम यहाँ पे बड़े एक्सपर्ट्स के साथ में बात कर रहे हैं, लेकिन इस प्रोग्राम को मैंने जस्ट अभी थोड़ी देर पहले स्क्रीन फ्लिप किया था, तो देखा करीब 25,000 लोग हमें वॉच कर रहे हैं लाइव ऑन यूट्यूब स्ट्रीम। तो बड़ी रिस्पॉन्सिबिलिटी के साथ हम यहाँ पे ये बातें कर रहे हैं, और आई एम सो ग्रेटफुल टू ऑल ऑफ यू फॉर कॉन्ट्रीब्यूटिंग एंड मेकिंग सो मच सेंस दैट सो मेनी पीपल आर अलाइंड। बिकॉज मुझे नहीं लगता कि कैंसर कॉन्क्लेव जैसे इवेंट को कोई जो है नॉर्मल आदमी या कोई एंटरटेनमेंट के तौर पे तो नहीं देख रहा होगा। आई एम श्योर दे वुड बी सीरियस पीपल। जेम्स जी, लेट मी कम बैक टू यू विद, जैसे हम बात करते हैं, जब एक्सेस की बात करते हैं, तो एक्सेस में ना, वैसे तो हम देखिए, हम बात कितनी भी कर रहे हैं आज केयर की, जैसे अभी डॉक्टर साहब ने बताया कि कितना भी कुछ हो गया है, लेकिन कैंसर जो है वो डेथ सेंटेंस तो है। मतलब हम लोगों के लिए, डॉक्टर कुमार ने भी शेयर किया था कि भाई जब एक वो पर्सपेक्टिव होता है, जब हम टेबल के उस पार देखते हैं तो चीज़ें अलग नज़र आती हैं। जब एक्सेस की बात करते हैं तो दवाई का जो है बड़ा महत्वपूर्ण स्थान है। इट्स वेरी इंपॉर्टेंट प्लेस और वेरी इंपॉर्टेंट पार्ट टू प्ले। सो what all are the things, like if we are trying to reduce the cost, there could be multiple ways, like one thing, as Dr. Chitra said, that part payment kind of thing. There are people who are donating nutrition things and other things, so to reduce the cost there could be a lot of things. But since your expertise and domain is into manufacturing or the pharmaceutical or especially cancer, and NATCO is a very premier name, like you had been serving the industry for quite many years, and very successfully. So what do you think that while when it comes to access to the drug, are we done enough? Like, the cost reduction and other things, are we done enough, or there is still scope of doing something, or how do you take this?
So when you talk about access, a lot has happened between 2003 and now, probably 21 years. Why I'm taking 2003 as a point in the history, because that's when the first targeted therapy was introduced, which brought in a sea change. And subsequently, a lot of oral as well as injectable targeted therapies came in. And that's what increased the survival graph in most of the cancers. So that's why I've taken 2003. Between 2003 and now, there's a lot of things have been positively done in the aspect of pricing. So I'll take example, one of the product which was introduced in 2003, which has completed 20 years now, that's in CML, costed 1,10,000 per month of therapy. I'm sorry, for a month therapy. And this drug needs to be taken lifelong. And the generics brought it down to 10,000 Indian rupees. And today it is available for 900 Indian rupees, even from a reputed company. So this is possible, and this is what has happened with all the synthetic drugs, the synthetic chemistry-based drugs. This is what has happened. To that tune, the price has been reduced. But at the same breath, I would like to say that you cannot stretch it beyond this. It is literally, the industry is bleeding. That's the kind of word I would be comfortable in using. It is not from a sense of revenue or profit, but from a sense of viability. You cannot, for that example, the drug which I said, you cannot go down below the costing of 900 rupees to the patient. It's to the brim, it's to the seam, and anything below that, it's going to put many things in question. So coming to the next set of drugs, the conventional monoclonals, yes, the biosimilars have brought down the price. Similar to what I said, it's not 900. You'll have to take the technology, the wastage, the build-up, everything into consideration. If you do that, most of the biosimilar monoclonals, the conventional ones, have been brought down in a range of anywhere between, let's say, 9,000 to 15,000. From a initial price of, let's say, 1.5 lakhs or 1 lakh. So again, the price has been brought down to the point of affordability. And if you talk about immunotherapies, and if you talk about antibody drug conjugates, currently they are available at about 75,000 rupees per month. With all the best access programs, still they would cost 75,000 rupees and above. Few exceptions could be there. Most of them are in that range, what I said. So keeping into consideration the kind of survival graph, which the impact on the survival graph they have brought about. Let's say the patient is going to take it in an adjuvant setting. The period he is going to take is quite long, or maybe in a maintenance setting, it's going to be quite long. So definitely there's a need for biosimilars in that segment. But again, it may not come down below 20,000. But the question to be answered is, there are patients who are getting treated in corporate hospitals. There are patients who are getting treated in teaching institutions like AIMS, TMH, or Kidwai, or Adayar kind of centers. They are totally different from the corporate clientele. And there are also patients who are getting treated in state-run centers, which is typically run by the procurement of the state medical corporations and the government hospitals. And there's a small set of patients. If you want the percentage, roughly around 35 to 37% of patients are getting treated in the state-run centers, and around 28% of patients are getting treated in the premier teaching institutes, and around 30% of patients are getting treated in corporate, and 5 to 7% of patients are getting treated in the panel. That's the ESI, CGHS, railways, DGFMS, and all those. So if you look at the segment of panel patients, everything is borne by their employers. If you look at both the state-run government hospitals as well as the premier teaching institutions, the availability of Ayushman Bharat and the state-run schemes have eased the access to a great extent, but you cannot expect government to spend for everything when drugs are so expensive, especially the immunotherapies. The pharma companies, both the multinationals as well as the Indian companies, have done justice to the pricing to a very great extent. But if you really explore the possibilities, yes, it does exist in immunotherapies and the newer therapies that are yet to come, but not in the synthetic chemistry drug. Now, talking about corporate hospitals, yes, there is an inbuilt affordability in that class of patients. But coming back to immunotherapies, even a biosimilar wouldn't make it possible less than 20,000 per month. And it is not viable. It is not going to be viable for any company to operate below 20,000 price point. If that is so, then how do you take this therapy to, let's say, Ayushman Bharat? How do you take it to state-run hospitals? How do you take it to the patients who are getting treated in premier teaching institutions? That's the place where health insurance, as a community, we need to, as an Indian community, we need to embrace health insurance at this point of time. If you look at CAR T cell therapy, even in a relapsed refractory setting of lymphomas or ALL, there are patients, including the first patient, Emily Whitehead. She's living for, let's say, more than a decade plus she's alive, and the response, the drug has been a living drug in the body. Do you think it can be brought down below 1,000 rupees? It's simply, I mean, even in dreams it happens. So the point I'm trying to make is there is a limit to bring down the price where the viability exists. So the affordability is not going to define access to treatment. Access to treatment is multifactorial. I mean, affordability is one part of that composite. And if you give anything free, unfortunately, the importance is lost. Sometimes I'm not cynical about it, but then
I agree.
Sometimes sometimes it loses its significance to a great extent. That's why I strongly believe that all of us should work together in bringing the right kind of awareness among people. Before going to awareness, when you talk about access, affordability is just one factor of that multifactorial thing. So the major thing, before you talk about treatment, you need to diagnose. Do we have the infrastructure, especially in a rural area? This is where recently, 1 month back, the central government has announced a plan that they will set up basic diagnostic capability in all the primary health centers and then refer the patient to the district or the regional cancer center. This is going to improve your access to the treatment. And the second thing is the point which you all talked about a little earlier, awareness. Awareness is complicated by a lot of local practices, social practices, cultural practices, and most importantly, the myths and the misconceptions that are working against even a simple procedure like a biopsy is questioned. People believe that once you take a biopsy, there's a lot of tumor spillage and the tumor will spread to different parts of the body. I mean, in 2023, people are not willing to do simple investigation like biopsy. So where are we in a scale of awareness? Probably in 1 or 2. So we need to increase the awareness by busting all the myths and the misconceptions, not only in rural and semi-rural, even in urban areas, even among the educated public, lot of misconceptions. So we need to bring in a lot of awareness. And of course, the infra which we talk about at the primary health center, there should be some modality to diagnose at the early part of the disease. And Dr. Kunal has emphasized on the screening part. Today, people are screening for breast cancer and head and neck cancer. But how about other cancers? Cervical cancer. Somebody mentioned about the vaccination program, which was announced. I think we are on the right track, but then the pace at which we are moving versus the pace at which cancer is advancing. Somebody talked about 14 lakh cancer cases as incidence. That's based on the community-based and hospital-based cancer registries. It's an extrapolated data. It's not a real-time data. And many of the oncologists feel that we will be having an incidence of 20 lakhs and above per year. So that puts the prevalence probably 40 lakhs and above. So the WHO has said that 1 out of every 10 Indian is at the risk of cancer. And today, 4 out of 10 Indians have a fatty liver. It need not progress to cirrhosis. The risk of transforming into a HCC is quite there. So when you look at different compartments, different tissue-based cancers, everything is progressing at a fast pace, whereas our awareness, our infrastructure is not up to the pace. But having said that, I would also like to congratulate the efforts taken by the central government. States like Northeast, I mean, many of the sister states in 7 sister states in Northeast were lagging behind many of the other states. But today, if you go to Assam, you have Assam Cancer Center-based, government-supported cancer treatment centers almost in every city. I don't know how many of them have heard about Barbeta or Jorhat. Dibrugarh, definitely everybody would have. Tezpur, people would not have heard about. Today, you have cancer centers there. It's because of the single-minded focus to get out of this cancer. Because this is a state, I mean, both West Bengal as well as Northeast. In the early 2000s, they used to travel thousands of kilometers to either Mumbai TMH or to the southern cities, southern states. But today, they need not travel even to Guwahati. They can get treated in their respective states. So definitely government has also made a lot of progress. Probably the pace at which we build the infra to diagnose and treat would make a considerable difference to access to treatment. It is not necessarily affordability. Affordability is stretched up to the seam because I've been part of this industry. I mean, this oncology for the last 20 years and industry 30 plus years. And I know where viability becomes a non-existent thing. And in fact, not just multinationals, even Indian companies, generic companies have withdrawn many products because of non-viability. Cancer is not like a cough syrup or an anti-inflammatory with huge unit volume. When you have a huge unit volume turnover, you can have least margin and you can operate. But in oncology, hardly 25% of patients get treated out of the incident population. When we talk about, let's say, either 14 lakhs or 20 lakhs as incidents, in 2000, hardly 10% was getting treated. Today, for a palpable tumor like breast, maybe 30% is getting treated. For a visible tumor like head and neck cancer, maybe 35% or 40% is getting treated. But those tumors are not visible, not really bothersome. They blow up in the last stage. Let's talk about acute myeloid leukemia or any type of leukemia. It doesn't really bother you till it really shows up in the last stage, or a pancreatic cancer.
Correct.
The percentage of patients getting treated is very less. Some of them are as dismal as 15%. Some of them are 20. That's how even today in our country, out of the incidents, only 20-25% average consolidated is getting treated. This is where we need to improve. This is where we need to build up the infra, I mean, spread more awareness, bring in more hope around the cancer treatment. I mean, talking about the pricing, which you expressed as a concern, I think the industry together, both the multinationals as well as the Indian companies have done their best in bringing the product at the best possible price. Maybe immunotherapies in the days to come will definitely see such kind of a price reduction. Over to you.
Thank you so much, Mr. James. And I see my fellow, subsequent moderator Ratna ji being here, and I'm having some pressure because we are running late because the discussions are so interesting and so intense that you just cannot pull out in between. We have to do a lot of work, and we'll keep meeting, we'll keep discussing. But before I wrap up my session, I have two small questions. Maybe we'll try to answer in 2-3 minutes. One, I'll come to Chitra. Chitra, because you are associated with, you had been part of various public policy organization, and you have done a lot of work in that direction. What do you think that pharma companies and patient advocacies के बीच में किस तरह का collaboration हो सकता है? What all are the things, like maybe a couple of examples if you have.
See, there are already so many examples, Vivek. So one example I gave you, like to adhere the patients to the therapy, to continue the treatment. There are a lot of things, even means as a practice, we have, we are very patient-centric company, and we always try to gather patient insight, because that is something is very, very important what you are preparing for somebody, even if it's a small literature or awareness material. You have to hear what patient is, whether they are able to understand or not, right? So it is a very simple to complex examples. And now when you're talking about Ayushman Bharat, insurance, I think there are a lot of things, even the innovative funding, global practices, there are a lot of ways the the advocacy groups can be strengthened and empowered by various stakeholders, not only pharma companies, but various other stakeholders, like Maulik was there from a financial, this economic background. There are possibilities, various models of collaboration. We collaborate in various ways. For example, Sanjeev ji knows when the COVID time, there was no channel, and most of the people at that time were facing a lot of same problems, and somebody supported. So it's in lung cancer case, probably we and few companies supported. So there was a need to establish a quick channel where patients who were struggling to get the prescription, right? So they needed some channel to get their prescriptions, consultations. So then the entire e-platforms and everything came up. So there are various ways, even the empowerment, capacity building, small things in very minor. We may think it's a small matter to how to do a Zoom meeting, but not for everybody. Right? So there are so many things where we collaborate. Recently, we have launched a global platform, which is Patient Advocacy Leadership Collective. And that is all basis on the input and surveys of the patient groups in more than 25 countries and more than 170 patient advocates, where we have collected what they need when it comes to capacity building. It's not me who deciding what you need. Actually, you should say what do you need, and then a collective representation. Basis on that, course has been designed by various universities, more than 50-60 courses, and those courses are also endorsed and designed by the patient advocates with the help of experts, and now patients groups are going to use those things. We have our help desk in more than 14 hospitals, COEs in country, the Asta help desk. Again, that's a patient navigator tool where we have touched, I have some data, more than 104,000, means it's the October data, where we have touched more than 1 lakh caregivers, more than 3 lakh patients, and helping them into accessing the, what are the different financial options, what are the places you can go, how to navigate the entire hospital, then, counseling. So there are a lot of things where partnering and possibilities to partner across the spectrum, whether it is awareness, whether it is advocacy, early diagnostics, and education, empowerment. The possibilities are enormous. It has no limits. Thank you.
Thank you so much, Dr. Chitra. संजीव जी, एक लास्ट सवाल, बिकॉज देखिए पेशेंट एडवोकेसी या सपोर्ट ग्रुप, ये जो चीज़ें हैं हमने अभी शुरू करी हैं, शुरू इसलिए क्योंकि मतलब ये 20-25-30 साल पुरानी नहीं है, इन लास्ट फ्यू ईयर्स इट हैज़ इवॉल्व, एंड मुझे लगता है कि आप भी एग्री करते हैं कि बहुत काम अभी करे जाने की ज़रूरत है. देयर इज़ अ लॉट टू बी डन. सो जो नए लोग आएंगे या जो लोग हमसे जुड़ना चाहते हैं, साथ आना चाहते हैं, उनके लिए क्या संदेश देना चाहेंगे आप?
जैसे आप बोल रहे हैं बहुत करने का, सपोर्ट ग्रुप, फिजिकल सपोर्ट ग्रुप तो हम लोग चालू कर दिए थे 2008-9 से ही होता था, लेकिन ऑनलाइन, जिससे चित्रा जी बोल रहे हैं, ऑनलाइन सपोर्ट ग्रुप हम लोगों ने कोविड में चालू किया. 1 मिनट लूंगा आपका. जैसे जेम्स जी ने भी बोल रहे थे कि रूरल एरिया में कैसे करेंगे, तो सपोर्ट ग्रुप हम चालू कर दिए थे. और जो हमारा यूट्यूब का चैनल का जो आइडिया आया था, हमें रूरल से ही आया था. मैं गांव गया था और घर से मैं जब सो के उठा और मेरे घर में 3 लोग खाना बना रहे थे और तीनों यूट्यूब ऐसे देख रहे थे। हाँ, तो सोशल मीडिया मुझे पता था, लेकिन मुझे वहां पे लगा कि यूट्यूब
इतना गजब का रीच होगा वो नहीं पता
इतना,
था।
हाँ हाँ, वो वही चीजें हैं। और वो आके फिर प्रभात थे, मैं था, विवेक थे, कुमार सर थे, हम लोग ने बहुत सारे लोग बैठे और डिस्कस किए। एंड 1 साल में हम लोगों ने यूट्यूब लंग कनेक्ट के यूट्यूब चैनल पे लगभग 100 से ऊपर वीडियो डाले हैं लंग कैंसर के बारे में, एजुकेशन वीडियो, और जो भी है हमारे ऑथेंटिक डॉक्टर के द्वारा है। और यही चीजें यहाँ पे डॉक्टर कुणाल बैठे हैं, मिस्टर बैंकट से मेरा बात हो रहा था कि 2025 लास्ट तक जितने लोग लंग कैंसर में गूगल को सर्च करते हैं उससे ज्यादा लंग कनेक्ट को सर्च करना चाहिए, इतना हम ऑथेंटिक उसमें चीजें को दें। तो ये रूलर का था। दूसरी बात है विवेक जी, सबसे बड़ी बात है ना कि कोई भी, बहुत सारे ऑर्गेनाइजेशन हैं, पेशेंट हैं, आप देखेंगे, हम तो देख रहे हैं हिंदुस्तान में, मैं 20-25 साल से इसमें हूँ, 2-3 लोग ही देश को प्रेजेंट कर रहे हैं इतने सालों से। हाँ, 3-4 आदमी से ज्यादा नहीं मिलेगा आपको, चाहे वो पेशेंट हो या फिर ऑर्गेनाइजेशन भी हो। बाकी जो छोटे छोटे अपने काम करते हैं और उसमें लगे रहते हैं चीजों को। तो सबसे जरूरी है कि अगर यूनाइट होना है हमें, एक एक साथ ये सारी चीजों के लिए कुछ चेंजेस लाना है, तो एक होना पड़ेगा सबसे पहले। अकेले हम कुछ नहीं कर सकते हैं, ज्यादा से ज्यादा हम ये कर सकते हैं, ये बन के ही हम लोग कुछ कर सकते हैं। तो सबसे बड़ी बात यह है। दूसरी बात, मैं जैसे पहले भी बोला था कि टाइम निकालना पड़ेगा, सब पेशेंट को खास के बात है जो है, और इंडस्ट्री को साथ देना पड़ेगा, चाहे वो CSR हो, ट्रस्ट हो या फार्मा इंडस्ट्री हो। और जो डॉक्टर का तो साथ होता ही है, वो लोग तो चाहते ही हैं कि जितने अच्छे से हो सके।
जी,
ठीक है, थैंक यू।
thank you so much, Sanjeev ji. And I think we tried to understand that how we, like industry and other, public patient partnership, rather, rather than only the policy, because सरकार तो अपना काम कर रही है, but सरकार को उसके काम को और अच्छे से implement करने के लिए how we all can come together and we can create a, or rather co-create a community that empowers everybody till the last mile. Thank you so much.
एक लास्ट चीज विवेक जी मैं बोल रहा हूँ कि मैं, कैंसर एक ऐसा जंग है जिसमें अगर कोई भी सपोर्ट कर रहे हैं थोड़ा सा भी, उन सबको मैं सैल्यूट करता हूँ। लेकिन यहाँ पे मैं ये शब्द भी बोल के जाता हूँ कि ये ऊंट के मुंह में जीरा का फोरन है। इतने भी चीजें हो रहे हैं ना अभी, बहुत कुछ। आप एक बार साथ बैठ के देखिए, उस पेशेंट के साथ में, उस फैमिली के साथ में। ये कोई जंग नहीं, ये वर्ल्ड वार है कैंसर का, जिस घर में होता है। हाँ, तो ये बहुत अभी काम करना बाकी है, और सिर्फ फंडिंग का नहीं है, उसके अलावा भी बहुत सारी चीजें हैं जो कि हम उनके साथ पग से पग मिला के चल सकते हैं।
जी, thank you so much, Dr. Chitra, Dr. Kumal. Yeah, Mr. James.
Yeah, Vivek, just one last quick word.
Please.
When we talk about closing the care gap, it's all about equitable care. So the equitable care with respect to India, it's not just the numbers. Of course, numbers are priority because out of 20 lakh or 14 lakh cases, probably 20% is getting treated. So when we talk about the quantitative aspects, let us also talk about qualitative aspects. Quantities and qualities have to travel parallelly as far as the treatment of cancer is concerned. Because when you talked about stretching the prices, I want to bring in quality. One question that all of us have to answer is, at what price you want to buy or at what quality you want to buy? Like the same drug at the lowest cost, can it be approved by an US FDA regulatory or an European regulatory? That is also important because we don't want the cough syrup fiascos which we came across. As a country, we could be a pharmacy for the globe, but then we also need to take care of our quality. I mean, it was just a small speck, but still it matters. I mean, it brought down our image. And we need to be, when we talk about closing the care gap, the equitable delivery of care also talks about the quality of care, which it also should be equitable. So talking about the pharma industry, please don't talk about the price alone, also talk about quality products, quality companies, because it is a matter of pride for India.
True, absolutely.
That's where I want to start. Thank you.
Absolutely, and I really respect it because it's a very important point, because it's a herd mentality, you know, like we keep going behind L1, but is L1 really L1 or it is not? Well, thank you so much, Mr. James, Dr. Chitra, Dr. Kunal, Mr. Sanjeev. It has been wonderful speaking with you all. It's a very small time that we could devote today, but the journey continues. We keep meeting, we keep discussing, and we keep evolving together. Thank you so much. And
Thank you. Thank you.
Thank you so much.
Thank you. And now I would like to invite Dr. Ratna Devi, who is representing Daksham, which is a patient advocacy forum. And Ratna ji, please take the lead and invite the panelists.
Thank you, Mr. Vivek. And being the last panel, I have the challenge of keeping everyone engaged on a Sunday evening. But the closing remarks from James were very revealing. I mean, not only about the fact that only 20% of patients are actually receiving treatment, but also that quality has to take center stage, and it is not just the numbers that we are talking about. On my panel today, and we will be discussing the topic, can advocacy groups facilitate for optimum implementation and usage of government schemes? And a lot has already been said about what patient groups can do, why there is a gap, and what kind of work that patient groups can take. Sanjeev ji has said a lot about how to get patient groups together, why it is important to unite all the patient groups. But what we would like to understand is there are several government schemes, and are patient groups aware of these government schemes? If they are aware, are they advised about the choice that is available to them? And are they able to avail the full benefits of these government schemes? If not, what can patients and patient groups do to increase the optimum implementation and usage of these government schemes? I have four excellent panelists with me. Joining me is Mr. Jaikumar Mane. He's a medical social worker from Tata Memorial Hospital, Mumbai. Welcome, Jaikumar ji. I also have Dr. Arun Chandrasekharan. He is a medical oncologist from Aster Calicut, Kerala. And Dr. Arun, welcome to the panel. I have Miss Vandana Gupta, who is the founder of WeCare. Welcome, Vandana ji. I also have Dr. Ramana, who has kindly stayed back and agreed to join us on this panel. Miss Urvashi, who was my panelist, has joined an earlier panel because she had some other commitment. So thank you so much for joining today. And we've heard a lot about the availability of government schemes. And I will start my first question with Mr. Jaikumar. Jaikumar, you worked in one of the largest hospitals that offers cancer treatment. तो आपके hospital में कौन-कौन से schemes available हैं? और ये schemes क्या सभी को उपलब्ध हैं और नहीं है तो क्या challenges हैं?
थैंक यू पहले मैं विवेक और उसकी टीम को इनवाइट करने के लिए, और थैंक यू मैडम। मैं हॉस्पिटल में जो हमारे स्कीम है ये आयुष्मान स्कीम ये तो चल रहा है। उसके साथ महाराष्ट्र में ये हॉस्पिटल है तो महाराष्ट्र के लोगों के लिए एक महात्मा फुले जन आरोग्य स्कीम है, वो भी चल रहा है, जिसका राशन कार्ड महाराष्ट्र का रहता है तो उनके लिए ये रहता है महात्मा फुले स्कीम। उसके साथ बाकी जो स्कीम रहते हैं, जैसे अभी उड़ीसा का है तो बिजू कार्ड चलता है, गोवा का मेडिकल फैसिलिटी रहता है तो उनका अगर रेफर लेटर लाया तो उनके पास से भी होता है। तो ये जो अभी स्कीम चल रहा है ये तो चार चल रहा है। उस हिसाब से हम उनको एनरोलमेंट करके आगे का उनको मेडिकल फैसिलिटी प्रोवाइड करते हैं। आयुष्मान में बहुत सारे लोगों का क्या रहता था कि पहले यहाँ पर उनका एनरोलमेंट हो जाता था और उनका ट्रीटमेंट दिया जाता था, लेकिन अभी वो एनरोलमेंट यहाँ पर बंद कर दिया है क्योंकि बहुत सारे बोगस ऐसा कार्ड बनते जा रहे। तो अभी वो एनरोलमेंट उनके राज्य में होता है, तो उस वजह से क्या होता है कि पेशेंट पूरी तैयारी के साथ इधर ट्रीटमेंट के लिए आता है और उनका प्लान जब होता है तो वो पता चलता है कि वो कार्ड उधर बनाने का, तो बहुत सारे फैसिलिटी नहीं ले पाते हैं। तो हमने हॉस्पिटल में अभी एक नया सॉफ्टवेयर डेवलप किया है कि वो पहले दिन से ही उनको उनका एनरोलमेंट है क्या नहीं, उसमें क्या प्रॉब्लम में डॉक्यूमेंट में वेरीफाई किया जाता है और उसमें कुछ दिक्कत है तो उनको उसी टाइम गाइड करके ट्रीटमेंट चालू होने के पहले जो 15-20 दिन का जो गैप रहता है उसके पहले उसका एनरोलमेंट पूरा करके जब ट्रीटमेंट प्लान हो जाएगा उस टाइम उसको कैसे एनरोल करके उसका फायदा उसको ट्रीटमेंट में कैसे दिया जा सकता है। ऐसा एक सॉफ्टवेयर बना है, जैसे कि कोई पेशेंट पहले दिन हमारे पास आता है तो हम उनको ऑनलाइन रिक्वेस्ट डालते हैं। आयुष्मान और महात्मा फुले काउंटर जो बना है वहां पर एक ऑनलाइन रिक्वेस्ट डालते हैं, एल्गोरिदम सॉफ्टवेयर का नाम बना है। तो रिक्वेस्ट डालने के बाद वो पेशेंट वहां पर जब जाता है तो वो चेक करते हैं कि किस लिए पेशेंट भेजा है, तो वो रिक्वेस्ट एनरोलमेंट के लिए, तो उसका सब डॉक्यूमेंट वेरीफाई होता है। अगर एनरोलमेंट हुआ है तो हमें दिखता है कि इसका एनरोलमेंट हो गया है, तो नेक्स्ट रहता है कि इसका ट्रीटमेंट अगर प्लान हुआ है तो उसका ट्रीटमेंट में बैठ रहा है कि नहीं देखने के लिए बोलते हैं। तो वो उसके सब ट्रीटमेंट प्लान डॉक्टर से लिख के लाने के लिए बोलते हैं। अगर वहां से रिजेक्ट हुआ तो हमें पता चलता है कि वहां से रिजेक्ट हुआ है, तो हम हमारे हॉस्पिटल में जो अलग अलग गवर्नमेंट स्कीम है, नहीं तो हॉस्पिटल फंड है, ट्रस्ट है, उनके माध्यम से हमको उनको देते हैं। सेल्फ पॉकेट जितना बचा सके वो हमारा प्रायोरिटी रहता है। तो ये एनरोलमेंट जैसे पहले 30% तक होता था, अभी 50-60% के ऊपर जा रहा है और आगे भी हम 100% करने की कोशिश कर रहे हैं।
थैंक यू।
ये एक
हाँ जी, ये तो बहुत बढ़िया आपने बताया। आपने जो एनरोलमेंट किया है, अब हमें ये भी पता है कि कैंसर्स भी कई तरह के होती हैं। तो जो आपके महात्मा फुले स्कीम है या फिर आयुष्मान भारत स्कीम है, इसमें सारी कैंसर्स कवर होती हैं कि कुछ ही होती हैं? और जिनका नहीं होता है उनके लिए आप क्या करते हैं?
जैसे आयुष्मान का है वैसा ही ये है कि जैसे केमो रहेगा तब 5000 देते हैं, कुछ केमो के लिए थोड़ा ज्यादा अमाउंट रहता है उसमें, और इसमें ज्यादा डिफरेंस नहीं। सिर्फ ये महात्मा फुले रहता है वो 1.5 लाख तक सपोर्ट करता है, और उसके बाद फिर आयुष्मान का फैसिलिटी वो यूज कर सकते हैं जैसे 5 लाख रहता है। लेकिन जो ट्रीटमेंट रहता है उस हिसाब से उसको सपोर्ट मिलता है। 100% ऐसा कोई भी नहीं मिलता। जैसे अगर सर्जरी उसमें बैठ रहा है तो आगे का सपोर्टिव केयर उसको नहीं बैठ रहा है, तो उसके लिए वो पेशेंट हमारे पास आता है। जैसे कि केमो रहेगा तो केमो ज्यादा अमाउंट का रहेगा तो उसको वहां से हेल्प नहीं मिलता है, तो हम अलग अलग ट्रस्ट, पहला रहता है कि हॉस्पिटल जो फंड रहता है उसको हम देते हैं। जो भी पेशेंट हमारे पास आता है, मतलब हॉस्पिटल में कम से कम 40,000 तो 45,000 न्यू रजिस्ट्रेशन हर साल होता है हमारे। तो जो पेशेंट हमारे यहाँ पर आ जाता है तो उस आज का उसका ट्रीटमेंट क्या है वो देखा जाता है। आज का उसका ट्रीटमेंट ना रुक जाए इसलिए पहले हम प्रेफरेंस देते हैं कि हॉस्पिटल में जो फंड है उसको दिया जाता है। अगर उसके साथ ट्रीटमेंट में थोड़ा टाइम है तो हम क्या करते हैं, अलग अलग ट्रस्ट है वो ट्रस्ट के लेटर बना के उनको ट्रस्ट के पास भेजा जाता है। तीसरा रहता है थोड़ा, अगर सही से किसी का सर्जरी 1-1.5 महीने का गैप है तो सीएम पीएम फंड रहता है, तो उसके लिए अप्लाई किया जाता है। तो अलग अलग ये उसके ट्रीटमेंट के हिसाब से हम अलग अलग क्राइटेरिया के हिसाब से अलग अलग ट्रस्ट, हॉस्पिटल फंड और गवर्नमेंट स्कीम का अप्लाई करते हैं।
Thank you so much. And that brings me very nicely to our next panelist, Ms. Vandana. Vandana, you have had extensive experience advocating for access to cancer therapies. And as Jaikumar just said, that some of these schemes do not cover the full treatment, and therefore either surgery is covered or chemotherapy is covered or some partial coverage is there. So in your opinion, what can we do to ensure that full coverage is there, and how can advocacy groups play a part in it? Is Vandana ji there?
No, I think she had to join in another program, and she had to rush kind of. She waited a lot, but then we got delayed a bit.
Okay, no problem.
Yeah.
So I will ask Dr. Arun. We just heard Jaikumar ji saying that some patients receive a part of the treatment, and for others they try to get supportive therapy from other means like trusts or some charities. So as a treating oncologist or as a physician, what are the challenges that you face when patients come who are eligible for government schemes and who then are put on those schemes but do not get the complete treatment?
Yeah, so thank you, Vivek, for the invite. So in the setup where I work in a corporate government a corporate setup in Kerala. So we do not have the Ayushman, or obviously due to political issues of Kerala in the center, but we do have our local insurances like Medicep, which is for the government officers. We have ESI and ECHS. So as rightly put, for ESI and ECHS, everything is covered, all modalities. But for things like Medicep, for example, we have chemotherapy and radiation covered. We do not have oncosurgery covered. So that puts us in quite a fix, because when you have a patient, for example, rectal cancer, which requires 3 modalities of treatment, and the patient is not very financially sound, it makes it difficult for us to counsel that, okay, you got to take chemo, you got to take radiation, but for surgery, you might have to pay. So in that situation, there are 2 options for our patients. One, our institute, our management has a special package rate for those kind of patients. And there's something known as the Astor Foundation, which kind of finances maybe around 30-40% of their costs. So we try to enroll the patients in them, in those schemes, but there's still some out-of-pocket coverage that the patient has to put in. So if the patient cannot afford that as well, we have to look for another center which does the surgery under the scheme. So we kind of refer this patient to another institute. For example, we have a medical college, a private medical college. They do not have facilities for chemo and radiation, but they do have surgery covered under this scheme. So our oncosurgeon travels to that medical college and does the surgery under the scheme. So we kind of do a big workaround. It's not ideal, but at least the patients do get the care that they want. It won't be as cutting edge because we've got frozen section, all the latest techniques of surgery. But for that patient, there will be a little bit of compromise. And with this, almost, I would say 80% of our patients, we are able to, offer the best possible care.
Thank you, Dr. Arun. And you bring a very important perspective into the discussion about multiple modalities of treatment for a single patient. So a patient might not be just requiring chemotherapy or surgery or radiation. And also if there are, reoccurrences of the same cancer in a more advanced stage, then maybe other treatments are required. However, most packages are not customized to be able to manage these kind of requirements. So the question is, who decides these packages, and how, how is it that the judgment is arrived at this is the best package that will deliver the best results to the patient? And in most countries, there is a process called a health technology assessment that is conducted, and it is a scientific process through which medicines or technologies are included into the payment mechanism or the packages that are there at the national level. So I'd like to bring in Dr. Ramana. I can't see him. Yeah, sorry. So, and he is a patient who has been on treatment for a very, very long time, and he has received targeted therapies. And we know that in Ayushman Bharat, there is a mechanism by which a request for inclusion of new therapies can be made. And Dr. Ramana has had an experience of applying through this portal. So we would like to hear from him as to what kind of challenges he's faced, what are the processes involved, and whether there is a scope for patients and patient groups to use this portal to demand for new therapies to be included into the national packages. Dr. Ramana, over to you.
Yeah, thank you, madam. Can you listen to me?
Yes, sir. We can hear you loud and clear.
It's pretty late for everybody. Well, yes. It's like this. Actually, I didn't know much about advocacy. All I knew is that I want to first get cured, and the moment I had a pleasant time and my quality of life improved, I thought, why not the others should get this one? So, of course, the lung cancer group has inspired me a lot. I made an application. First of all, the application form itself is extremely complicated. The moment you look at it, you feel like, okay, thank you. Let us not go ahead with that. Actually, it could have made very, very simple. The technical details they want, the various other things they want, they expect the people who fill it up, he already has a good knowledge of anatomy of gray. Whereas I am simply an engineer. So even then, I attempted, made it pretty simple for me. I only said there are certain new drugs that have come up. I gave an example of 4 to 5 drugs which are being used by a number of doctors, but they are not a part of HBA. I checked about 67 pages of HBA to find out which are the drugs which are allowed. So these are not part of the drugs which are told. And in fact, very senior doctors helped me in identifying those things. The only problem is they say that we can't approach it. It's better that you approach it. I said, okay, all right. Then I kept those 4 or 5 drugs. He said, these are very useful. I am giving it as an example, and you may kindly include these things as a part of it. Then, my God, it has taken such a long time with them, and it went on from one person to the other, one person to the other. I started in 21 December. It went on up to 22 March. And in 22 March, somehow they suddenly took good decisions. And they said, yes, we are going to process your application. Well, first they said that we require some additional information. So whatever I could, I have given them. But the main problem that I feel is coming is this particular targeted drug is something which is not actually executed within the premises of the hospital. This is something which is actually given only in the hospital, in the patient's house. So they say that fundamentally they are supporting only the treatments which are given by the hospital, because we don't know what is happening, whether the patient is really using or he is selling it. So I do agree. But then I said, well, at least, such an amount of approaches you can make so that it can be given. As a matter of fact, that was more or less the end of the matter, end of the road. Then I gave another application telling that, well, I did not get proper answer for it. So kindly just look at it. They said, okay, we are again looking into it. They said, we have referred the matter to NHA. Because now, as you said, there is a specific technical assessment committee. They will look into the particulars that you are given. And they said that every year we are including a few of them. Some of them, what I said, they said we have already started the method of including those. Because I mainly saw breast cancer is one of the most important ones, then lung cancer. So identified the normal drugs which are already being given by the doctors. But the doctors naturally said they are very costly. As it is not a part of HBA, the patients are not getting the benefit of it, nor the insurance companies are giving the money. So that's where it stands. So I said, okay, I have made my effort. And at this stage, well, I require a bigger support. Then I came to know about the advocacy groups, which I never heard of it. So now Vivek and Sanjeev, they are the people who are taking up these causes. I'll be extremely happy. I'm 84. Well, I do hope that during I am alive, I will see some progress in this particular matter. Started in 21, now it is 24. So, well, you see, it requires a lot of perseverance to continue and do it. It has taken for me number of days of work to fill up each. You kindly look at that particular one, the application form is threatening, actually. So I wish it could be made a little bit more simple so that the net finally what the patient wants, whether that is acceptable or not. That's what is mainly.
Thank you, sir. And just to clarify, the application form was not meant for patients; it was meant for industry. And you had the courage to be able to tackle that and fill it and still submit. So maybe one of the outcomes could be to request for a similar, application, which is a simpler language that patient advocacy groups can fill and make requests. And I would also like to maybe, ask Dr. Arun, given the experience that Dr. Ramana had, and the support that he received from doctors to be able to fill that form, do you see a benefit in doctors and doctors association working with advocacy groups to make similar requests? Because right now the portal encourages just the industry to make a request.
Right.
But going forward, since doctors face the challenge, as you have rightly explained, where 2 procedures were covered, but the third one was not, and the interface of the patient is maximum with the doctor, and the disappointment and the frustration is what reflects on the doctor. The insurance agencies and the other people do not face that. So do you see an advantage in pushing for an application portal where doctors and patients, or doctors alone and patients alone, could make new applications, and the advantage of physicians like yourself and physician associations working very closely with advocacy groups like ours and with Sanjayji's advocacy group to be able to make new applications for new and advanced therapies to be included into Ayushman Bharat and other government schemes?
So absolutely, definitely that's an important aspect. For example, my experience, as I said previously, we have this Medicep insurance which is there in Kerala for the state government employees. So when it launched around 2 years or 1.5 years back, it was very, let's say, bare bones. There were many treatments which were not covered. So we had patients of myeloma where simple bortezomib itself was not covered within. There was no coding which was there. We couldn't fill the code and then submit it. So what we did is we raised this issue with our state organization, and with a state organization, with the backup of the IMA, they've put forward this is the request, or this is the kind of list of drugs which needs to be given. And I believe that the list from Ayushman Yojana was also kept as a comparison to know the rates and everything. And with that, within a few months, actually, which was quite surprising thing, considering things in Kerala are quite slow, things moved forward, and we were able to make a difference, get that new molecules into the system. Now, personally, in Kerala, we don't have the portal system for the patients or the doctors. It's actually done by the administrative staff who are in the background. But I feel that in such a situation where you have new treatments coming, or for example, you have newer generics which come out, which are much cheaper, but we don't see that you cannot, it's not there covered in the scheme. This is where we need to, join hands together. We need the patient advocacy groups, along with the doctors, along with everyone, our administrators, social workers, put things forward to the government. And I think if you attack from all positions, things should move faster and move better. And as you said, it's in the end of the day, it's us who are sitting in front of the patient. So when it's their pain, it's their loss that we actually feel. The person on the other side of the computer probably doesn't know the implication. It's not that the other person is bad, but he does not see this person. So as an advocacy group, I think if we are able to, bring the gravity, or, tell that, they're able to understand this is the situation, this is the person, and, this patient requires care, I think, there should be no hurdle. Means any human would feel it in their right minds to, push things forward.
Thank you, Dr. Arun. And my last question is to
May I
Mr.
just add a little, Madam Ramana Rao
Yes,
here?
yes, please.
No, it's like that. When I tried to put any of my views, any of the panels, they were not accepting me. So I put doctor there. I'm a doctor actually in engineering. So I become automatically a member of groups like ASCO and other things, where I was able to learn and contribute also. The other thing, this terminology is pretty complicated. I thought I lost my kidney. Then after 10 years, I came to know it's not kidney, but it's RCC. that I came to know when they mentioned RCC, I thought it is my building. I constructed with reinforced cement concrete. So then finally, when I looked really into it and asked the doctor, he said, no, RCC is a renal cell carcinoma. I mean, just telling you how ignorant a patient can be. So he has to be supported, and he should not be threatened when he approaches an organization. Thanks a lot. Thank you.
Rightly said, sir. And medicine is ever evolving. So ignorance is not something that, one should be afraid of. We should keep on asking questions so that you can learn what you don't know.
Yeah.
My last question is to Mr. Jay Kumar. And Jay Kumar ji, आपने बड़े successfully 2 programs TMH में आप चलाते हो और patients को support देते हो. But हमारे पास में 29 other states हैं या 28 other states हैं, तो हर स्टेट में अगर इस तरह से पेशेंट ग्रुप्स हैं, तो उनके लिए आपकी क्या मैसेज होगी फॉर अपटेक ऑफ गवर्नमेंट स्कीम्स बाय द पेशेंट्स? क्या करना होगा उन्हें ताकि ज्यादा से ज्यादा पेशेंट्स को इसका लाभ मिल सके? सर, आपको अनम्यूट करना होगा.
आ रही आवाज?
Yes, now we can hear you.
तो पहले तो हमने जैसे बताया कि हम पहले दिन से उनको स्क्रीन करने में जुड़े जाते हैं कि ताकि वो आगे का जो ट्रीटमेंट है उससे बेनिफिट ले सके. तो ये पहले करना चाहिए कि सभी स्टेट को कि पहले दिन से उनको डॉक्यूमेंट क्या क्या चाहिए वो स्क्रीन करना चाहिए. जैसे कि बहुत सारे राशन कार्ड, आधार कार्ड, ये रहते हैं मेन डॉक्यूमेंट। तो वो पहले बहुत सारे पेशेंट लेके नहीं आते, तो उसी दिन वो अगर स्क्रीन करेंगे तो आगे का उनका एनरोलमेंट जल्दी हो सके। और आगे का अगर कुछ डॉक्यूमेंट क्वेरी रहेगा, जैसे किसी का राशन कार्ड नंबर दिखता नहीं है, किसी का आधार कार्ड में प्रॉब्लम रहता है, एड्रेस का दोनों जगह अलग अलग रहते हैं, तो वो सब ठीक करके एनरोल, जब तक ट्रीटमेंट प्लान होता है तब तक वो सब सही करके उसका बेनिफिट ले सके। तो ये मेन जरूरी है। दूसरा है कि अगर बहुत सारे पेशेंट जैसे कि दूसरे स्टेट में ट्रीटमेंट लेते थे, अपना स्टेट का जो स्कीम लेता है वो बेनिफिट नहीं ले पाता है। तो हमारे टाटा के भी अभी अलग अलग ब्रांचेस ओपन हो गए हैं, तो हम ज्यादा से ज्यादा बोलते हैं कि वहां पर आप ट्रीटमेंट करोगे तो वो भी आपको बेनिफिट, ज्यादा एक्स्ट्रा बेनिफिट मिलता है। तो हम दूसरा एक चीज बताते हैं कि वहां पर लोकल जो स्कीम है वो बेनिफिट ले लो। तीसरा रहता है कि अलग अलग ट्रस्ट कनेक्ट करना जरूरी रहता है। अगर यह इस स्कीम से अगर बेनिफिट नहीं मिल रहा है तो दूसरा उसका ट्रस्ट से अगर कनेक्ट करोगे तो वो ट्रस्ट के पास से उसको थोड़ा बहुत उसका पॉकेट कम होकर उसका बेनिफिट उसको अलग सा मिल सकेगा। और चौथा रहता है कि जो हॉस्पिटल का जो फंड रहता है वो CSR वगैरह रहता है, वो रहता है। ये चार स्रोत है जो पेशेंट ट्रीटमेंट सही तरह से पेशेंट बीच में ना छोड़ के उसका ट्रीटमेंट कंप्लीट हो जाने की।
Thank you, Jai Kumar ji. And just to wrap up what we have been discussing, there are already a lot of government schemes, but how do we increase the optimum utilization of this? So 2 or 3 takeaway points. One is there needs to be more networking and learnings from people like Mr. Jai Kumar, Mr. Sanjay, because they already have a lot of experience. There are new patient groups and even some older patient groups, they are still struggling. So how do we bring all of these together into a network so that some of these challenges are not being learned from the bottom of the pyramid? So there is a lot of learnings already there. How can these people learn from them? There needs to be some synchronization between physicians and advocacy groups, so that advocacy groups who are trying to reach out to the government counterparts for inclusion of new schemes or for better utilization of the existing schemes can work with the knowledge that physicians give them to be able to make applications or to follow up on applications. And the third takeaway is that there is an existing portal which encourages industry to make new applications. A request could probably be made as an outcome of this discussion today, that maybe there should be an opportunity for patients to apply in a much simpler format, as well as for physicians to apply in a more technical format. I think these 3 takeaways could be a good way of taking the discussion that we had today forward. Thank you, Vivek ji, and over to you.
थैंक यू सो मच रत्ना जी। देर आर लॉट ऑफ थिंग्स, जब हम बात कर रहे हैं तो बहुत सारी चीजें जहन में आ रही हैं, लेकिन फिर लग रहा है कि थोड़ा थोड़ा करके हमको बात करते रहना चाहिए एंड कंटिन्यूअसली करते रहना चाहिए, rather than talking on one day. But it has been a very good kick start, and for the rest of the year, let us hope and let's unite and do a lot of significant work and dramatically change the lives of cancer patients and caregivers in India. And moving forward, before Umesh says vote of thanks, I need to thank him for his patience. And let me have Mr. Umesh Nath Sharma, who is co-founder UHAPO Health Services Private Limited, which is a social enterprise. And Umesh comes from a deep industry background. He has been leading multinational companies and is being associated or rather co-founded UHAPO right from the beginning, and is an advertising guy now. Welcome, Umesh.
Thank you, Vivek. Thank you very much. I think, this was an amazing discussion. It's our second year. Last year we started with access, and this year we went on advocacy. In fact, what I would like to say is that UHAPO Cancer Conclave, our objective is to bring the best minds in the country, focusing on a specific topic. Like I said, this year it was advocacy, and discussing it threadbare. Finally bringing out a white paper like we did last year for access. The same way we are going to bring in white paper for advocacy, and this will be shared with all important government and non-government organizations. That is our core objective of having this important discussion. As we heard today, today's event, the cancer advocacy, it is critical part of cancer treatment. Both go hand in hand. and especially in our country where patients and caregivers face multiple and unique challenges in terms of cancer treatment. I mean, that's one of the biggest thing. I have a long list of people whom I need to thank. So I'll immediately, rather than discussing other things, I will directly go to thanking all these people. I would like to specially thank our amazing panel, faculty today, I mean, of the Cancer Conclave, with their various wonderful inputs that they have given. And this will help us build up the whole discussion and build up our white paper. We would specially like to thank Dr. Kumar Purabash sir and Dr. Vijay Patil because they had, I mean, given us end-to-end support, I mean, very frankly, and they were very gracious enough, even in their very busy schedule. They gave us time and gave us guidance for this ensuring that this program goes successfully. All the topics are relevant in advocacy. We would like to thank our scientific partners, CRSF. Also, we would like to thank UTSA Foundation, our sponsors for today's event, Pfizer, NATCO, and Cipla, with whose help, I mean, we could execute this program successfully and reach out to you. We would like to thank our audience. I mean, they have been, it started 2 p.m. sharp. I mean, it's now well past 7. I mean, so thank you very much for sticking with us. I mean, the fact that there are so many people listening to us means, I mean, this topic is very, very relevant and we did justice with this topic and their very good time. Hope they would have definitely gained something out of this today's discussion. Finally, I would like to thank the Sutradhar of today's event, Vivek. I mean, I know he has been last many months dedicated completely to ensure success of this Cancer Conclave. And also would like to thank our UHAPO team. One name I would definitely call out here. I mean, the whole team was they worked very closely, but I would specifically like to thank Kailash here and his IT team because they have been working very closely with us and especially Vivek to make sure that this program reaches out to as much as people as possible. And our broadcast partners today, we see now, especially Shrikant, with whom we have been working earlier, and his team. So, lot of thank you. We look forward to connecting with you again, same day, same date, that is 4th of Feb, with another relevant topic. Until then, wish you the best of 2024. Thank you very much.